All right, folks, we're live.
Good morning, everyone. Thank you for joining us and welcome to the Eastern Sierra Substance Use Conference. My name is Jacinda and I'll be your host today, and along with Arlene Brown, who will assist me in the afternoon. Before we get started, I just have some, for those of you who are tuning in different ways, whether it be through Zoom or on your phone or through Facebook live event. If you have any questions for Zoom participants, please enter them in the Q&A. Or if you would like to speak, please raise your hand and we can unmute you. For those on an analog phone, use *9 to raise or lower your hand, or *6 to mute or unmute yourself. For those participating through Facebook Live, please post questions on our event page and we will be monitoring that and adding them into the Zoom Q&As to bring up. This morning we have 5 speakers and then we'll break for lunch around noon or 12:30. Then return in the afternoon for our community panel, 2 more speakers, and lastly close with an open discussion time. And before we get started with our speakers, I have Chelsea here who is going to open up the conference with an opening ceremony and an honor song. Morning, Chelsea.
Good morning. Can you hear me?
Yes, we can hear you.
Okay. I don't know if you can see me or not. Yeah, okay.
We can see you.
Okay, well, hi, I'm Chelsea. I'm 16 years old and I'm a junior in high school currently. And I'm going to be singing you a song.
Oh, thanks, Chelsea.
Dawa kamena hayata wili mado naniti. 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 Thank you.
Thank you, Chelsea. Chelsea, where'd you learn that song?
I'm a hand drummer, and a hand clapper singer, so I learned it from like my cousins in our tribe.
Cool. You live in Bishop or?
Yes, I live in Bishop.
Cool. Thanks, Chelsea. What's your last name, Chelsea?
Chelsea Gallardo.
Gallardo. Awesome. Thanks a lot.
You're welcome.
Yeah, thank you, Chelsea. And in the afternoon,
you're welcome.
We'll have you close us out in the afternoon. Thank you.
Okay, thank you.
All right, so before we get started with our speakers, just wanted to mention that this conference was created as part of the Eastern Sierra Substance Use Project, a collaborative of people from Inyo and Mono County. If you're not familiar with this collaborative, please check out our website, which is monohealth.com, public health page, Eastern Sierra Substance Use Project. During our breaks, I'll have some screenshots of our webpage and some other resources. And we also have a Facebook page, so please like our Facebook page, which is the Eastern Sierra Substance Use Project Facebook page. All right, so let's get started. Our opening speaker is Robin Roberts. She kindly accepted my request to provide an opening remarks at the very last minute. And Robin is the director for Mono County Behavioral Health. Robin, I'll turn it over to you.
Thank you. I'm happy to be here. And I just want to give a couple disclaimers. Number one, my dogs will bark probably around 8:20, 8:25 when my puppy gets picked up to go on an adventure with other dogs. So just sorry for that in advance. And also it's very, very weird for me to be sitting down talking to a flat screen in my living room. And I know that's true for all of us. So I'm going to do my best here to talk about us and to talk about harm reduction and to talk about love. So just a little background about me, just for the sense of context. I moved to Santa Cruz, California in 1982. I started graduate school to become a marriage and family therapist in 1984. And in 1985, heard about the gay cancer, in quotes, on the news, and reached out to one of my professors, a man named Jerry Solomon, who was a gay man. And when I asked him, like, what is this? And is there anything that I can do to help? He just started to weep. And that was the beginning of my experience working with people who were on in the margins with a pandemic going on and a gigantic health issue that people were dying from. And so what I learned from that will move me into why I have this position now here in Mono County a bunch of years later, is that I grew up as a blonde-haired, blue-eyed white girl in a predominantly white area. And so I trusted the government. I felt, I went to the DMV or unemployment office or to the doctor or whatever and was treated with respect. I was treated. I had insurance through my parents. I got what I needed. And so I went into the work with what at that time was called HTLV-3 because HIV hadn't yet been discovered, and was all about having the county government help us, the AIDS Project, which is what we ended up being called, with outreach, engagement, and prevention, essentially. And learned very quickly that my perception of county government public health was very, very different than the men who were trying to rapidly come up with some alternatives for what was going on to help keep people safe and alive. And it was a very intense and very, what's the word? I guess sad, just angry and sad time because so many people died so quickly. And I learned two things from that I use in my work now. One is nothing for us without us. I think that government workers we all have big hearts. We work really hard. We really care about what we do. And we're not that great at bringing the people that we're serving to the table so that we find out what it is they need and what it is they need in their language. And an example would be that back in the 1980, probably 5 by this time, the Santa Cruz County Public Health Department and Mental Health Department, again, all wonderful people, were very slow to come up with ideas about how to get to a prevention strategy, and then wouldn't entertain the prevention strategies that were given to them by the community they were trying to serve. And so basically they went in this direction, and the men that I was working with went to the public sex spots and started to pass out condoms that they had to use their own money to get. And it's a long story, but what it taught me again is that government can think it's doing a really good job and also be a barrier to the people that it's trying to serve. And so a little bit I want to talk about that today. Because most of us that are on here are somehow related to a government agency. And so I want us to be able to figure out, how do we talk about us instead of talking about them? And I don't mean them necessarily in a negative way outside of us, but the client, the probationer, what else do we call people? Consumer, patient. We have lots of ways that we talk about those people, but we don't have a lot of ways that we talk about how we're doing and are we doing the job that we need. The other thing that then happened through when AIDS became the pandemic that it was, is that people who use drugs, especially people who injected drugs, became part of the circle in Santa Cruz of people that were sick and dying. And then through that, the Santa Cruz Needle Exchange popped up. And I was asked to help with some things related to that, and learned from them that the work is not about abstinence. But at that time in graduate school, somebody in my position, it was deemed unethical for a service provider to see somebody who wasn't clean and sober because they weren't ready to do the work. And although that made no sense to me, that was part of our law and ethics exam. And at the same time, working with the Needle Exchange, realizing that people needed connection and they needed help. And again, being a white girl, that time with brown hair and blue eyes, a little bit of gray at that point, I started to realize like, oh, the government doesn't actually notice these people. And there's a lot of stigma and there's a lot of blame on people who aren't purists. So with all due respect, one of the things that we do, health providers and otherwise, is we offer the purest example in order for us to be able to make the changes that we might need to make in our lives. So your blood sugar is a little high. Here's the purest example. You need to only eat vegetables, don't cut down on your sugar, and get this much exercise every day. Sorry about that. Hey, hey, hey. Go, go. That's the purest example. And if I can't meet that example, then I'm a failure. And then the chances of me coming back to you as a provider are about 0. Or I'll come back to you and I'll tell you I'm doing these pure example things so that you feel like you're being taken care of and I can get the healthcare that I need. But at the same time, I'm actually not able to do those things for a whole variety of reasons. Let's say I have kids at home, or I don't have enough money to buy the foods that you're telling me I should eat. Or the idea of getting exercise after I've worked in cleaning hotel rooms all day is insane to me. I can't even imagine doing that. And so what we end up with is shame. And I think that us as providers are responsible for looking at how we create shame in the rooms that we work in. And I say rooms with quotes now and in general, that is part of our work. So if you're a provider or you're a county group of people coming up with prevention ideas, I hope that what we will do after this conference is start to say, who's at the table? Who are we serving and are they at our table? And how are we potentially creating shame as a barrier for people not to approach us? So when we do we're open from this day to this day and nobody comes, we decide that that's about them and not about us. So how can we start a dialogue about us around that? So I worked with the AIDS Project and the Harm Reduction Needle Exchange Project until I moved to Mono County in 2008. And by weird experience, became the director of behavioral health because I am not by choice or by genetics an administrator. So when I became the director, though, I felt like I wanted to bring one of my main goals on my list was to have a syringe exchange program through the county in Mono County. And I knew that in 2012, I couldn't just start with that conversation. So I started with bringing harm reduction as a concept to my department and to my board of supervisors, because what is at the center of that concept is that we care about the people that we serve. We serve anybody who comes through our door, no matter what their needs are, and we want them to come back. Those are my kind of beginning, steps, I guess. So if we want you to come back, that means that we don't offer you abstinence if you come in talking about drug use. If we want you to come back, that means we don't start to give you the purest idea of how you can get the help that you're asking for when you come in talking about drug use or trauma or anything really. If we want you to come back, the way we do that is we say, hi, my name is Robin, what's your name? How can we be of help for you today? And you say, I need I'm hungry and I'm hungry and I don't have the housing that I need. And and then I say, well, when was the last time you had a glass of water? And you say, I don't know. So I get you a glass of water and I find you some food and I say, housing's really hard here, but how about you just keep coming back and we'll stay connected. And they do. That's the cool thing about it, is that really what we're talking about is at the heart of harm reduction is that we make and keep and maintain and nurture connection no matter what. So what I learned in the beginning of what I learned through school and what I learned just by being a part of this culture is that drug users are bad people. They choose it. We call them addicts, we call them dope fiends, we have all kinds of names that we call them. We scratch our heads and wonder why they keep doing it. We put them in jail. We forget that they're people. And if you find a way to the person and make a connection, then what you're offering is for them to feel connected to somebody at a time in their lives when they probably feel disconnected from almost everybody. And through that connection, we create healing, because that's what humans do. That's why many of us are in these fields, is because if I make a good connection with you, then you're going to come back and we're maybe going to work on some of the things that you need, that you want to work on, and maybe work on some of the things that you probably need to work on if you want to feel better, do better, get out of jail, get your children back, all those things. But if we don't create an experience of connection, then what we do is we create an experience of shame. So lots of people will be a part of our systems because they have to be. And they will do what they're told to do because they don't want to go back to jail or they want to get their kids back. But through the process, they still feel the shame that they started with. And maybe they get clean and sober and stay sober and abstinent for the rest of their lives. Let's say that happens. But they still leave not feeling like they're good enough, or they're a good person, or that they're lovable, or that they have that it's okay for them to want to belong to us and to anybody else around them. And we do that, we've created this all through our systems, through public health, mental health, or medical system, that we have a very strong belief that if you're using drugs and or alcohol in a way that's harmful to you, or in a way that's created dependence for you, that is because you're making choices. And as long as you have that belief inside of you and you're not working to get it out of there and to keep moving forward with a different way of looking at it, dogs are going to bark, then you are creating a barrier of shame, whether you want to or not, whether you understand how you are or not, or whether you mean to or not. Because if I hold out that the way for you to get what you need from me is a purist idea, you have to be abstinent. You have to be abstinent to get your kids back. You have to be abstinent to stay out of jail. I'm not going to listen to any stories about how you want to use weed in order to get off of heroin. Oh, wow. Sorry, my life. I don't know, I'm working. Okay, Tallulah, Doozy, and Lyle. Okay, Lyle's gone. All right, so that's what I can tell you as a provider, and that's what I can tell you as a patient. I've told this story before, some of you I'm sure have heard it, where I went to a doctor, my blood sugar was a little bit high, and she said, come back after you've lost 20 pounds. I haven't been back to that provider. I'll never go back to that provider, because what I've learned in that exchange already is she has a belief about me. She has a belief about what I need to do, the care that I need to do to take care of myself. And as I can talk to her, it's a closed system, right? That the loop will go something like, you need to lose weight. Like, okay, I need to lose weight. Well, here's the reasons I'm not losing weight, is I'm not able to get enough sleep. And I'm not able to get enough sleep because my hormones are out of whack. This is at a certain time of year in my life, or a certain decade in my life. And, you know, blah, blah. There's a whole series of things, but I never got to talk about any of those things because the provider was clear that the way that you do this is you stop eating tortillas, you stop eating beans, you get your exercise, you, right? Manage your stress differently. That message is a shaming message. So I do not have a drug dependence at this time in my life, but I need connection and I need belonging. And every day that I do my work and work with people, it's about bringing love to the table. And I don't know about you all, maybe you all grew up at a different time and place, and maybe you have a different philosophical point of view, but I was taught that if you talk about love in your work, then you're unethical. And I want to say that I really try to find a way to love everybody that I work with and to love my work at all times. And that harm reduction as a process and as a philosophy and as a way of life and as a way of expressing my heart is something I can do with everybody and anybody, no matter their circumstance. So if your children have been removed from you because you are not able to care for them, and part of that reason is because your drug use has gotten to the point where you can't control it anymore, then if I'm going to engage with you, I'm going to engage with you through my heart. If I come at you starting to talk about abstinence and how you need to do all the things on my list because I have a job and I want to get those things checked off of that list, then I'm going to create shame and you're not going to want to talk to me. You're not going to want to talk to me anyway if I have your children, or I'm not going to want to talk to me anyway if you're in jail. But that doesn't mean I can't be the person that you feel cared about and that you think, okay, this person actually seems to care about me. They want to know a little bit about how I'm actually doing. They want to know a little bit about who I actually am. They seem to be really thoughtful about what the stories that I told them. I have a sense of belonging that I'm starting to have. They're reliable. They show up when they say they're going to show up every single time, not just once. They seem to want to talk to me about more than what's ever on their clipboard. That's how we create relationship in this work. And that's what this is, in my opinion, all about, is that we can create relationship with anybody who comes through our door. That's our job. That's our ethical responsibility. And we can do our job in a way that promotes the care that harm reduction brings to us. And we do that by creating connection so that healing can happen. One of the things that I struggle with in the job that I have now, because I do work for the government now, and I do understand that there's regulations and mandates, and I do believe strongly that there's many ways you can meet that mandate and still use at the core of it the love and care and connection that comes with harm reduction as a philosophy and a way of life. But one of the things that I hear about a lot is, you know, we're all kind of put in a position where we're taught to be trauma informed. And I think what we've taken from that, as far as I can tell, is that we understand that trauma impacts people's lives. And I don't, again, you're just a bunch of names here to me, and it looks like there's 39 participants, and I'm talking in a room by myself with now 2 dogs, not 3, because one just went on his adventure for the day. And so I have no read on kind of who you are or anything about you, but I will say, I'm going to take a guess that if you take your ACE score, which I'm assuming you all know what that is, there might be some of you here who have a 0 or a 1 or a 2. That is highly likely. And so that maybe you've done some work around that yourself. But for those of us that have a 3, 4, 5, 6, or a 10, anywhere in between, for those of us who have a higher than a 4, I commend you, because the trauma work you do for that is so terrifying. And it takes so much courage. And it feels so endless when you're in the middle of it. And it feels impossible. And to find a provider that can hang out with you and do that with you, and is willing to do that with you, and hold that space when you start to get reckless or feel suicidal or feel like you can't do it, that is an incredible, incredible thing to do. And it is the hardest thing to do, to walk through that level of shame, to relive the trauma. When we take people into our systems through a mandated way and we say, you know, behavioral health, could you help them work on your trauma? You're asking that person to relive something, maybe the worst thing that ever happened to them. You're asking people to do that at a time when they're already incredibly stressed out and they're not choosing it. It might be the best thing in the world for them, but they're not coming to you and saying, hey, I need help with my trauma. I'm starting to have dreams again about being raped. I'm starting to have dreams again about the time I didn't know where my parents were for 5 days and I was walking around in a dirty diaper. No, very few people are going to come through a mandated door and ask you for that. And yet we've created these systems where we want people to work on their trauma so that they won't be so inclined to use the drugs they're using so that they can be better parents, so that they can get their kids back. And all of that makes sense. I'm not here to argue with that as making sense. I am here to say, however, that if you start to I was going to say decompose, that's not the right word. Decompress, that's not right. Deconstruct that model, that way that we have created, and you add harm reduction into there, and you add engagement into there, and you realize that every one of our workers has to be stellar at engagement and really care about the heart of the work. Every one of our providers has to understand that they could be creating the barrier that is making the client not engage with them because they're talking in a way that's shameful, or they don't mean to, but they might be. Every one of us has a responsibility around that. All of us who are supervisors have a responsibility to work with our staff so that we're using language that's inviting and not shaming. So how long have you been an addict? Okay, how long, what drugs are you using and for how long? And do you have a sense of why and where are you with it? How are you feeling about it? How much stress does it cause you? If you could have an alternative and not do it, what would that look like to you? What do you feel like I could offer you in our relationship while we're talking about drugs and alcohol? I know you don't want to talk about it, but what else, who else are you? Do you read? Do you watch stuff? Can you tell me about what you did today? All of those questions are about a person. And I'm going to guess, I know that some people that I can see on this list have been through these systems before. But if you've never been through these systems as a client, as a patient, as a probationer, as a consumer, all the other words that we use, like you haven't entered the mandate door, you haven't had your kids removed, you haven't been put in jail, or you haven't had to do some kind of mandated service. If you've never been in that situation, then I really recommend that you talk to the people you're working with about what it's like. It's probably very similar to me going somewhere and having somebody give me the purest example of what my health should look like. And, you know, around here, most of our providers are, forgive me, skinny white folks who are very fit. So when they tell somebody who's not looking like that, that they need to lose weight or get more exercise or whatever, it can be intimidating. If you ask a person like, what's your stress level like? How does that influence your day? Who are you when you're stressed out? Who are you when you're not? What's the time of your life when you were least stressed? How come? Things like that we don't reduce people down to the thing that's wrong with them and the choices that they make. Now, what we know now, and have known some of us for a very long time, is that there's something called addiction science, and it tells us that people who have dependence on alcohol and drugs there is the potential for them to be able to have treatment through a medical provider that will help them manage their dependence in a way that allows them to get a little bit more function and get a little bit more of the life that they want back. That takes time. It takes people to trust you. It takes you to use language in such a way that every time that they're around you, they feel welcomed and that they want to come back. If that is just your thing, is how do I get you to come back? Not because you have to, because you want to. If I take that on as the rest of my career, you'll find all the ways in which you can recognize, like, oh, I'm getting in the way of this person. My agency is getting in the way of this person. My agency, when I first came to Monroe County, wouldn't see people who were actively using or who were high at the time. And I don't think that's correct. I think that doesn't mean you'd sit them down and want to talk about trauma. No, definitely not that. But that doesn't mean you wouldn't go say hi to them and say, hey, let's see if we could maybe talk a few hours from now, or I'd love to see you tomorrow. mean, imagine if you were someone who couldn't make it on time, and rather than be seen as somebody who's resistant, someone asked you, can you talk to me about why you don't get here at 11? And they tell you any matter of things, like, I don't have a phone. I don't know what time it is ever. If I have to get here at 11, it means I have to drop my kid off earlier and then they charge me more. I mean, there's a reason for things. It is very unlikely that somebody is just only trying to be defiant for the sake of defiance. They're trying to be defiant because they want to protect themselves. And I believe it's our job to figure out why that's happening and how could I be contributing to that. Oh, that's a lot of words, y'all, for being in a living room. And I can't read the chat and talk at the same time. I don't have that capacity. I think it's my age. I'm happy to have people jump in if you have questions or thoughts or ideas. I don't know if that fits the format. I don't think you probably want to start earlier, but I would love to have someone join in here, maybe, and just say, like, how do you deal with this? How is this for you? Did I make you mad? Did I make you feel like you're not doing your job correctly? And can I help correct that? Can we talk about what it's like to love a client? I could talk to my dogs with y'all, but it's not that fun. It's kind of boring. We talk about bully sticks and food.
I do see a hand raised amongst the attendees.
Thanks.
It's Dirk. I'm gonna allow you to talk, Dirk. And
Oh, Dirk.
you.
Hey, good.
Hey, Dirk.
How you doing, Robin?
I'm good, thanks. How about you?
I am doing well, thank you. Hope everybody survived the Thanksgiving weekend. I was wondering, in your experience, Robin, how long it took you as a therapist to be able to accept your patients as they are without any coloration from your own previous past experiences, and how you work on that to this day.
You know, Dirk, you always ask the best questions. That's a really good one. I'm going to say I've been practicing psychotherapist for, I think, about 36 years now. And I'm going to say 36 years it's taken me. You know, in the beginning, I mean, I was an intern literally when the AIDS crisis was really amplified. And at that time in my world, it was mostly gay white men, mostly younger than I was, who were dying very, very quickly. And I was in a situation where, again, being in graduate school with law and ethics, is that you only see the client in your office. You never talk to anyone outside of the office about the client. Like, there's a kind of a tradition in Western white psychotherapy where you only have the information about the client that the client brings into the room, and they never have information about you other than whatever happens in the room with them. And I lived in I'm a lesbian. I worked in the gay and lesbian world. My world had a lot of overlap with that was unethical as deemed by my professional organization at that time. And again, I ended up seeing a lot of people in the hospital because at that time, the time between infection and somebody dying was 6 weeks for a white gay man. It was much quicker. It was 4 days for a little while there for African-American women. I learned a lot about the disparities of healthcare. I learned a lot about how racism is a part of our institutions. I started to question why, like this might sound silly, but like, who came up with the 50-minute hour? Where did that come from? Who came up with the idea of what a diagnosis is? How is that culturally specific to being white and middle class? all of that stuff started to be a part of my world because of my experience through the AIDS Project. And then you switch to the needle exchange, which at that time was quite illegal. And I'd done a lot of illegal things before then, but not in a way that I could get caught. And it was easy for me not to get caught because I was a white girl with blonde hair. So I just learned like, oh, we actually, and this is going to sound probably stupid and certainly silly and definitely privileged. There's a whole bunch of people out there in the world that we actually don't take care of. We actually don't. And that all of our systems are built around the people that we do take care of. And so again, you say to a person that they need to get more exercise and they just clean all these rooms for the day, which is a very physical job. Or you work in a kitchen. I worked in a kitchen for 6 years and it's the hottest, most physically challenging job you can have. And now we have people who have to also wear masks and all these coverings in a kitchen. That might be the best way for protection, and I'm not going to argue with that, but are we talking about that? Are we talking to them about that? Are we understanding what it means? I don't know how many of you have had to scrape other people's food off of a plate and then wash it with really hot water in a tiny little room where it splashes all over you. It's a crappy ass job. And we have people doing that right now. We have people all over the world doing that. We have people in Inyo and Mono County doing that right now today, and they're also exposed to coronavirus. And so, in my opinion, we're responsible for the message and to make connection with those people. Does it mean that we're going to stop coronavirus? It doesn't seem to mean that. I don't think that what we're doing is stopping coronavirus. But does it mean we can't still have a message around community? I don't think so. So the answer to your question is, it's a daily job, Dirk. I feel like it's a very internal personal work to get out of the way, to understand my privilege, to understand my place in the world, and to really understand what I've been taught. And all of us, every one of us have come away with this idea that the model that we've created around substance use is medically substantiated, and that's not true. This idea that people choose it, that's not true. That people want to use, that's not true. We've created so much shame for people just by the questions that we ask. And the way that we assess somebody for their use is very shaming in our systems, in my opinion. And so, it's taken me a while to figure out, are we using those assessment tools because the government tells us we have to? Because I have a responsibility to keep the doors open for Mono County Behavioral Health. So I may have to use those, but can I add new ones to it? No, those things came from somebody's book some 20 years ago. We're all using them. They use them in the hospital. When was the last time you had a blackout? How many drinks do you drink a day? Like those are important questions, but out of context, it's very shaming. And I'm not going to tell you those answers. Why would I? I answer like, are you depressed? Again, it's not that it's bad. Those are good questions, but if you take them out of context and you take them out of relationship, then we create a barrier with clients. That's what I want us to be thinking about, is how are we creating these barriers?
Thank you, Robin, and thank you, Dirk, for the question. We do have another question from,
Awesome.
which I might be saying your name wrong, sorry. Thank you, Robin and Jacinda, for this platform. Yes, can you please talk about what it is to love a client, how to give them their while supporting them and not becoming their enabler?
Perhaps the definition of love is what I've learned most about, perhaps. Love doesn't mean helping you out of the hole necessarily. Love means that I don't leave you while you're in the hole. Love means that I do my own work to understand how I can make a relationship with you. Like I have difficulty with certain types of people. I'm a human. And my job is to say, everyone wants to be seen, heard, and understood. And so if I can put myself in a position to see you, hear you, and understand you, that doesn't mean I can't also do my job. And it does mean that it comes from love for me. So these are really hard things to describe. So let's say like one of the hardest jobs for a therapist in a government setting is to work with a client who's also in a mandated setting. So if I have somebody who's on probation or in child welfare, and I recognize that this person has a tremendous amount of childhood and adult trauma, and so what that means to me, just put it in a nutshell, is they have a tremendous amount of shame. And they are used to lots of people telling them that they're not doing things correctly, or that they're a piece of shit, or if they really wanted the thing that they say they want, then they would stop doing these other things or start doing these other things. Like people don't come into our systems without hearing all of that from somebody, family members, friends, institutions, and then we do it. Then we start saying it. So it's very hard to do that work because I might see a level of trauma in a person that they're not ready to talk about. And I feel like I can see, or they might talk about how they can't stop thinking about a memory, let's say, or they're still having to be in contact with the person that abused them because it's the father of their kids, let's say. And it makes them feel crazy, and then they feel angry, and then they, quote, act out of that anger, and then they're seen as just this angry person. I think the bottom line is all behavior has a function, and all of that function is survival. And if we can just sit still long enough and not judge them, that's loving. And so someone comes to me and they have a long list of things they need to do from the other agency, that the reason they're with me is they came through another agency, and they have a long list of things they need to do. Okay. The way I talk about it is I say, look, you got a long list of things to do here. And let's negotiate that together. Let's try to figure out how I can help you with that list. Let's try to figure out how I can hold hope for you while you're dealing with that list. Let's figure out how I can get to know you while you're dealing with that list. And it's kind of a both and situation. And if I put myself in charge of that list without making a connection and without having a relationship, then I'm shaming the client. And I think that's true for all of us. Because again, I don't know how many of you are in situations where you have something taken away from you that you want, and then you have somebody else telling you the things you need to do in order to get that thing back. Your freedom, your kids, your dog, whatever. That's a power setup right there that we are in charge of, and we can change it. That doesn't mean we change the rules. That means we change engagement. And so I'm not answering your question about love so well, I don't think. I just know that I feel deep love talking about this. I feel like allowing myself to know people where they're at and getting to know them. I've met amazing people. Do they all do the thing that they need to do to get the thing that they want? No. Is that my job? Not really. People are resilient. They'll figure it out if we help them. But if we don't have a relationship, it's very hard for the work to be done. And we in Mono County and Inyo County are working really hard through this program. I mean, in the last 2 years, the way we talk about people who use drugs and alcohol has changed tremendously. I mean, that's unbelievably hopeful for me that you're here, that I have some relationships with some of you where we talk about people differently. And I know we've all had our own journey to get there, internally and externally. You know, for those of you that are clean and sober, you had to reckon with shame, no question. And if you use the abstinence only model with yourself, then you create a tension within yourself that then it's really hard to work with people who are using drugs right now because you're caught. So you've had to do that work with yourself. I know that because that was my history too. And it's, you know, I'm really reluctant to use words that get overused like self-compassion and self-care. Those things are important, but when I'll give you an example. Like there's a fellow that I run into every week when I am dealing with my trash. And I watch people go by and argue with him. I watch people go by not wearing a mask and he tries to talk to them. I watch people not say hello to him. I watch people speak to him in ways that as though he's not equal to them. And so I do this, and this, I don't know, my mom taught me to always be nice to everybody, to be nice to the checkers or be kind to the people that are helping me, like the post office or whatever. And so I always ask the guy how he's doing, like, how's your day been and all of that. And he told me the other day, like, he goes, oh, and you know, I have a hat on now, sunglasses and a mask so that you can recognize me, I guess, because of my dogs, maybe in my car, I don't know, that he recognized me as, but I'm not doing it so he feels better. I'm doing it because it's the right thing to do. And that matters to me. Do I know anything about that guy? No. Do I think I'm gonna help him in his life? No, that's not the point. The point is he's a human and I'm a human and I want to make a connection with him. And we don't do that enough. And in our work, we forget that, I think, a lot. It's really hard to remember that patient that, oh, I hate seeing that patient. God, they drive me nuts. They're 10 pounds heavier, or their blood work's all out of whack, or they've got abscesses again, or, you know, whatever. I get the frustration. And if you've created a connection, you can always go back to the connection. Hey, how are you? You seem to be struggling again. What's going on? Are you okay? Did something change in your life? It doesn't take very long. Yeah, I lost my housing. Whatever. Well, you're a wonderful human, and I appreciate that you're trying. You're not defined by these bad behaviors. Gotta tell you, this is super weird talking about this all by my little self in my little room here. Arlene, I see you. What's up?
I think Vidka had a question earlier.
I do. Robin, it's great.
Hi, Vidka.
Hi, Robin. It's great hearing you talk. I wish we were like in the same space and having
Yeah.
coffee together. The person who just asked a question mentioned enabling, and I often think about the concept of enabling as the way we shame the people who surround the people who use drugs.
Yeah.
And that we make them feel bad for trying the best way they can to love the people who are struggling with potentially struggling with their drug use. So I was wondering if you could talk a little bit about your thoughts about
Thank you.
and helping people who are trying to love somebody who's using drugs, and like the complexity and of that.
Oh, okay. Thank you for that question, because that is again, when I was coming up, Codependency No More became a thing, and there were all kinds of books written about it, lots and lots of books. And so then I had a private practice for a long time in Santa Cruz, and people would come in and go, I'm really codependent, and especially women. And I think, okay, well, on that list of things, you know how there's always a list of things that we check off, like, do you choose someone over you? Well, yeah, that's the role of a woman. there's so many things on there that were super sexist and very misogynist, in my opinion. So that's a great question. So it's fine to love someone and have accountability. In fact, it's really important. So if you are in a situation where you're working or living or loving somebody who is actively involved with dependence around drugs or alcohol, you get to love them. Tough love didn't work. In fact, it's probably led to a lot of people dying. Okay, you get to love them and you get to have your own set of boundaries and accountability to those boundaries. So it could go and get support, find support. Therapy, of course, I'm always going to think therapy is great support, but find a therapist who will not call you a codependent and not use the word enabling, but who actually talk to you about, like, what do you want from this? And how do you weigh out what you need versus what they need? And what is helpful? So, it kind of comes down to that thing around, like, I'm not going to give money to that guy on the street because he's just going to go buy alcohol. And I think, who am I to say that? So he goes and buys alcohol. I have people in my life that that when they're intoxicated to a certain extent, they become very aggressive with me. So I've had to work hard with them. I've had to be brave and courageous and have really hard conversations that have scared me, that have been something like this. I love you. I'm not going to stop loving you. I care about your well-being. And then there's a certain dynamic between us, is that when you get to a certain point around your drinking, you get aggressive with me. It scares me. And so I'm going to set some limits around how that goes. And if you can't keep the limit at that point because you're too intoxicated to be able to remember our conversation, I'm going to do these things in order to get away from you because I don't want to get hurt. And then later, we'll have a conversation about it and see how it goes. So in other words, I'm not putting myself in a position where I'm staying enabling by loving them still or staying in a relationship. There's so much cultural permission to leave relationship when somebody's doing something that you don't like. And I'm not talking about abuse. I'm talking about just stuff you don't like. And, that to me is part of what holds all of this process around addiction together, is the idea that if you're choosing it, then you're not choosing me. And if you're not choosing me, then I'm either bad for choosing you or I'm bad for not getting out. And the only way that I can be good is to get away from you. That's kind of the dynamic we've set up in our society around this, I think. And it may be that you don't want to give somebody money, let's say, but you can buy them a sweater. And then you go, well, they're just going to sell the sweater. It's like, all right. I mean, that you still get to have acts of kindness and acts of love and stay in connection. And then the work is also our work. Like, do I want to help everyone? Like the enabling question of, if I love, then I enable. And I think if I love, and enabling to me would be more about me trying to solve a problem for my benefit as opposed to theirs. So when the client comes in and says, I need a sandwich, I'm hungry. And I say, oh no, you don't need a sandwich. You need to be clean. So I'm going to send you to rehab. We're going to talk about rehab. And you're like sandwich. And then that's for me, that's not for you, right? Because I don't know how to hold you. I mean, for me, and I know all of you who deal with people who are using opioids right now, it's terrifying. Back in the day when I worked, I don't, in my job right now, not as much, but you worry about your people. Are you going to be safe? I have people who use their drugs alone, inject drugs alone. I used to wake up at night about that. That's loving somebody. But that didn't mean that I went to their house. I mean, it meant that I made sure they knew they were loved. I made sure we talked about everything that she or he could do to help be safe, and then held my breath, to tell you the truth, and just hope for the best. I mean, that's what we can do. That's loving somebody. I don't know if I'm answering your question, but I rail against the whole idea around kind of codependency, and especially if you look at that list, and it's a lot of the traits that women are also expected to have. I don't think it's easy. I don't think that doing the same thing over and over and over again because you think that you're helping is necessarily bad. I think it's that you get some professional help or talk to some people to try to sort out, what are you trying to solve for here? And a lot of it's fear, or a lot of it's guilt, or a lot of it's shame.
So we have about 4 minutes and we have
Oh, yay.
in the chat. We have Savannah Cole asks, what do you believe has shifted over generations within our society that has created the shift in leaving relationships so quickly due to conflicts in perspectives or other disagreements?
I don't know. That's a good question too. I lack of skills to be able to sort out conflict. You know, the not knowing the difference between being abused and being hurt. Deciding that being hurt is being abused, so I need to get away from you rather than work it out. And I'm not advocating that people stay in relationships where abuse is occurring. That's not my point. But we have othered perpetrators. And again, I'm going to go out on thin ice here. I have certain types of people that are really hard to work with, for sure. But I also know that we're all hurt, and so we act out of hurt. And I think that we have created these weird dynamics in our culture where if I feel betrayed or hurt by you, then I get to either act however I want to by hurting you, or I get to leave. And we had a long period of time where we were all about the tough love and sending kids away, and having kids come home and not being able to get into their home. And there's a lot of middle ground there, like that intense humility that kid. I remember this over and over in Santa Cruz. I'm gonna change the doors on the lock, and I'm gonna put an envelope on the door and say, you're no longer welcome here, to kids, because they're using drugs or stealing cars or whatever they're doing. Okay, so does that mean that the only way my choices are either you get to use your drugs in the house and steal cars, or I'm gonna kick you out and never see you again? Why are those your only choices? Why don't we talk about a middle? And I think we've had a lot of professionals participate in this idea that if you're doing bad things, especially if you're using drugs, especially if you're injecting drugs, then I can't be around you. And you may make that choice, but you do it in a way where it's with love, and you help them find their next place.
Thank you, Robin.
I appreciate you all. Thank you. Thanks for listening to me yammer here.
Thank you for setting us.
I'm excited for this, and I appreciate the work you do.
Thank you, Robin.
Yeah, thank you.
Jacinda, can I jump in really quick?
Yes.
I just wanted to apologize. Chelsea Gallardo is not on anymore, but she was our young lady who was able to offer that song for us. And I just wanted to apologize to her and apologize to you guys too. I was having some difficulties getting on, but I wanted to be able to introduce Chelsea to you guys. She's 16 years old. She's an amazing, amazing person, and she's very valuable. But yeah, she's a junior in high school, and I just wanted to give her a shout out and apologize that I wasn't able to get on in time to introduce her properly. I got on when she was just finishing up her song. So, but that's Chelsea, and as very awesome. She's not feeling good today, and she still tried to show up for us. So I just appreciate her a lot for that.
Yeah, that's great. Thank you, Arlene. All right, so next we have Dr. Vidka Eisen. She's the president and CEO of HealthRight 360. Vidka Eisen is the president and chief executive officer of HealthRight 360, a network of federally qualified health centers and one of the largest providers of behavioral health services in marginalized Californians, services to marginalized Californians. With over 30 years of experience in human services, she has dedicated her career to supporting people and communities struggling with addiction and incarceration through the provision of integrated, compassionate, and relevant care. Since being appointed to her current role in 2010, Vidka has led HealthRight 360 through a series of mergers, growing the organization to serve over 36,000 people annually. A frequent speaker on innovative clinical and business practices, Vidka serves on the board of directors of the National Council for Behavioral Health, the California Association of Drug and Alcohol Program Executives, and the California Council of Community Behavioral Health Agencies. Vidka earned a MSW from San Francisco State University and doctorate from Harvard Graduate School of Education. She is also a person in long-term recovery from substance use disorder, having participated in treatment for over 30 years ago at the agency she now leads. Vidka, I'll turn it over to you.
Thank you. Thanks a lot. And Robin, first of all, thank you all for inviting me today. I so wish I could be there in person. I was really excited when Tom and I first had a conversation about me presenting. I was super excited about going over to Mono and Inyo counties because it's one of my favorite parts of California. So, so we have to live on Zoom as we do now. Robin, thank you. It was our work clearly intersects. So it's great that you went first. I'm going to share my screen. It might take me a second to figure out make sure I have this right. Okay. Are you able to see my screen?
Not yet.
Not yet, okay. Hang in there for a sec. Oh, technology. Can you see it now? Not yet.
No.
Okay, I'm getting technical help. If you want to take a bathroom break now would be a good time. Okay, sorry. Okay, share screen. Pick. This one? Oh, we got it. Yay.
All right, you can see it. Thank you.
Okay, you can see it now. Yes? Great. Thank you. Okay, sorry for that. You think I've done these enough that this doesn't continue to happen to me, but what can I say? Okay, I wanted to talk a little bit about, I'm going to talk a little bit about the organization that I work for, and then talk about harm reduction, in specific, how to integrate harm reduction practices within substance use disorder treatment, because it's complicated. So as an organization, you heard Jacinda made the introduction. We do operate a number of programs in 10 different counties. And we've really developed our services around kind of placing the patient or client at the center, and then trying to develop the care and services they need in order to help them on their path to health. And so that has included substance use disorder treatment, detox, residential, in a variety of settings, residential, outpatient settings, street outreach, that we do provide services that address the social determinants of health. We have dental care. We actually looked at dental care as a way to access clients who wouldn't otherwise come in for care. which is exactly what happens. Our street outreach team goes out, and people may not want to come in for care for their hypertension or for their mental health, but they will come in if they have a toothache, and then we're able to link them up to other services that we have, maybe manage their diabetes or hypertension, you know, get them a sandwich, like Robin said. So that's kind of how we've developed care and services. We definitely have a no wrong door approach. So wherever you come in for care with HealthRight 360, we hope that we can, like whatever it is you need, the next thing, that we can provide that for you or link you to it in any way that we can. There's lots of benefits to integrated care, obviously, you know, it allows for different people, a team of people to work collaboratively, putting the person, you know, the person served is like in the center of that and drives that team. And it also offers a comprehensive level of care for people. What we know is that it decreases the cost of utilization of emergency departments, it decreases utilization of inpatient costs, and it decreases the total medical costs. And certainly during the period, this particular period, starting in March with the shelter in place and the widespread of COVID-19, we very much see our services as kind of flattening the curve and helping people, providing services to people to make sure that they don't need to go to the hospital, so that hospitals are freed up to deal with what we now see as a surge across the state in COVID-19 care. And it is even included, like currently we're flexing and providing, we're overseeing some of the isolation and quarantine hotels in San Francisco, because as it turns out, as people test positive who are in congregate living settings or in shelters or in residential treatment, they're sent over to the hotels. And we thought, well, let me just keep taking, we were the ones sending half the clients to the hotel. So then why don't we just try to see if we can operate the hotel and keep people safe until they clear COVID. So it's kind of, that is always how we think about the work that we do. And this is just another image of it that we drew about, like, you know, another way of looking at kind of what no wrong door means. Wherever people come in, we can link them to services. Which is important because there is no, you know, somehow we think about healthcare, what is essential in healthcare, and we tend to, the healthcare system tends to think about there's like, you know, there's like neck up and then the rest of you, but obviously those things are all integrated. So this is the, you know, this is what I think about a lot in our work, and I have been doing, I've been working in the field for a really, really long time. And I asked the question, what is our plan for improving health for the majority of individuals who have problematic substance use? So this is information, hasn't changed very much over the years. It's from the National Survey on Drug Use and Health. This is from 2017. And this, again, this data has been fairly fixed. It showed about a little over 20 million, almost 21 million people needed substance use disorder treatment in 2017. And of that, 2.5 million people received treatment, and 1 million people perceived the need but were unable to get it. But over 17 million people did not perceive a need for treatment and did not receive it. Now, that does not mean that 17 million people didn't need care and support or some kind of way to keep them safe or healthy. And I think that big chunk of that circle, huge 17 million number, that's the spot, that's where we need to focus more of our attention, and not necessarily moving people into abstinence, but really moving people, making sure that they're safe, that they have access to the care that they need, whatever that is, to keep them safe. I often think about harm reduction. I mean, it's a relatively contemporary term, but I think about it as services that have existed for a long time. The picture you see here is from the Haight-Ashbury Free Clinics. Picture was taken in 1967. And Haight-Ashbury Free Clinics is one of our programs, and it opened in the Haight-Ashbury district in the middle of the Summer of Love to provide services for all the young people who kind of gathered in that part of the city. And the services offered by Haight-Ashbury Free Clinics were harm reduction services, although they weren't called that. They were welcoming, they were non-judgmental, they were loving, they were whatever people needed to kind of get care. In my own experience, as Jacinda said, I'm a former drug user. Haight-Ashbury Free Clinics had one of the first outpatient heroin detox programs in the Bay Area, if not the state. And you could go into that program, you know, every month, every other month. You can come in and they would never shame you. They would never make you feel embarrassed. They'd never say, aren't you sick of this? Oh, you never get that like, oh, you again. Like you'd show up and they'd be like, oh, I'm so happy to see you. We talk about, you know, baseball, or talk about football, or, you know, how's your cousin, or I saw your cousin the other day, or whatever. And so you always just felt welcome. So you didn't mind going back. You'd go back, you know, if ever you felt like you needed help, you go back just to talk to them, you go back and hang out with them. So that eventually my own journey, when I was like, things hit a place where I wanted to make some more changes, it was to them I went and said, what do you think I should do? Where should I go next? What should I do? And I trusted them. So to me, like harm reduction, that's what we are as a treatment system. We need to journey back to that kind of the sort of the hippie ethos of approaching people with love and without judgment. We're not this. You've already heard definitions of what harm reduction is. So it's a set of practical strategies aimed at reducing negative consequences associated with drug use. It's also a movement for social justice. It's not particularly arbitrary or haphazard. It's not an encouragement. I mean, these kinds of things that people think about when they think about harm reduction. It's not the solution. It's part of a range of solutions. It is definitely not incompatible with substance use disorder treatment. And it's also not necessarily dismissive of abstinence-based treatment. I think as Robin spoke before me so eloquently, it really is about meeting people where they are, putting them at the center, and then offering them whatever they need to help them on a path to health, with whatever and however that they define that for them. This is one of my favorite pictures. I had the opportunity at a grant and had the opportunity to visit some supervised drug consumption programs around Canada and Europe. And this is a supervised consumption facility in Spain, in Barcelona. And all throughout Europe, supervised drug consumption, they have injection rooms where people can be observed injecting drugs and make sure they don't overdose. But they also have inhalation rooms because a lot of people smoke drugs, and they can also overdose from those drugs. And so here's a worker in the inhalation room, and she is preparing clean equipment, crack pipes, basically, for people. And I just loved her. To me, like her face and her expression, she's like, crack pipes, really embodies the spirit of harm reduction, in which she's there to keep the people who are in the other room safe, and to help to make sure that whatever they do doesn't cause them any further harm or ill effect. And she does that with a great deal of just what I saw as youthful joy. I'm going to talk briefly about MAT, but I don't actually think of MAT, medication treatment, addiction treatment, as harm reduction. I think of it as it's medicine that people take to improve the quality of their life and reduce the mortality for their drug and alcohol use. And it's I'm happy to see. I believe that this state, Department of Healthcare Services, and so many counties have really invested in educating communities, provider networks, providers, and people who are in their care that MAT, it's medicine. There's so many times I've met with clients who are coming into treatment, and there's clients who've been in a treatment a number of times for opioid use disorder, and they'll be like, I'm on methadone now, but I plan on getting off it. And I'll be like, well, let's talk about that. Why? It's like, well, because I want to be clean. I'm like, you can have these are medicines you're taking, and we don't put judgments on people who take other kinds of medicines where there's a behavioral component. People who take medicine for diabetes, or they take medicine for asthma or hypertension, and yeah, those conditions all have some behavioral components to them. We don't judge people for taking medicine, but we do judge ourselves and judge people for taking medicines for their drug and alcohol use. So I think, again, I'm proud that be in a state where I think there's so much work has been done and invested in making and kind of normalizing medication treatments for substance use disorder. I want to talk a little bit about coercion. And this has been like the thing that's been on my mind a lot lately. And that is the impact that coercion has had on treatment. I think it's particularly relevant if you think about Oregon's recent referendum on decriminalizing drugs. And I think that over the years, coercion has become so much a part of treatment that it is made for a lack of creativity and innovation on the part of treatment providers in the treatment system. Because you become dependent on coercion rather than creatively figuring out what is it that people want and need. There's all this research that shows, a lot of research on drug courts that talks about that these are effective interventions. And I would argue that that research does not take into account the level of damage criminalizing drugs in people's lives has had on entire communities, particularly communities of color. But I also think it's created this system where, as the laws changed in California, as we began to a certain degree not enforcing such heavy felony penalties for people who use drugs or sold drugs. And all of a sudden people stopped going to treatment because they didn't have the threat of going to jail. So we were left going, my God, people aren't coming. And I think that is a crazy way to run a business. Like if we were running a restaurant and people came to us and then they left because they didn't like the food. I was like, I don't like your food, I'm leaving. We don't usually say, well, this would be a great restaurant if the police made them come, or if they had to come here with the alternative being they would go to jail. And we don't say, well, they're just not ready for our food. They just need to go out there and eat other people's food, and then they'll come back and realize that our food is the best. I mean, that's just a ridiculous concept, but that is how treatment is operated. And because of that, again, we have, I think as a system, need to really kind of retool and truly try to meet people where they are. I used to have the belief that every single person who left treatment prematurely, it was because we failed them. And to a certain degree, I haven't entirely given that belief up. But I also know that sometimes we force people into treatment who don't want to stop using drugs. They don't want to. And we think somehow we have to, it's our failure that we haven't figured out how to get them to stop doing that, instead of trying to figure out what it is they need to be healthy and safe. And I think that is our charge. And I think coercion kind of alleviates that of our responsibility. So that's my little piece on coercion. I'm going to give you some examples of some harm reduction principles, as Robin talked about. Is syringe access programs, obviously, are harm reduction programs, which started in response to people transmitting HIV and the risks of HIV transmission through shared needles. Overdose reversal medication, naloxone, is also harm reduction. I think the broad degree to which naloxone is distributed in this state and parts of this state, I think has helped save countless lives. This is a picture of our, we have Narcan rescue stations in the residential facilities and our outpatient facilities. We give it out quite freely because we came to the realization that just because people are in treatment, again, remember, people are still coerced into treatment, doesn't mean that they are ready to completely stop using drugs. And so having dealt with some overdoses and the ability to reverse them, we wanted to make sure that staff were trained in its use and other clients were trained in the use of Narcan. Drug checking. So many syringe access programs offer drug checking, which is an ability for people to test their drugs to see what's the composition of those drugs, like what those drugs are, what's in it. That doesn't mean people also they'll look, they'll say, I thought this was meth, but it's got fentanyl in it. Doesn't mean they won't necessarily use it, but at least perhaps it gives them the option of asking for some support or making sure that they're with somebody else, that they have Narcan available. So drug checking is an example of harm reduction. Also frequently done at raves where people were getting kind of tainted Molly and things like that. So drug checking. Housing first is probably one of the most effective harm reduction interventions, which is make sure that people are housed so that they like that, because not having housing is such a huge has such a huge negative health impact. So first, make sure that people are housed without conditions. So without, you have to be sober in this house, or you can't drink in this house, or without conditions. So housing first is a harm reduction example. Integrated primary care. Again, I think I gave you the dental example earlier, so including integrated dental care. We really did look at dental care as kind of a first line of access for people who wouldn't come in for any other service. Managed alcohol programs. I believe that currently San Francisco is looking to develop, the county is looking to develop a managed alcohol program. These are programs where people stay and live, and where alcohol is dispensed to them. So this kind of came about as part of the COVID-19 emergency, as the city attempted to house a lot of people who were experiencing homelessness, many of whom needed alcohol every day in order not to go into acute alcohol withdrawal. So the city began providing alcohol, and then realized this has a lot of other benefits. And there's been research that shows that managed alcohol programs reduce emergency department utilization. They reduce the amount of people who go into acute alcohol withdrawal, which is pretty damaging. And they actually reduce the amount of alcohol people drink. People who must consume alcohol before they can go into shelters, from a scarcity perspective, consume lots more, or consume it very quickly in ways that aren't safe. So managed alcohol programs offer like a stability and a safety that people actually reduce the amount of alcohol they consume. Decriminalization of illicit substances, which I'll talk more about later, and then safe consumption services. Supervised consumption services. So this is actually a picture of, it's probably the most studied and visited supervised consumption site in the world. This is the Insight location in Canada. So in a supervised consumption site, this is a different one. Supervised consumption site, people bring pre-obtained drugs to the site, and they get access to clean equipment, and they consume these sites while supervised by somebody to make sure that someone's there to reverse any overdose, and if necessary, and to build relationships with the people who are using drugs. I think Robin spoke very eloquently also about the importance of connection and relationships. So like one of the main benefits of supervised drug consumption sites are that they enable people who are using drugs to build connections with people. And those people, if you build trusting relationships, maybe you can take a look at that open wound on your arm or on your leg, maybe connect you to other kinds of care. And certainly prevent you from dying from an overdose. So at the Insight location in Canada had research behind it, an evaluation behind it, which showed that there was an increased connection for the people who use the site to detox and substance use treatment, although there's not an expectation that you would. So they are compassionate, non-judgmental, but just being there and building connections. If people wanted something else, Insight was able to connect them with that. Definitely a safer management of overdoses. It also allows them not to use Narcan immediately. If anyone's ever done a Narcan overdose reversal, people who fought hard to get the drugs that they've just consumed because they've had to scramble to get them, you administer Narcan and immediately it kind of reverses that drug, and they can kind of come to and be upset. And so it allows you to monitor people who may be at risk for overdosing, and their oxygen saturation, and to give oxygen, and then keep monitoring that, and if necessary, give Narcan, but it's not the first thing you have to do necessarily. They reduce public drug use. They also reduce bacterial infections and transmission of HIV and hepatitis C. There's definitely a cost savings due to reduction in overdose deaths, disease, and emergency medical department usage. And then you build connections with people not already connected with treatment. I've been advocating for this with a number of others in California. This is probably going on through 4 years now. We keep getting a bill before this legislature. It comes close to passing, then it doesn't finally passed, and Governor Brown vetoed it at the 11th hour, which was kind of sad. And so we're back at it again. I think Senator Scott Wiener is introducing the bill, and it's for to allow for pilot supervised drug consumption sites in San Francisco, Oakland, and Los Angeles, which are 3 communities that have asked to do this. In San Francisco, currently, more people have died since March in the shelter in place as a result of COVID-19. More people have died, considerably more people have died of drug overdoses than have died of COVID-19. So it is a health crisis. Public opinion is shifting about it. This has been, I think, one of the most interesting experiences in doing advocacy around, particularly around supervised drug consumption, is that often people start out, like, if you've done advocacy work before, many of you have, you know, often people are in really fixed places, in fixed positions. You believe this, you believe that, and it's difficult to see any movement often. And I've never had an experience like working around advocating for supervised drug consumption, because so many people, they change their minds in a conversation. To the degree that when I went to Vancouver, it was actually with the San Francisco Chamber of Commerce, which is usually chambers of commerce are fairly conservative bodies. And they went to visit the Insight program and came away from that thinking this makes total sense, and then supported the San Francisco's efforts to develop supervised drug consumption. So it has been quite remarkable to see public opinion shifting. The more and more people die from drug overdoses, to see public opinion shifting, and which is an opportunity to help people understand more about substance use, problematic substance use, as well as more about harm reduction. But we have created a system that is very heavily reliant on abstinence only. So what's the consequences of an abstinence only treatment system? Well, we end up discharging clients from programs when the client needs us most. So many programs still discharge clients for drug use, residential programs, and to a lesser degree, outpatient programs. So you gotta say, what would you think of your cardiologist who said, oh my God, I can't see these patients anymore. They keep getting heart attacks, right? So people come to us for help for a condition for which its primary symptom, if you will, is using drugs. And then we kick them out when they show their symptoms. And so we discharge the clients who are the most at risk. We also increase stigma and shame associated with substance use. So when you ask someone to leave a program, it's hard for them not to feel some sense of shame about that. I mean, so we're just reinforcing that person. We used to use the term, we don't anymore, but we used to use the term, they were treatment failure. It's a treatment failure. Now, if that's not a stigmatizing term, I don't know what is. We further marginalize people who use drugs. So instead of keeping them connected with us, we have pushed them out. We push them out. And so they're no longer connected to any kind of care. We also end up keeping all the clients who might have gotten well without us. You're cherry picking clients. So you only treat the clients who are ready. So treating the ones who are ready might be people who might have gotten well without all of the services we get them. Instead of trying to find a way to work with the people who are at most risk. And then finally, you increase the risk of overdose because the person may have been in treatment for a minute. So they may not have the same tolerance that they had from when they came in, and then use the same amount and potentially die from an overdose. So why don't we incorporate harm reduction principles into SUD treatment? Well, some of it comes from our really deeply held moral values and beliefs about substance use. As Robin said earlier, we think it's kind of these like Calvinist beliefs of like, we think people who do too much of something are bad people, they're intemperate. And we don't look at it as any other kind of health issue or health challenge. Often, many of us who work in the field, substance use disorder treatment, have a history, have lived experience. And so there is there is a bit of what worked for me will work for you. And people will reminisce about their own treatment experience and think that that's what everybody needs. And it's important to challenge that assumption internally, and for people who operate programs to challenge it amongst their staff. I mean, people also have funny ways of remembering things, I think. I had a conversation with somebody about, it was in a community forum about supervised drug consumption. And a gentleman got up and he said, you know, I had to hit bottom. And it was through that I finally got recovery. And so I'm concerned, he said, that you're enabling people into using drugs and they'll never get into recovery. And I said, I thought that people have a funny way of remembering their histories, because I asked, if you really think about what led you on your path to your recovery, I'd be willing to bet that there was actually somebody in that in that process who actually gave you hope. It wasn't that they rejected you or that your life had become horrible. It's that somebody reached out and connected with you and believed in you, and that's really what works. You don't need to put people into sheer misery or utter misery, because actually many people are living in a great deal of pain and misery, and reinforcing that doesn't make them want to stop using drugs, doesn't give them the energy or ability to change their behavior, reduce their drug use in any way. It just reinforces shame. So, you know, hitting bottom, I think, is one of those terrible myths that have become part of the whole recovery story, that I think is so dangerous, just because I think for many people that they have to die first, if that's what that means. You know, people have concerns about encouraging or enabling drug use. You know, I'd asked Robin to talk a little bit about enabling. And I think that it's a harmful principle that we've come across. And I understand. I mean, it's like I said, I've been doing this for a long time. And I remember years ago, the counselors in one of our programs was talking about the parents of a person in treatment. And they were talking somewhat derisively, I'll say, about the parents, because the parents used to drive their kid to the connection so the kid can get drugs. And I was like, yeah, they just didn't want their kid to die. Like, why would we shame parents for that, or anybody for that? And so, you know, I would worry less about enabling drug use and more about how do we build connections with people that keeps them linked to care. When people ask me, like, what should I do with my kid? And I will say, well, for one thing, keep paying for their cell phone service, because once that's lost, you've lost them a bit, and so they need that link. You're their lifeline. There's also in the field. I mean, this is an amazing conference day you have planned today, because you actually have a lot of conversation within it about harm reduction. It's often completely absent from any conference platform conversations about harm reduction and how it's part of a continuum of care. Therefore, there's also a lack of training, and people have a lack of, therefore they don't have the tools to implement harm reduction. So there's funders who prohibit it. Oh my goodness, I got in a lot of trouble with the drug court judges, because we weren't kicking people out for using drugs. They're like, I want an abstinence only house. I'm like, no one will be in your house. You will have an abstinence only house with nobody in it, because people's desire to be in treatment fluctuates minute by minute, day by day. And so if you say, they may come in saying, I want an abstinence only program, and an hour later they don't, or something happens that night and they feel like they need to use drugs. So we had to really, and luckily, like, the county was supportive. In this case, it was San Francisco, supportive. We met with the drug court judges to talk about it being a harm reduction county. So these are kind of things that like keep people from implementing them. You know, things that also force us to over-test people. Urinalysis testing, UTOX, which I think is also a problematic practice. So, you know, what are the pathways to better health for the people we serve? So let's see if we can embed harm reduction principles in our treatment programs. And I think Robin spoke a great deal about this earlier. When we all like to say we're client-centered, but what does it really mean to be client-centered? Like, what does that mean? How do we live that? What does it mean to meet clients where they are? I was giving a tour of one of our residential programs one time. I think I had like, it was a Thunder tour. And this guy met us at the door. He's like, hey, I'm living in transitional housing. I used to be in this program. Let me give you the tour. I was like, great. I was like, introduced himself. I said, how are you? And he said, I'm doing great. And he's like, whips out his cannabis card. He said, I got my cannabis card. I'm doing great. I said, that's fantastic. He said, yeah, I don't drink anymore and I don't use meth. This is really showing me his cannabis card. Now, who in the world doesn't think that that is a better outcome for this person? Like this person, because he himself feels so much better. Yeah, he uses cannabis, but he's not doing the thing that for him caused him to suffer. So I think we have to really think about what is it that we can do to really meet people where they are. If they don't want to use meth, but they still use something else, let's get them there. Let's get them there. Let's get them off. Let's move them on the path that they see is fit for them so that we maintain that relationship and connection. We also need to create a system of care that has multiple options. I had a conversation, I think I said this earlier, we force people into treatment because they have no other option for where they can be, particularly if they're experiencing homelessness. So you can go to jail, you can live under the bridge, or you can be in treatment. And so they're going to choose treatment, but they have potentially, they just don't want it. They don't want to be in the streets, but they don't want to stop using drugs. That is not for them what they see as their chief problem. But we don't have options for them. So we force them into treatment or we send them to jail. And so we need to come up with a system of care that allows us to move people based on their current needs to what it is that they need. We have to assure that all clients remain connected to care. We operate a number of residential programs. There was a period of time when everybody started having cell phones. And so lots of programs took clients' cell phones, and we decided, you know what, we're not going to take anybody's cell phone. They can keep their cell phones. And there was concerns about, like, are they going to arrange drug drops? Like, what's going to happen? They're going to get calls from family members, going to be distracted. But we were like, no, they can keep their cell phones. They just need to give us their phone number. And so if people left program, we can call them and say, hey, are you doing okay? Is there anything you need? If you want to come back, we're here for you. Like, so you want to maintain that connection. And if they can't maintain it in residential, can we move you somewhere else? Can we see if maybe outpatient care would work for you? We also have to change how and what we measure. Like, if all we measure is abstinence, then programs drive towards abstinence. If we have to measure other things, other steps along a path to health. And finally, we need to check our own judgments at the door. This isn't about what we think is the best or right. It's about meeting with clients and helping. Let's see if we can get them take any step towards their health, improving their health. So I'm not going to pretend it's easy to do this because it's not. There's a lot of challenges embedding harm reduction, some key challenges embedding harm reduction principles into substance use disorder treatment. And one of the big ones, particularly in a residential setting, is bringing together people who are ambivalent about recovery with people who are seeking recovery and desire a drug-free environment. That's a challenge. If we don't want to ask people to leave when they exhibit their symptom, which is drug use. At the same time, there are other people who are truly triggered by that, particularly in the early stages of their recovery. So how do we create an environment where everybody is safe? Also, our staff and our clients think about, our clients come in thinking about, they have kind of a movie notion of what treatment's supposed to look like. And therefore, they have this whole notion of, am I ready? I'm not ready, this whole readiness idea. And also this whole notion of like abstinence is the only path. And so we need to really, really do work on helping staff and the client community understand that people are on different paths, and how can we make sure this house and the community is safe for everybody in it. And we also need to change policymakers thinking about harm reduction and recovery, like I said, to get in trouble with the drug court judges. And it took a while. I mean, again, I think that DHCS, Department of Healthcare Services, has really been a good partner. But was just a couple of years ago that it was a legal requirement. It was in statute. It was in our regulations. I mean, it was in regulations that a person who used drugs in a residential treatment facility had to be asked to leave so that they can go to detox. And so it took a while to bring about change in that, so that we weren't actually forced by regulation to ask the clients to leave. Talk for a second about criminalizing drugs and decriminalization, because I think that is like, you can't talk about harm reduction without talking about decriminalizing drugs. Criminalizing drugs has not resulted in less or safer drug use. In fact, at the height of criminalizing drugs in California, we had the third highest incarceration rate in the world. People continue to use drugs. During the fentanyl overdose crisis, people overdosed in prisons. They were overdosing at a fairly high rate in prisons. So people don't stop using drugs when you criminalize it. All that did happen is it resulted in mass incarceration of people and communities of color, and that had devastating generational impacts. It also drives an underground economy, which means that you force people, they're always doing something illegal, you force them into an underground economy and a marginalized life. Then it forces us to overly rely on coercion over quality and innovation. It makes recovery challenging because it serves as an obstacle to gaining employment and housing. There's many places where having a felony conviction for drug sales means you're not going to be able to get federal financial aid or can't access HUD housing potentially. So there's lots of challenges that you create in people's lives that make their lives more difficult because we criminalize their health condition. And it prevents the expansion of evidence-based harm reduction efforts, because for the principal reason why supervised drug consumption has not opened in San Francisco or in Philadelphia, where it was challenged even in the courts, is because of the statute, the crack house statute, which said, you can't operate a premises that knowingly has drugs, where drugs are consumed on the premises. So it prevents the expansion of evidence-based harm reduction efforts. So what does decriminalization look like? Well, and you should know, it was done in Portugal a long time ago, and Portugal decided it was let's take a public health approach to people's drug use, and it did not result in an increase in drug use or an increase in crime. What it does do is eliminate penalties for drug use and possession and low-level drug sales. It also eliminates penalties for possession of equipment to use drugs. And in so doing, again, instead of sending people to prison, instead of marginalizing them, we are able to maintain those connections that might move people to health. I close with this. We cannot solve our problems with the same thinking we used when we created them. Or, as you often hear in the rooms of 12-step, insanity is doing the same thing over and over again and expecting different results. We cannot use the treatment models of the 80s to meet the challenges of the 21st century. So with that, I will stop and answer any questions, get a conversation going.
Feel free to put in questions in the Q&A.
Hey, so this is Tom Booth. Thanks a lot, Vitka. That was great. And while we're waiting for other questions, so yeah, I'm really interested in the possibility of decriminalization in California. I guess that most people on this call at this meeting know that Oregon, I think it was a voter initiative. They just passed the first, broad drug possession decriminalization law in the country. Probably goes into effect, in a few weeks. Not quite sure. But is there anybody who's working on that in California? Oregon's usually a little bit ahead of us on things like this.
I know, right? I was like, Oregon, how did you go first? And the challenge for Oregon actually is that, and maybe it's important that they did it, was because they actually didn't have as robust a treatment network across their state as California does. In other words, California is in many ways more prepared. So what the ordinance in Oregon did was it did say that they had to increase the investment in treatment as well, which is a good thing, right? So it was amazing that they were able to kind of do both of those things at the same time. And I definitely think you will see us as advocates beginning that work to look to see if we can find legislative sponsors to carry a similar decriminalization bill. I would anticipate that happening. Like I said, there's already Senator Scott Wiener is introducing the latest version of the supervised drug consumption bill. The session hasn't even started yet. I would imagine I would be surprised if we didn't see another bill following Oregon's decriminalization bill.
Hi, Vitka. It's really nice to meet you. I wanted to get some clarification about something that you mentioned, and also just note to Tom that I don't know legislatively who will be that champion, but I know Drug Policy Alliance is always on the drug decrim thing. So I assume that whoever it is, they will also be championing that.
Yeah, my guess is they will. They'll probably reach out to see if there's any appetite for it, for a legislative sponsor.
Yeah, absolutely. Got to get through the safe consumption sites first, and then go there. But yeah, so you had mentioned something about like Narcan stations in residential treatment facilities.
Yep.
So I live up in Humboldt County, and we have a facility here. And they were having some issues getting Narcan access to their clients. Essentially, they said something about like, because it's technically a controlled substance, or like as a prescription, right? Yeah, you have a prescription for it, that they couldn't make it easily accessible to participants. Like it had to stay in a locked box behind a locked door. And it looks like yours was just like freely open to staff and clients.
Yes.
So I don't know if there was a confusion there, or like there are some different rules depending on funding. I just wanted maybe some clarification about how you worked that.
Yeah. So my guess is, this is how I think it works. Every drug Medi-Cal program in the state needs to have a medical director, and the medical director can write a standing order, and that standing order allows for the distribution of the Narcan. So in fact, they sign off on our Narcan requests, because I think we get it through either the county or the state. But I believe it's through the standing order. Tom, you may know more than me about this, but I think that is how we are able to make it so freely available.
Yeah. Thanks, Vitka and Jessica. Yeah, so the law that makes it possible to distribute naloxone without a prescription does require some education, and a funky bit about that is it actually has a line in there about requiring education in mouth-to-mouth resuscitation, I think, which a lot of programs feel like they don't really need to include, but there probably should be some attempt, some way to provide education, and whether you just provide some education to everybody who comes in the program from the get-go, then make the naloxone available as needed. I would think that would be real feasible. But yeah, so I think people just have to be creative. But it's clearly I mean, you can buy it at a drugstore now without a prescription. I mean, the state has gone to great lengths to make it accessible, but there are a few requirements that probably no one's going to enforce it on you if you don't meet all the requirements. But if you're trying to adhere to the law, you got to try to provide some education on how to use it.
Yeah, the Narcan rescue station picture that I showed was from our facility, and it has instructions, a big poster of how to use it right there. So it shows you exactly how you're supposed to spray it. So we meet that. First of all, we provide training for staff, but we also meet the test because it's great, big, easy to read infographic instructions on how to use the Narcan. And you can't, you know what, I was really curious when, as the state began to expand Narcan distribution, I went to the local Walgreens and I said, hey, if I want Narcan, could you just sell it to me? And the pharmacist said, yep, I can. I said, I don't need a prescription. She said, no, she has a standing order as a pharmacist that she can distribute it. And then she said, I actually offer it to every person every time we fill a opioid prescription. I do a consult and say, would you like some Narcan? And explain what it is. And she said, they always say no, because they think, oh, overdoses are something that only happens to people on the streets. But I was impressed that that's where the state has come to that place where, you know, your Walgreens and CVS pharmacists are able and willing to offer people Narcan.
We have a question in the Q&A. How would you respond to people that say, in quotes, the government shouldn't be providing or using taxpayer dollars for safe using supplies or supervised sites, etc.?
What I've typically said is, if you come from a place of recovery, then know that dead people don't ever recover. So people who die of overdoses have no, like, what is the alternative to that? The alternative to that, because it isn't going to stop people from using drugs. So people continue to use drugs, only they will do it in ways that are at much higher risk and potentially much higher costs. In other words, infections, transmit infections, the cost of Hep C treatment, still pretty prohibitive. And so so the government is, one way or the other, the government is paying for that. So why not pay for it on the front end? And at the same time, help people move on a path to health. I always like to remind people that we do have supervised drug consumption legal in this country, in the United States, where people are able to purchase and consume drugs under the supervision of a bartender, and it's called a bar. So people, you go to a bar and you drink and you buy your drinks and they pay taxes. You get taxed for that. And sometimes if it's a responsible bartender, they might take your keys, call you an Uber, make sure that you're not driving drunk home. So we have such spaces already. We just don't have them for people who use drugs that we have arbitrarily really classified as illegal. There was a period of time in which alcohol was an illegal drug, and all those people who drank during Prohibition were criminals. And then all of a sudden, the repeal of Prohibition, they became non-criminals. Like, that's how that works. We classify, how you classify people as criminal or behaviors, criminal in this sense, is completely socially constructed, right?
All right, any other questions or comments from the other panelists? All right, so we have about 7 minutes until the next speaker. We'll take a short break. Thank you so much, Vitka.
Thank you, everybody. Thanks.
Yeah, thanks again, Vitka, and we'll get you out here to Mono Inyo next time
Oh,
when
please.
the pandemic settles down. Yeah,
I definitely want to come. Thank you.
Thank you, Vitka.
Okay.
All right, so I think we'll start with our next speaker. We have Sarah Reese. Hi, Sarah.
Good morning.
Morning. She's
Hi,
the assistant. Oh, go ahead.
Sorry, Jacinda. Antonio was going to introduce Jacinda for us. Or Sarah. Sorry.
Okay, sounds good.
Hi, Antonia. You are muted.
Unmute.
Oh, my name is Antonio Cardenas. Good morning, everyone. I'm formerly incarcerated. I'm in active recovery right now from drug abuse. I've been clean for 7 years now. I am from Bishop. I'm a tribal citizen. I was invited to this event, and I was in the course of my work. I'm in the University of Montana School of Social Work. I'm a grad student. And I met this professor who was talking about perinatal SUDs and MAT and case management. And I was like, wait a minute. And so I approached her, and we talk all the time. Anyway, she's my favorite professor.
Thanks.
So yeah, we talked, and she said yes, and here she is. So go ahead, Sarah.
Antonia, thank you so much. And I have to also say that you are one of my favorite students by far. So I'm so grateful to have this opportunity to be here and talk with you all today. I am a new professor at the University of Montana in the School of Social Work. And I've worked with people who are, struggling with substance use disorders, mental health problems, and poverty over the last 10 years or so. And for the past 5, I did more research on substance use disorder and chronic pain, and focused specifically on pregnancy and substance use in pregnancy. So I'm really excited to be here and talk with you all today. I had the opportunity to learn a lot from working in a high-risk prenatal clinic in Salt Lake City, Utah, that was doing some really exciting work and providing comprehensive care to women who are pregnant. And I've also here in Montana had the opportunity to work on a project that's implementing a system-wide approach to substance use in pregnancy. So we're working to create a system to universally screen all women who are coming for prenatal care, and then connecting them to needed services. So I'm excited to be here, still learning a lot about this subject, and also learning a lot about Mono County. So I know you all have a very specific context that you're working in. So I want to encourage anyone who has thoughts or comments or questions to feel free to chime in at any time. So actually, before I get started, I want to ask you all to bring to mind a person you've worked with who was pregnant or recently had a baby who was also struggling with substance use. So what was this like? What was the context that you were working with this person? In your mind, what did you think was the best course of action working with this individual? And what was the outcome you wanted to see with this person? And any other thoughts or feelings that come up around working with this individual. So taking a moment to think about that. And what I find is inevitably when we're talking about substance use, like the speaker prior to me, Vika, was speaking about, there's tremendous stigma, not only sometimes within our own minds and judgment, certainly within society, that can be reflected in these policies. So I think this will be a really nice, it will follow well from the previous speaker. So especially when we're talking about women who are pregnant, when I'm working with providers of any kind, it's, I think, helpful to acknowledge and recognize those thoughts that are coming up. So it might be thoughts like, how could a woman do this while she's pregnant? Or it could be thoughts and concerns about the baby and this real urgency to feel like you want to help, you want to do something, you want to do anything you can to help. You might also be thinking about a person really close to you or a loved one, because there's few of us who have not been touched by substance use disorder in our family. So noticing throughout this talk, maybe paying attention to that and keeping in mind these experiences you've had. So the first thing I want to do, I know many of you are very involved with this work, but I want to make sure we're all kind of using the same language. So I want to describe or to define substance use. And over time, we know that recurrent use of substances can result in neurobiological changes that lead to physiological, cognitive, and behavioral symptoms. People develop a tolerance for the substance. They begin to need more and more to achieve that same effect. They also experience withdrawal symptoms. When they don't use the substance, they feel sick, they feel emotionally down, and they begin to experience cognitive symptoms like craving and a strong desire or urge to use substances, even if at the same time they experience a desire to cut back or control use. So finally, people exhibit all of these behavioral symptoms, for example, continuing to use substances even though they are experiencing physical or psychological or social problems related to use, and are giving up important social work or recreational activities because of substance use. So sometimes it's difficult for those who are not experiencing symptoms of substance use to understand really what's going on here. From the outside, it can look like people are making a choice about their behavior. But we know that this misunderstanding has led to, like was spoken earlier, the stigmatization and the criminalization of this brain disorder, especially among pregnant women and also other marginalized groups like people of color. So this is not a moral deficiency. This is not a lack of self-control. The development of the opioid epidemic, for example, is really a result of different community factors and individual level factors really coming together to form a perfect storm. So in the 1990s, medical providers began prescribing opioids at higher and higher rates. We know that this was likely fueled by drug companies marketing medications without accurate science to back up their claims. And as early efforts to curb the opioid epidemic were starting, the prescription of opioids became more and more difficult. It's more and more challenging to obtain opioids through a prescription. So people began to turn to heroin. It's just a cheaper alternative and more accessible. And then there was a rise of heroin-related deaths beginning in 2010. And heroin manufacturers then began to add illicit fentanyl to heroin and increase its potency, leading to higher and higher synthetic opioid overdoses in 2013. And I missed earlier, we might have already discussed this as well, but just a quick review of that. So as this is happening on a larger scale, neurobiological changes are happening within individuals. Opioid use leads to intoxications, and this is true for all substances, as opioids and substances are activating the brain's reward systems. Through motivational learning processes, the effects of substances trigger craving due to the dysregulation of those reward systems. Over time, ordinary healthful rewards like food or interacting with your child can be outweighed by drug-related rewards. So people then find themselves ignoring these ordinary pleasures and shift their focus to obtaining and using substances. Changes in the emotional regions of the brain result in this increased reactivity to stress. And as a result of these changes, individuals begin to take substances automatically as a way to relieve withdrawal and negative affect. This is why many people say that they don't like the substances, but they continue to take them anyway. And in addition to changes in this reward and emotional centers of the brain, changes occur in the areas of the brain related to executive functioning like self-regulation and decision-making. So I bring up this neuroscience perspective to emphasize that addiction is not a moral failure or a lack of willpower, but it is a brain disorder. So understanding the systemic dysregulation of brain networks can inform interventions for substance use disorder in the perinatal period and in general. The opioid epidemic has had significant effects on all people across our country, but today I'm going to draw particular attention to women and families. And though there are more men have died of opioid-related deaths, deaths among women have risen at more than twice the rate than that of men. This may be understood through the concept of telescoping, which states that though more men use substances than women, women progress towards substance use disorder at a much faster rate, requiring treatment and hospitalization earlier than men in the course of their their disorder. So there's a lot of information coming out right now about how hormones like estrogen may prime the women's development of substance use disorder. And I think this is going to be more and more important moving forward as we're talking about treatment really targeted for women in particular. So the opioid epidemic, or as more, let's say, so we know this is affecting everyone, but as more and more women of childbearing age use opioids, there are more effects on both mothers and babies. So here we can see this is the growing rate of opioid use at delivery. And as a result of that, we are seeing increased rates of neonatal opioid withdrawal syndrome and neonatal abstinence syndrome. So this is a connection of symptoms, a collection of symptoms that affects newborns, their gastrointestinal tract, the central nervous system. At the estimated cost of opioid exposure in utero is about $573 million in 2016, and it's growing. So although the long-term consequences of neonatal opioid withdrawal syndrome are largely unknown, many children are at higher risk for involvement in the child welfare system. And some of you might be involved working in the child welfare system and have seen this, of course, firsthand. Here in the state of Montana, we have one of the highest rates of removal from the home for children because of parental substance use. And of course, I'm not focusing specifically on alcohol here, but alcohol exposure in utero can lead to fetal alcohol syndrome, which can have lifelong effects for children and for families. So we often speak about opioid use in pregnancy, but as we're really beginning to focus more and more on methamphetamine use. And here you can see the rates of both opioid and amphetamine use at delivery in the Western United States in particular. This is between the years of 2004 and 2015. And this black solid line that you see here is representing amphetamine use at delivery. The dotted line is, and we're looking specifically, at the differences in the Western context, but also rural versus urban counties. So this dark line is the rate of amphetamine use in Western rural counties. The dotted black line there is the rate of amphetamine use in Western urban counties. The gray solid line is looking at opioid use in rural counties in the Western United States. And the dotted gray line is is opioid use in Western counties that are urban. So what I think is really interesting here is, though, this is use of amphetamines and opioids it increased from 2004 to 2015 in all parts of the United States. In the Western United States, you can see that it was the only area of the United States where amphetamines were actually a higher rate. And in all of these areas, you could see a difference between rural and urban counties. So there's a disproportionate rate of increase in substances in the rural areas. So I know this probably is also, for many of you working in this field, not surprising. But I think what is important to recognize is that these authors also found that amphetamine-related deliveries were associated with higher rates of preeclampsia, preterm delivery, and severe maternal morbidity and mortality. There are pharmacotherapy treatments for opioid use disorder, but there's not clear recommendations about medication. And please, for medical doctors, if you know something different than me, please feel free to chime in. But the recommendations aren't as clear for medication to treat methamphetamine use disorder. So one of the most challenging things working with the women at the clinic where we were is that for folks who were struggling with opioid use disorder, we had medications to offer. We felt like more treatment options to offer. And for women who were struggling with methamphetamine use, we didn't have the same tools, I felt like. And one thing to also recognize is for many of the women that we worked with, there was polysubstance use. So people were using both opioids and methamphetamine often. Something to keep in mind. So when talking about, So when talking about substance use in pregnancy, I think it's easy to feel discouraged and to think about the effects for women and for babies, for children. But I think that it's important to emphasize that there is hope. The pregnancy is an opportunity for change. And I wonder if generally people can experience increased motivation during this time. And I would think that maybe some of you who have worked with this group of people can think of those women who show up and, despite the fears that they have of accessing treatment, are incredibly motivated to provide the best opportunities for their child. And in fact, 83%, in one study, 83% of women, they were stopped using one illicit substance during pregnancy, and often without medical intervention. So our goal here as providers is to find a way to capitalize on that motivation during pregnancy. The World Health Organization has outlined 5 treatment guidelines, and I'm going to focus on 3 of those, beginning with talking about discrimination and stigma. And I know this whole day is going to be on this, but really, if you leave with anything, I think this is the most important thing to leave with. So women using opioids or substances during pregnancy may be viewed by some as selfish, unfit mothers. And if you have not had those maybe thoughts like this before, maybe you've already made the, despite the best efforts of our society to kind of send that message, it might be that you've already been able to shift your way of thinking, but you likely are still working with individuals who have this type of mindset. So the experiences of stigmatization can lead to internalized stigma, resulting in significant shame and guilt in women who are pregnant and also struggling with substance use. The experience of stigmatization can lead to chronic stress. It can exacerbate mental and physical health problems. And this view, when believed by healthcare professionals, can be especially detrimental to the well-being of mother and baby. Research has found that stigmatizing attitudes of medical providers can lead to punitive policies, which can deter women from seeking and continuing treatment. So I encourage you to think back on at the beginning of the presentation when I ask you to bring to mind a person that you've worked with. And I wonder if you can think about your own thoughts and feelings. How do you think your thoughts and feelings towards that patient or client might have affected your interaction with the patient? And do you think that these thoughts and feelings could inform or do already inform any policies at your work? So if it's not you personally who's experiencing this, I wonder if you can reflect back on, what it looks like in your work day to day with the people you're working with, and focusing on. And I think this pairs well with the earlier talk about what kind of policies you have in place in your workplace now that may be affected by stigma. And one that I encourage you to think about your own language. So one thing, if you can see like here on the slide here, we have common terms that have been used over time. And I know for me, I'm still working on my language as well. Language is a very powerful tool that we have as providers to help to destigmatize substance use disorder. Because many of the women that you may work with, they are already experiencing this internalized stigma and shame and grief potentially around their own use and the messages that they've received about substance use disorder, which haven't been that it is in fact a brain disorder, and a treatable brain disorder. So here, what I like about thinking about this different terminology is that the authors of this paper have provided sort of guidelines about what type of language, of course, is is going to be destigmatizing in the work that we do. And then there are some words like addict or alcoholic, substance abuser, opioid addict that might relapse, that might really fit with an individual's identity and fit with an individual's ideas about their own recovery. But as providers, are not supporting the destigmatization of this chronic brain disease, treatable brain disease. So, for instance, switching our language from addict to a person with a substance use disorder, a person struggling with substance use, is one way to destigmatize this brain disorder among our patients and clients, and also among our other coworkers as well, or the other people that we interact with in the work that we do. Another one is a move that I'm working on right now is thinking about moving from medication assisted treatment, which is use of not only medications like methadone and buprenorphine, but also behavioral health treatments like cognitive behavioral therapy. And my understanding is that there's movement in the community towards medication assisted recovery instead of treatment. So that's one that I'm working on. But I really liked this chart to kind of think about how the language feels like it's changing quickly. I don't know if you've experienced this as well, but how something small like the language we use can potentially help destigmatize substance use. So the next the guideline that the World Health Organization has provided is the use of universal screening for substance use. So this may or may not be appropriate in the context that you're working with women. But if we're thinking about healthcare context, potentially, the one place that you're going to meet in OBGYN offices, or you're going to have the opportunity to meet with many, many women and or do some early identification of substance use disorder and prevention. So one in the study that we're doing right now, and this it's a big health system intervention study, is to ask all women to complete the 5 Ps, which is just one screener. It's just one standardized screener, and ask these questions. So these questions are specific for pregnancy because of the fear of potential potential involvement in the child welfare system if you disclose that you're using substances during pregnancy, as well as in many states a real fear of being potentially like arrested for use in pregnancy. Not many. I think there's only still like a couple that go to that extent. But these questions like, do your parents have a problem? Your friends or peers have problems with alcohol or drug use? These types of questions are, I think can encourage people to talk about substance use in a way that feels less scary. So this is the one that we use. There's others like the NIDA assist tool. That can also be the CAGE, which is an alcohol, a brief assessment for alcohol use. This is just the one that we're using. But by asking all women about their history and their associations with substance use, this really builds an opportunity to have a conversation. So then this would lead into screening, after the screening, brief intervention and referral to treatment. So this is a system we're trying to put into place in our hospital setting, our clinic setting. And the goal here is for after being able to screen everyone, that you'll have an opportunity to do a brief intervention. I'm going to talk more about motivational interviewing briefly, but it looks like there is a great opportunity through Mono County to do more training on motivational interviewing if you feel led. So then you have maybe a brief intervention just to ask with the provider to ask, could you tell me a little bit about your substance use? Is that something I noticed here that you've had problems in the past? I wonder what that's like now. I just want to know, we ask all women this, and I want to know how to best support you during this pregnancy. And then that conversation might lead to an opportunity to refer to treatment. One thing we're doing in Montana in a rural setting is building a connection to a provider that can provide a pharmacotherapy like prescription for methadone or buprenorphine. Of course, methadone is more regulated, and you would need to go to a specific clinic to receive that. So we're hoping that most of our women will be able to be treated with buprenorphine because that you can treat on an outpatient basis. So the goal here is to universally screen, to have that brief conversation, and then to be able to refer to pharmacotherapy and behavioral health treatment. The provider we're working with the goal is to be able to do as much as we can virtually because of the limitations we run into being a very rural state. So there always is an opportunity to look more into residential treatment options. But I think it's very important to consider the barriers to residential treatment for women. Many women are working, and this would involve having to leave their job or take a leave of absence. And some women have other children that they're caring for and that they will need to have arrangements for. If your area is similar to ours, we have a very limited availability for inpatient treatment where you can also bring your other children. So there are many considerations when meeting with a woman to talk about. I know for me, sometimes that comes the urge to talk about residential treatment comes up, and I always talk about it with women, but also respect if it doesn't make sense for them at the time. So looking at this here, I also want to talk about the importance of case management and psychosocial support. Oftentimes women who are struggling with substance use may also be struggling with other things like housing was a significant one, or intimate partner violence, or generally a lack of resources. So ideally, we're able to assess the needs in all of these different dimensions and help connect women with the services they need. I know that this in practice can be very challenging, especially in rural areas where there aren't as many resources to connect to. This final guideline I want to talk about today is respect for patient autonomy. So overall, I think one of the most important things to take away from today is that what's good for mom is going to be good for baby. Not all the time, but generally what's good for mom is what's good for baby. So if we know that there are some risks to some treatments for moms. For instance, if a mother is being prescribed an antidepressant medication, there is some risk for withdrawal from the baby when they're born. But we also know that a mom that's as healthy mentally as she can be is going to be best prepared to care for her baby, and she's going to be best prepared to take care of herself during pregnancy. So though there might be some risks to consider, I guess this is a whole risk reduction conference, it's good to keep in mind that keeping mom as healthy as possible is going to be good for baby later on. So overall, whenever working with a mother who is pregnant and using substances, I think we have this in our country. Oftentimes there's an argument about who's going to make choices around when a mother is pregnant about her baby, and in these contexts, I encourage you to always ask permission to talk about substance use. And just in general, when thinking about also the high levels of trauma experienced by this group of women, to asking permission as you're moving forward and working with them and taking a motivational interviewing approach. So this would involve engaging, focusing, evoking, and planning with women. So the engaging I know many of you are very familiar with this. When engaging with a mom, using open-ended questions, affirmations, reflections, summarizing, taking that time to really see her situation from her perspective. But then as you're moving forward, working towards focusing on what is most important to her. So it might be that what you really want to talk about today is cutting back on substance use and maybe tobacco use. But what's most important to her today is talking about, as I think as a behavioral health provider, maybe what's most important is she really wants to talk about this feeling of loneliness she's having. And maybe that's where you start. It's giving permission, allowing for moms to start with what's most important to them, and also exploring and not being afraid to explore the ambiguity around making choices to cut back or to access certain resources or start certain interventions. And then, of course, evoking would be focusing on when a mom talks about her motivation to change, then focusing on that and evoking more of that talk, more of the reasons why she would be interested in making a change. And as you're moving towards the as you continue to work with this mom, doing more planning around how to move forward, how to address the barriers that are coming up, how to set goals, and to follow up. So one thing I want to acknowledge is that in the research and in practice, there's a lot of focus on the perinatal period, but a lot less focus on the postpartum period. So one study has found that 80% of women who were able to stop using an illicit substance in the last month of pregnancy, they resumed use of at least one substance within that first year after giving birth. And I know that for me, and there's limitations into how our healthcare systems work right now to be able to continue working with moms after they've given birth. We tend to kind of separate and have this OB specialty where women don't work with their OB provider after they have, often don't work with their OB provider after they've given birth. And so one of our most biggest challenges working with women is finding a provider that they could work with after they had their baby, when we weren't able to follow up with them. So I think there's a lot of opportunity to think about how we support moms and families during the postpartum period. So this is really a brief overview of maybe the kind of where we're at with the prevalence of substance use in pregnancy, and then just small ways about how to move forward. And this, I'm wondering about, there's the context of your community. Likely there's already a lot going on with, for instance, like where the harm reduction efforts that are already going on in your community. So if you will take a moment to think about, what's already going on in your community. How does this look in your community? What kinds of considerations or adaptations are important to thinking about addressing perinatal substance use in your community? One big thing that changed for me is moving to Montana from Salt Lake City. We had a lot of resources in Salt Lake City and a very comprehensive clinic and lots of different places to refer. In Montana, I've noticed there's just not the same level of resources, and there's a significant distance that people have to travel for care. So I know that this is going to be unique to your context as well. And then thinking about that patient or client that you brought to mind in the beginning of this talk, I wonder now, thinking back to that, is there anything, what would you want her to know? What would you want to say to her? And in an ideal world, what actions would you take, or what would be your approach to that client? So I want to offer, or really ask you all now, what questions or comments you have. Just want to open it up to questions to start a conversation.
Thank you, Sarah. And in case you just joined us, feel free to put in any questions that you have in the Q&A or raise your hand. If you're on a phone, that can be *9 and we can unmute you. Sarah, this talk is especially important for me with my work pre-COVID. I work for the health department, and my primary role prior to COVID was maternal, child, and adolescent health. And so it's an area that I think is really important. And I think I really appreciate your talk, because there are aspects of, screening questions where I find that maybe I'm not wording things appropriately, where I'm almost like asking the question, hoping that there's a no. And I'm not giving that opportunity or space for someone to talk about where they're at and for me to meet them where they're at. So appreciate you providing this talk to have that reminder.
And Jacinda, I'm so glad you bring that up, because I think there's a lot of discomfort talking about substance use in pregnancy. And I think part of that is like, ooh, what am I going to do afterwards? Do I have the resources? Where am I going to connect her to resources? So I know, for one thing, in our hospital setting, we're talking to providers about how to ask these questions. So it's easy to say, I've seen some medical assistants say, "You're not using any substances, right?" And not that you were saying that, but
it's like you kind of want a certain answer, so you ask it in a certain way, and it's like,
absolutely. And you don't want to offend people, So we train folks to say, we ask everyone this question, and also the screener we're using, I like it because it does. I think women are more likely to answer yes to some things about other people in their lives and maybe not about themselves. So thanks for being willing to talk about that, because it is just challenging to have these conversations sometimes.
Yeah, and I'm definitely going to be adapting those screening questions into our questionnaire, because I think that's good. Yeah, so it looks like we have a question in the Q&A. Thank you, Sarah. In your work, have you seen intersections with perinatal drug use and syphilis? California has seen an alarming increase in the rates of congenital syphilis.
I have not seen high rates of syphilis, but have seen high rates of hepatitis C. So I wonder, that's interesting. I wonder if that's going to start spreading, across the United States to different areas too. The doctor I worked with began more commonly doing labs to look for hepatitis C. That was one thing we did do. And I wonder if that would make sense for syphilis too. I'm not sure. But we did see high rates of hepatitis C, and as a result began to screen for everyone, because what a great opportunity to, in pregnancy, women are showing up to their medical appointments. And this is a great opportunity to say, there you are hepatitis positive or C positive, yes. And there's treatment for this. Like, let's get you hooked up with treatment while you also have insurance. So maybe it's the same for, I don't know how that would work in your context, but is there an opportunity to identify this need and then get people the treatment they need while they have insurance?
I know through the health department, we do have that opportunity to screen people if they would like. I mean, it's an optional screening of, Hep C to, we have syphilis, HIV testing, and chlamydia and gonorrhea testing. But I think it's about how to approach offering those screenings, because I find that it's very much, again, like a, no, I don't need that kind of response. And I want to work on how I can offer that. So then one feels like this is just a normal part of taking care of your health, and especially while you have insurance to take care of your health at this time. Any other questions or comments from the panelists?
I want to just thank you again for your presentation. It was very informative for me. It's a side I haven't got to see yet, mostly theory. But yeah, I just want to thank you, because I'm actually working with a person, a young lady who's in like around her 5th month of pregnancy, and I'm just trying to get her, like, I'm actually going to use those questions in my interaction with her, and go from there, and because I'm at this point, I'm trying to just, like, encourage her to go in, and I'm around people a lot, like more than I should safely be. But like in the work we do, like, I'm not gonna, if somebody's dying, and I'm not gonna stop and, oh well, what about COVID? It's just, it becomes secondary at that point, and that's happened recently. There's been a lot of overdoses in the last few weeks here. So, I know a couple weeks ago it was like 13. So yeah, I really appreciate that. I'm actually going to take that approach into my next interaction with the young lady.
Antonio, I appreciate you bringing that up, because I think it's helpful to acknowledge that there is a sense, I know for me as a social worker, a sense of urgency, wanting always with people you see struggling with this brain disorder, like wanting it is different for that, to be different for them. And it feels like sometimes that urgency escalates when it's a pregnant woman. So I think it's helpful to acknowledge, like, oh, we're on the 5th month, and I'm feeling kind of urgent about this. And to then again, like you said, kind of give it back to them and give them that autonomy, and just be there as a person to ask those questions. It can be a really tough position to be in. One thing I'm not addressing too, I'm acknowledging, is that there are different laws and regulations around, policies around referral to child welfare services, depending on which state you're in. So I feel lucky to be in states where there is not there's not a mandatory reporting law when women are pregnant. There is a mandatory reporting law when the baby has been born. So I'm having this moment of realizing, like, I'm actually not sure what California's law is. So that's one thing to, and maybe if we have any folks from Child Welfare Services, it would be great to hear from you all, or working as a mandatory reporter. That was one thing, conversations we had with the patients and clients we worked with early on, to be very clear about the when we do need to make a report. And that was when there was another child in the home, and there was a suspicion of child abuse or neglect. And then after the woman had the baby, if there were any like positive tests during their pregnancy, positive urine drug screens, then there would be a report at delivery. But we just talked with women about how to set everything up for if there were any involvement with DCFS at the time of delivery, to set everything up prior to that. And for women who are really struggling in the last months of pregnancy, we were very clear about what their options would likely be when they delivered. So if they were continuing to use substances illicitly in those last couple months, we were pretty clear about the fact that, like, so when we worked with moms, like in this situation before, these were the options. Someone in your family could assume custody of your child while you continue to work with DCFS. You might have the option. You will have the option to go to a residential treatment services with your child, because we had that to offer in where we were in Utah, and we're pretty clear, like, these are sort of this is how we've seen this move before. We encourage women to get involved with child services earlier, and to try to change the way of thinking about child services. So we had a group, our Department of Child and Family Services was well educated about substance use disorder, and they were really wanting to work with families, with moms and dads, to get all the resources that they needed, even before the baby was born. So anyway, as you were talking about this, Antonio, I was realizing like, oh, I did not address this big issue. So thank you for the work you're doing, and with this mom, but also with all of the people you're working with. It's important work.
All right, so I'm not seeing any more questions in the Q&A. Any other comments from the panelists before we take a break?
Sarah, I would just like to, thank you for coming on and, giving us a great presentation. I think what's important for our community is that we have a starting point, because we've done a lot to address the opioid crisis here. We've done a lot to try to help reduce stigma, get naloxone out there. So I think, one of the next areas that I would like to really focus on is this perinatal group, and how are we making sure that we're not marginalizing them or placing any more stigma or shame on them, and to, do the opposite and actually start creating better space for them to feel safe, loved, welcomed, no matter what, not just in the clinical setting, but in the community too, in all aspects. And so I think, one thing that's important for people that are viewing this right now is that, your presentation helps give us that equal footing. So we're all kind of just going to start building upon that too, and know that we have a direction and a goal in mind to work towards. So thank you.
And thank you, Sarah. And I think we'll take just I guess it'd be, I can't do math, but we'll meet back again at 10:55. And then our next speakers are Arlene and Marlise, and we'll introduce them then. So again, we'll meet back at 10:55.
And just thank you all for the work you do. And feel free to contact me if you have any questions.
Thanks so much, Sarah.
Sarah.
Take care.
All right, I think we'll get going again. And I'm going to hand it off to Antonio to introduce our next speakers.
Hello again. It's my pleasure to introduce the next speakers from the panel. Again, I want to introduce myself. My name is Tony Cardenas. I'm an MSW intern at Toyabe, currently doing my practicum there. So just want to give them a shout out real quick because I forgot to introduce myself as such. But yeah, so I want to introduce Arlene Brown and Marlise to you right now. And thanks.
Thank you, Antonio. Still on mute.
I double muted myself. Hopefully you can hear me now.
Yep.
Awesome. So Arlene, is it okay if I kick us off?
Yes, please.
Okay, wonderful. I'm going to share our presentation here. So just give me a moment as I pull that up. So Arlene and I were really fortunate to have the opportunity. Let's see here. We start from the beginning. So let me just back up here a moment and just start with, as I'm sure most of you know, there has been funding coming down from the federal government for states to apply for around the opioid epidemic. And so, of course, California has applied for that funding, and I have some more information about that as we move through the presentation. Did I do that? Okay. And so in doing so, we have, let's see, it's been about 3 years that we have been receiving this funding. And so for California, I am the project director for our state opioid response grant. And we get together as states and we share best practices, promising practices, areas where we have issues, things like that. But so the federal government asked us to do a presentation on our work with our tribal communities here in California. And so the presentation that Arlene and I are going to do for you today, we already did for all the other states. And so I'm just really, really proud of the work that we have been doing. And but I just wanted to kind of give you that backdrop. And I'm just really, really honored to be able to do this presentation again with Arlene. She personally really inspires me with the work that she does and the work that is occurring up north. And so with that, I'm going to just jump right in and go through the presentation. We're going to have plenty of time for questions for anybody, so feel free to ask us whatever you want. But so yeah, today I'm going to just start us off with some of the background and then also really highlight the projects that we're doing under our tribal MAT projects. I did just want to talk a little bit about some of the recommendations we've made for other states. I think it's really applicable, not just for other states, but anybody that wants to work with their tribal communities. And then Arlene is going to do our community spotlight and bring it home for us. All right. So our background here is, I really wanted to set the stage because our work with our tribal partners began before this funding that I mentioned that I'm going to talk a little bit more about. We've really started back in, it was about 2015, where maybe even 2014, we started working with our tribal community and started talking about the need to improve our substance use disorder services throughout California. We were putting together what's known as a waiver. And so this is for our Medicaid population. So in California, we call that Medi-Cal. And so what we did is a complete redesign. It's called our Drug Medi-Cal Organized Delivery System. But while we were doing that, we started talking to our tribal partners and really saw the need to do not only what we were doing with the ODS, but also really make it culturally specific and really look at the unique needs of our sovereign nations. And so what we did is we kicked off the ODS in 2015. It was phased because it was just such a big undertaking. So we phased it geographically across California. But then what we had started is what we called phase 5, is really looking at, once again, our tribal communities and how could we deliver services in a way that was really appropriate for that population. And so while we were doing this work, some of that first batch of money came down from the federal government around opioids. And so this has really been evolving as we've been moving along, and we've learned a tremendous amount along the way, which is, I think, really, really been beneficial for us to some of the work we're doing now, and then some of the work we're going to be doing in the future. And so I do just want to state, I mean, we have done a lot of collaborative work with our tribal partners and other stakeholders, and we have a lot more of that to do as well. And so while we were, oh my gosh, I'm clicking too fast. There we go. Sorry about that. I'm not going to touch my laptop. But so when we were working in developing our 1115 waiver, one thing that we really saw was just looking at the data, and I'm going to talk more and more about the data because I think it's a really important part of this whole story and how we move forward. But we definitely saw a need to, really look at the Indian health clinics, really look for our tribal and our urban clinics, really look at the data, what was happening there, how many folks were currently suffering from an opioid use disorder, but a substance use disorder in general. We've really picked apart, really needing to provide these services in a culturally sensitive way, but more than just culturally sensitive, I think sometimes we tend to look at that like, here's the services, and if we just put this lens on it, then everything's great. But really recognizing that was not the case, really looking at it quite differently. And so one of the things that we were doing as we were, looking at this benefit redesign, and like I mentioned, these opioid funds came through. We saw a need at the department that we really needed to set aside some of our opioid funds from the federal government and create the tribal MAT project. We had looked at a lot of our data. There were not a lot of the health clinics that were prescribing medication-assisted treatment. There was a lot of work to be done in the area of prevention and also recovery services. So some of the things that we really wanted to do in our tribal MAT project when we first kicked off was, of course, promote opioid safety. Like I mentioned, improve the availability of medication-assisted treatment, and then make sure that there was ample access to naloxone. And I'm sure you've seen these statistics, and these were, at the time, some of the statistics we were looking at, and we were really, really concerned about the opioid crisis in our Indian country. You can see here the overdose rates, how significantly larger they were for this population. And unfortunately, currently, while these figures have gone down, it is still quite concerning and alarming. So as I mentioned, we had these, really high overdose rates for the population. However, oh, come on, little button. Oh, now my thing is not moving. Oh, there we go.
I'm gonna say you're leaving us in suspense.
I know, sorry about that. And so we saw this data and obviously we're really concerned. We were doing a lot of these efforts, but what we really came, as you continue to peel back that onion, is the data does not even begin to capture the extent of the problem. We really learned from our partners that the AIAN folks, they're underrepresented. There's all kinds of issues around racial misclassification. There's also just miscounts of, some folks not wanting to, come forward, or even the coroner not wanting to, mark them that they were of a certain race or ethnicity. So we kept digging deeper. There is a study, and so here's some more information if you want to look into this further yourself. But there's a study from Washington that they suggest that this data is underestimated by approximately 40%. And then once again, this misclassification, you know, around this population. And so if you want to, you know, really, like I said, dig deeper, it's an opportunity for you. And here's a link, and you can engage your Tribal Epidemiology Center if you want to look at any of the supplemental data. But really the take-home message around this issue is we have a really, really high overdose rate here in California for our Native American population. However, it's much higher than the statistics are even reporting, which I'm sure for a lot of you, you already know this, but I don't know that everybody understands the extent of the issue. So I do want to spend a little bit of time today because I find it's really important. And I just want to say before I go into talking about tribal background, I am not an American Indian or Alaskan Native. And by all means, I am not the most qualified to be talking to you today about the tribal background. However, I do notice in speaking with many different stakeholder groups at local, county, state, federal levels, there's a lot of misunderstanding and a lot of just not understanding the background of our tribal partners. And so I feel I do a very big disservice if I don't spend a few minutes, even if there's just a few of you that don't know the background, because I think if you don't understand the background of these individuals, you're not going to be able to treat them effectively or prevent the use of not just opioids, but any substance. And so, you know, some of this, and I apologize if you do know this, but once again, I think it's just really important to reiterate. So state and tribal governments, we're both on equal grounds. We're both federally recognized. We are both political jurisdictions. We both have the same scope and authority. And so I think it's really, really important that you acknowledge that. So when you're working with your tribes, that you acknowledge that most likely you going to them, they're at a higher federally recognized, you know, political level than you are, and to honor them. We are, as a state in California, we're sovereign, that are, you know, it's all defined in the Constitution, everything that's laid out, but the same is true also for tribes. So we are on equal footing, and we have a government-to-government relationship. And so for tribal membership, there are treaties that were made years ago in exchange for land and peace. And so I have some of this listed out for you, just because once again, I think it's really important to know the history. And so there is the federal trust responsibility. There's all these treaties that I have listed out here. And then I think really importantly, in 1955, the Federal Indian Health Services was created and to oversee this whole treaty process and everything that was agreed to. And so in the nation, and I'm sure the statistic, because it was from a few months ago, has changed, but just to give you an idea, there were in September, 567 federally recognized tribes, plus 66 state recognized tribes in the United States. So another thing I think is super important to understand is what is an Indian healthcare provider? So there's 3 different types of Indian healthcare providers. There is the Indian Health Services, which I just mentioned. They actually operate some facilities, and I think I have some statistics later on, but in California, we actually just have one of these, and it's relatively new. It's down in Hemet, and it's a youth facility for substance use. They are actually going to be opening up one in Yolo County around Davis, so that'll be the second. There's also another type. It's a tribe or tribal organization. These are called, you'll hear them referred to a lot as Tribal 638 clinics. That 638 is actually just where it is in federal law. And so if you're wondering, where is that from? That's where I've discovered that it's from. And then we also have our urban Indian health organizations. So all three of these provider types are funded differently, but they all do serve this population. So there has been over time in talking in the nation, a trend towards the self-governance. So really moving out of the Indian health services and moving more into tribal clinics. Now, once again, like I mentioned in California, we're actually already pretty much mostly in the tribal 638 realm, but in other states, there's a lot of governance under Indian health services. So in California, we have almost 100 Indian healthcare providers. We have 83 Indian health service and tribal providers, but just like I mentioned, we only have one actual Indian health service provider. The rest are all those tribal 638s. And then we have 10 urban Indian health programs. And that's 30% of how many urban clinics that there are in the whole country. And so we have a really, really great opportunity in California. We have a lot of great representation of tribal services and a lot of really, really great clinics across our state here in California. Which is important because in California, we have the largest population of American Indian Alaska Natives living here within what we would consider California boundaries. That's 12% of in the nation. And then what's interesting is of this population, 88% live in urban areas and then 3% on reservations. So in California, of our 109 federally recognized tribes, there's also 78 tribes that are petitioning the federal government for recognition. And then there's 44 that lost the federal recognition. And so another thing I think is just really important to recognize is this is in flux. There's tribes that are, moving within and then without of this federal recognition. So the population before all the missions, the fur trading, gold rush, it was about 200,000. But between 1840 and 1870, the population decreased down to 12,000. And this was due to disease, removal, violence. And I think once again, this is a really, really important piece to think about, especially if you're working and serving this population, whether it be through prevention, treatment, or recovery activities, is there is a tremendous amount of historical trauma. And there is, while I've seen and I've heard some amazing presentations, and I would encourage you to really, study this, become educated about the historical trauma, especially if you're treating individuals. But also what I've seen is an incredible amount of resiliency. I have to say I've been working in this field for 19 years, and this is by far my favorite population and my most favorite people I've ever worked with before, from what they've taught me personally, and then also to see what they've been through and what they can accomplish. So before California, yes.
From a participant in the audience.
Thomas, go ahead.
Go right ahead.
Oh, I am sorry. I was typing and I unmuted.
Oh, okay.
No, were you trying to get me? But it's a great presentation. You got the mic. Really appreciate
Awesome.
it.
Oh, good. You're encouraging me along the way. I like it.
And your last statement really did touch me as well. So I'm glad that you're learning. I think those relationships are most beneficial when they are peer-based versus, so keep going.
Awesome. Wonderful. Thank you. So here is a map of, this is before California Indian, the territories, before pre-contact. And you'll see here just this beautiful map of the tribes and the areas where they lived. Once again, I think just really, really important to recognize. So what I want to do next is kind of walk through what we're doing with our tribal MAT project at DHCS. And so here are some of our partners that are helping lead out these efforts. I want to recognize that with every single one of these projects, they're led out by tribal members. And so, you know, we really at the state, once again, worked really collaboratively to see what was needed. We brought forward the experience that we had, but these decisions have been made by our tribal partners. And you're going to see they've done some really phenomenal work and some of the work that we're going to be continuing moving forward. So I'm really hoping from this part of the presentation, you're able to see where you may be able to connect in on some of these projects if you're interested. So with our CRIB and Sakui, so they are our partners that really, they help oversee the clinics for the urban clinics, and then also for the tribal clinics. And oversee is probably not a good word. They're really advocates and helping and assisting them. And so with both of these groups, they have been putting together community opioid campaigns, been doing naloxone distribution. They also each have what we've called MAT champions. So these are individuals, paid individuals that go out to the urban and tribal clinics, but not just even tribal clinics, but they could be working with the local governments there or with the first responders. They're teaching them about opioid prevention, misuse. They're distributing naloxone. They also have been doing local media or flyers. You'll see some of that. So, but really being the boots on the ground and being somebody that is, you know, the carrier of the information through various, you know, different parts of not just what I mentioned here, but even some of the other projects as well. And of course, we have these really great local opioid coalitions that we've been funding. We've also provided funding if they want to participate in already established opioid coalitions and want to do a project there. They've also started the California Indian Opioid Safety Coalition, which is statewide, which has been really phenomenal. But so this is just some of the work that's being done by CRIB and Sakui and will continue to be done. We did receive another 2 years of funding that we just kicked off in September. So this work will continue forward until September of 2022 at this point. So here's some of the materials. Had to share them. They're absolutely gorgeous. So these are some of the materials that are either placed in clinics themselves or anywhere in the community, depending on, you know, really looking at the prevention angle or treatment. And here's some more. And as you look at these, I just want to say too, like, I think one of the most important pieces of not just the MAT champions, but those that are working from CRIB and Sakui on this project, is really a lot of the one-to-one relationships. You'll see here the one about dispelling myths. You know, there is, as we all know, there's so much stigma around a substance use disorder. And then there's even more stigma around medication-assisted treatment. And then you have on top of that, you have, you know, a lot of cultural concerns with American Indians, Alaska Natives around medication in general. And so we've really been trying to do a lot of work around how medication-assisted treatment, you know, can work for the individual, and also naloxone as well, because that is a medication, but recognizing what naloxone can do and the importance of having that to reverse an overdose. So much work has been done with the tribes and with the urban clinics. And this is just one small display of some of that work. Another, like I previously mentioned, CRIB has created this tribal, you know, the local opioid coalition. So, I mean, they're doing all kinds of work through the coalition around Narcan trainings. We also have at the state, which I hope you already know about, a naloxone distribution project where anybody, any entity can apply You'll see here high schools, hospitals, county health departments. So while CRIB has naloxone that they can provide, we also, these same entities can come at the state level and get it, delivered to them if they need that. So I just want to emphasize that while we have these the tribal MAT projects, all of the other projects our tribal members are also welcome to be a part of. This is just specialized for them and really designed for them. So of course, with the local opioid coalition, they've built a lot of referral partnerships with their local sheriffs. We also have a really large project, and Arlene's going to talk a little bit about it. Our California Bridge, this is with our emergency departments. We also have created some increase in access with a project called our Hub and Spoke. So once again, just really continuing to link folks into the services, helping people understand what's available, and really helping to break through some of that stigma. So the next project I want to talk about is called Telewell, and I apologize. Excuse me, I'm so sorry. My allergies are getting me today. But it's called Telewell. And so this is where we have some actual services that are provided through, a lot of it through, and this is before COVID, but through telemedicine, through telehealth. And so, because not all of our tribes have health clinics, and so obviously there's individuals there that still need services, but you'll see here some of the work that's being done around prescribing, counseling, managing, case management. There's even some co-occurring psychiatry services, things like that. And really the whole goal of this project was just to increase the access, jumpstart that capacity, but making sure that it's done in a way that's really appropriate culturally for the population. There's also what we've called office hours, but this is where other individuals that are working at maybe starting MAT, or they have a patient that's on MAT, but having some consultation available for that. Educational webinars and have been done once again on all of these areas. Where it's not just a webinar, but really looking at a case, doing didactic work. And then also another part of this project that's been really awesome has been just really providing like at the clinic level technical support. So once again, getting that individual coaching, everybody's at a different level. They may be interested in providing MAT, but how do they, talk to their board about it, or their board already approved, but how do you establish protocols for the delivery of MAT? All those types of things. So this project provided over 16 different clinics, this type of really individualized TA. And then our next project is Project ECHO. So for those of you are probably familiar with Project ECHO, it started in New Mexico a long time ago, but it's basically a way for physicians to learn something new. And so they meet together about a topic. And so what we developed is, while there has been some Project ECHOs around MAT and opioid prescribing, we wanted one specifically for Natives. So this was developed by a Native member, by a Native that has the health background and education and understands the disease, but also understands the population. And so these are 60-minute virtual clinics. Once again, it's didactic in nature. There's a case, there's a facilitated discussion. There's, as you all know, there's lots of complexities with opioids, especially with our rise in methamphetamines and then using both. What do you do about marijuana? What about a pregnant woman? And then also what's great in this Project ECHO is really blending in those traditional healing and cultural practices as well. So we also have had a partnership with our Two Feathers Native American Family Services, and they really focused on looking at the youth population. They were working on a curriculum and really, once again, looking at that culturally appropriate service delivery. And then we also have been working with USC, and they developed our first in California tribal needs assessment for substance use disorders. And they're also evaluating this tribal MAT project as well. I think I have more slides about the needs assessment, so I'm not going to touch too much about that. But I would highly encourage you, if anything I've said is of any interest to you, that you go and read that. It gives such a beautiful background and history. It talks about all these projects as well. And then it gives you the data on the extent of the need around substance use disorders for this population. See, I knew I had a slide on it. So these are some of the statewide need assessment findings. You know, obviously a lot of these are probably very familiar, but needs around prevention and stigma, you know, obviously an increase in medication-assisted treatment, looking, you know, at developing culturally centered recovery programs, different levels of care where there's gaps in the systems. There's a really great section on policy recommendations. And then, of course, home insecurity, which is super important, because if somebody doesn't have stabilized housing, you know, that just adds to the issues around opioids, and then really great recommendations around harm reduction as well. So we asked for this to be developed because, once again, like I mentioned before, there were just a lot of gaps in the data. Even the data we had was concerning. So this, I was so impressed with the number of Native members that participated in the focus groups that provided data and information. And it just really showed how the community came together because they wanted to be a part of the solution. So once again, here's the link at the bottom of this slide. I highly recommend that you look at that. Really, really outstanding information in a really easy to digest manner that it's presented. So here's some of our accomplishments. I mean, I couldn't not talk about accomplishments. You'll see here by each of the projects, them listed out about how much naloxone has been going out, the opioid coalitions that I mentioned, how many webinars, how many, you know, patients have been served, all of those types of things. Really, really, really proud of the group and all of the different things that the group has put forward. So this says if funded. So I want to talk just briefly about what's coming up in the next 2 years. And it is funded. So this was back right before we got approval. So this is funded. So really, really excited. And you're going to see, I apologize, you keep going to see if funded, but it is. So what we wanted to do is we're going to continue the work that we've done in our first tribal MAT project, but now we're calling this 2.0. And really improving upon what we learned from the needs assessment, and what we've learned from our partners and those, you know, that are being served. So we've created this really awesome opportunity called Tribal Community Defined Best Practices. And I can't wait to kick this one off. It's going to be putting money where our mouth is of implementing traditional healing within the health program. And so that's being established, and an RFA is going to go out for that for clinics to be able to participate in. We're also having a tribal MAT learning community where we're really focusing and offering medication-assisted treatment, but once again, not just us trying to shove a Western philosophy onto our tribal partners, but really in a culturally centered approach. And then we're going to kick off a California Indian harm reduction work group and really, once again, look at harm reduction, but through a Native lens. And we're also really going to be beefing up and looking more at the data that we have, you know, and looking at data fidelity, you know, and then what are the gaps, once again, in that? But with the data that we have, what is it telling us? We'll continue to have a lot of policy training opportunities, advocacy. The department right now is going to be putting out in the next few weeks some guidance pertaining to Indian healthcare providers and substance use disorder services. And so we want to be able to make sure that clinics understand, what does this mean for us? But so really creating those bridges of understanding. And then of course, reaching out and continuing to with our providers, making sure they understand, you know, medication-assisted treatment and not just medication-assisted treatment. What's really, really exciting about this new 2.0 is we're also able to offer treatment and education around stimulant use. So super, super exciting about that. So that'll be woven through all of our projects. So really quick, I do just want to spend just a moment, because I don't want to suck up all of Arlene's time, but some engagement strategies. So I get asked a lot, oh my gosh, how do you work so, you know, with your tribes? I don't, you know, we try and da 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 da. And I really think, and I have some tips here, but I think it's all about relationship building. You know, in taking the time, in my role at the department, I'm on a pretty fast track, fast pace, and I think we all are. So many meetings, got places to be, and you know, I just want to credit the partners that I've worked with that have really helped me learn how to slow down when working with tribes. I went to a lot of any invitation I was given, I came to. You know, I was so excited. I went out to the opening of that youth facility I talked about in Hemet. That was phenomenal to see. Lots of meetings, lots of time together. And I also had to really work at putting aside what I thought the solution was. And so really, really learned so much. But mostly, I think what was helpful was I feel like the partners that I started working with, they trusted me and they helped guide me. I'm prone sometimes to fall into a hole and they'd like rescue me out if I'd already fallen in or before I stepped into it. But really, we established some great relationships together and trust. And I think that's what's really helped. And quite honestly, I feel like my role has been so small. They had the ideas, they knew the connections. I just did my piece of it and they just made some amazing things happen. But so, yeah, so just if you're looking to increase your, you know, relationship with your local tribes or your clinics, you know, of course, you know, if you're invited somewhere, go. And if you're not invited, you know, make the first move to get to know them. Also, of course, relaying any major developments as soon as possible, whatever the case may be. Maybe you're working with, you know, a tribal member and somehow maybe you're working with someone locally there and you have some things that you need to talk to them about, but the sooner the better, and give them time. They're very thoughtful people, and they really engage so well. Communication is so important to them. And once again, making sure that they're the experts on the tribal values and culture. And if you're not a tribal member, you're not, and that's okay. They are, they know what to do. And then I rely on the stakeholders to disseminate the information or the messaging or whoever it is that you're working with at that local level, because they're far better message carriers than you probably might be, or for me, at least in my case. These are just some ideas that I've also talked to our tribal partners with. And so I'm always encouraging them to bring their key players to the table, bring their ideas for projects, or if they have funding requests, recognizing that we don't really, at the state level, we have a lot of experience working with counties, but we don't have, our experience is pretty minimal when it comes to our Indian health care programs. So anyway, just wanted to share this with you as well, in case you're one of our tribal partners and things that you want to or have ideas on how to engage with the state partners. And I do just want to pause here really quick and just also state, speaking back again about our partners with Crib and Sakui, you know, we know, at least from my lens, because that's all I can really speak to, is I grew up with states as boundaries, but that's not what it is at all for our tribal partners. We have tribal nations that go across states, and they have a really neat network of national tribal events. It's something that I've been really excited to see and hear about is like members from Crib and Sakui and other tribal partners that take the relationship that we've been building together and sharing that with other states as well. And ultimately with the goal of helping anybody with a substance use disorder get the help they need. So it's been really, really fun to see how well they're teaching some of their other partners that live in areas that are located in other states as well. So I'm not going to talk about other states. I think most of us here are from California. And with that, I've talked a whole bunch. So I hope that this was helpful for you. What I want to do right now is turn it over to Arlene, because what Arlene's going to do is make sense of everything I just said, because she's going to explain to you how it's been happening at the local level. And so with that, Arlene, I am more than happy to push your slides forward. Just let me know when you need a next slide, and I'll turn it over to Arlene.
Thank you. My name is Arlene Brown. I'm a recovery support navigator for Northern Inyo Hospital Healthcare District at the Rural Health Clinic. I'm also a member of the Bishop Paiute Tribe, and I'm also a vice chairwoman of Bakersfield American Indian Health Project. Marlies, thank you for the great presentation. I think it's amazing to me to see how funding can be distributed when we kind of recognize the fact that we are working with, you know, sovereign to sovereign government relationships, and that we need to always have seats at the table about the funding, about, you know, the big critical decisions. When I first did this presentation, it was with Tyler Sadewith, and it was, you know, pretty awesome to kind of see where and how this funding kind of came from and how it got created. You know, I think for me, it's a great example of how other funding organizations can kind of replicate that idea of making sure that, you know, people have their voice in the decision making. And so without further ado, I was asked to do this presentation, and it is an honor just because they highlighted Inyo County for the work that has gone on specifically here, and kind of bringing all of the funding and different services into play. And I have a really unique position to where I've done TMAT funding for Bakersfield. And so I've worked with Sakui, and then have done TMAT funding here. And so I've worked with Crib on the rural aspect of it. And I still have a part to play in both of those. And so in 2018, we applied for funding for to start the Tribal Local Opioid Coalition. That started in 2019, and to see where this has come from. So a little backstory. None of these things were happening in 2018. There wasn't tribal MAT, there wasn't implementation in the jail, there wasn't a recovery support navigator at the hospital, and there wasn't the bridge program there. And actually, there wasn't much discussion about what was happening in our local area about the opioid crisis, and kind of what service providers were addressing it and how they were addressing it, and what was happening. And so, so to come from 2018, the fall of 2018, where nothing was being really addressed in that sense, and then to come all the way, you know, in just a short time, and to have all these services, and you know, we still have a long ways to go, but to have all these services in place is pretty amazing to me. So the hospital applied for an ED Bridge grant, and when they received it, they were able to hire a recovery support navigator. And Marlies, I seen in your slide you put a son / recovery support navigator. And that was something that the hospital had done to change the term from substance use navigator to make my position a recovery support navigator to kind of help destigmatize that. But ED Bridge is magnificent in the fact that they've really changed the narrative throughout California and getting services right there in the emergency room for people who go and present there, who have overdosed, who are seeking treatment and help. And so they have really done a lot of work on, and actually are still doing a lot of work on destigmatizing services in the ED. And I forgot how many sons they have now, but they're in a lot of the emergency departments throughout California. So it's been a really neat program to be kind of part of and to be connected with all of the other ED Bridge hospitals. And then to be part of all of that has been pretty phenomenal to see too, and learn from other hospitals and providers and what they're doing. And then also Inyo County had received the grant to implement MAT in the jail. They were in that second wave. And what that meant was that they were going to kind of pilot getting people started on Suboxone or Bupe in the jail while incarcerated. And so it's been, pretty cool to be part of that because we've worked directly with the jail. If patients go into the jail system, we're able to work with them, the nurses there. If somebody gets started and in there and it's identified that they want to be on medication assisted treatment, then we're able to continue that when they get out. The hospital will actually go and pick up people from the jail when they will coordinate appointment times. We've gone and transported and picked up people right from release and brought them right to the clinic to be able to help provide that continuity of care. And we've also done Zoom meetings where we're able to meet people while they're still incarcerated, and then get that relationship and that connection going. And then when they get released, then we're able to continue that, but they're able to have an interaction and a conversation. One of our MAT champions at the hospital, one of the doctors, she's actually been on the meetings with me to meet people that are currently incarcerated in county jail, just to meet with them and say, hey, I'm after you're going to see when you get out. And so we kind of have been able to kind of bridge that piece of it. We've also I know, most people know that the prison system, they've already, released a lot of inmates, but prior to that, they were getting ready. When they were getting ready to do that, they started working with a company that was getting people plugged into services prior to them leaving. And so it's been really neat to be able to be part of that, because if it's identified in the prison system that they're going to need Suboxone or addiction services when they get out, then that company is able to call us and we're able to release, do some waivers and start working with them and get their appointment time set up. So when they get home, they're already plugged in and they know where they're going. And so that has been a, really neat aspect of kind of how this funding has all worked together too. I would say that we've had over 35 successful naloxone deployments. And, in 2018 in Inyo County, you couldn't get Narcan. It was only given to you at the pharmacy. People didn't know about it. The community didn't know about it. And it was really, it was a barrier to have to go to the pharmacy, for some people. And, for some people it was okay, but for others, it was a barrier. And we didn't have community access to the naloxone here. And so, and now we do. And so for the, simple fact that I know that there's over 35 people walking around right now, and they wouldn't be here if we didn't have the naloxone in the community. And so, I'm glad that we're able to talk about that. And, and the job's never over there. We still need to get naloxone out there. We still need to educate people. We need to get, it in every home. I'll be happy when every home and every person knows about Narcan, is carrying Narcan, and, advocates for it. So I know that this funding has looked different in all the communities, that it's touched. But, like I said, this is kind of how this funding has played out in our local area, in our community. Is what's on the next slide? So just some of the things that we've done, and to kind of deconstruct and put more of like a native spin on that. We have done, so one of our local beaters beaded that around, and some of our providers, wear these with their name badges. Bakersfield, they did a lot of different things too. They have the name badges as well, the beaded ones, and then they made shirts and sweaters and overdose kits, with some of their funding, and some of the things that we've done also locally has, we've done a tribal proclamation. So on August 31st, which is National Overdose Awareness Day, we came together as a community and we did a Narcan drive-through event. And so we served food. We came out, they provided lock boxes. They helped distribute the naloxone. The hospital had ice chests and food, and shirts and all kinds of things. We handed out over 200 overdose kits that day. The Bishop Paiute tribe did a proclamation, and we had the radio station there broadcasting it live. We ran out of food. We ran out of overdose reversal kits. And so we had to go run down and get more boxes of Narcan to hand out. And like I said, I know we got over 200 overdose reversal kits out that day. And in turn, Bakersfield got to do the same event where they did a drive-through. And then from that, Taft went and did a drive-through event. So, that's why I said it's really, I'm in this unique position to be able to see the rural and then in the urban parts of it and how this kind of plays out for our communities. I can't remember if there's one more slide after this one. I think that was the last one. So just some of those key messages, and I know Marley's kind of talked about that too, but really integrating that sovereignty and that cultural aspect. I really appreciate the fact that Robin came on earlier and spoke about, kind of that balance and that struggle between like a system that tells us how we're going to do something. Marley's talked about, this Western philosophy of, this is how we do things, and how we change that though to making it our own narrative and to bringing the medication assisted treatment in our own way, and developing that and bringing that, that making it our own. We have to have our own spiritual leaders and healers in the community that come and be part of this. We have our own unique recovery ecosystems that we really have to be able to integrate all of these different things, our different cultural values, our traditions, and education. I hope that more board members, more tribal leaders throughout the state and throughout the country are able to kind of see how, this funding could help make things their own, and really implement because that's the true sustainability of the funding is, empowering the communities to, have their own way to do things and develop everything. And I think, everybody is totally different of where they're at with their understanding of harm reduction. There's communities that, don't have needle exchanges. There's communities that still don't have access to Narcan. There's communities that, aren't where we're at. And so, I feel fortunate, even though I know we have more work to do. I know we've come a really long way as a community to get a lot of different things in place here. And so the resources are here. People can get Narcan at 10:30 at night in our community. They don't have to go to the pharmacy. We have the connections, meaning we have medication assisted treatment. We have things happening in the emergency department for people when they need services. And so, we have connections with the probation officers and the district attorney's office and with the jail itself. And, for me, that's the best possible outcome, is that we're all working to get people where they want to be and where they need to be. And so that's kind of been, a really neat aspect of all of this as well. So. Any questions?
I had a comment. I just wanted to thank you both again for highlighting that. It's like, and Marlise, that's like a dream come true to see all that. It's something that Arlene and I have been conceptualizing since 2018. And one of the events that kicked everything into gear was my younger sister had overdosed in Mono County and passed away. And I didn't know what to do. Arlene had a she was pretty passionate about what was going on at the time, and that was kind of the catalyst for getting the Narcan out there and trying to destigmatize and changing the way we look at things, and to kind of a little bit of backdrop on that, and then into now where we're talking about indigenous epistemology guiding our approaches, and like privileging native ways of knowing, indigenous ways of knowing, not necessarily over Western medicine, but having them come together and work together, but also the issue that you both raised of cultural humility when dealing with this population, as it is a very at-risk population in the context of OUDs. So I really appreciate that information again, and I'm just glad that it's nice to know that other tribal communities and at the state and agencies at the state level are recognizing this trend. But I just thank you both again.
Thank you, Antonio, for sharing that. And yeah, there's Antonio and I have a really big story to share. One of these days we'll get that story out there, but a lot of the things that have happened here was because he wasn't going to he wanted change, and he wasn't going to accept the fact that he lost his baby sister, and what was being done about it. And I wasn't working in the field of addictions. I was a cultural and family coordinator, but I have over 15 years of working in addictions. I know harm reduction, and I know my tribal people too. And so when I found that out and I heard what had happened, and then I was like, God, what is happening? Like, who is talking about this? Nobody's doing nothing. And it was really just a moment of like stopping and looking at what was going on in the community, and knowing that not just our tribal community, but our community in general is suffering in silence. The services weren't there, and like I said, I know that people didn't have access to Narcan, unless they went to the pharmacy. And so, that was like one of the first things we did was, Crib actually helped get the Narcan here. And they said, yeah, we'll bring Narcan up, when you need it and stuff. And like, no, we need the ability to distribute Narcan whenever we need to distribute Narcan. And Crib was, awesome in responding to, they're like, oh yeah, that's right. We'll get the Narcan, up there, and we'll get people trained. And, and it's just been, one thing after another and of happening. And so then I ended up working for the hospital, and, and it's just hasn't stopped. And, I know more good things will come, and, but like I said, I know there's a lot more work to do. So somebody had a
And I
question.
just want to thank, before we jump to the question, I just want to thank you, Antonio, for sharing. And my heart goes out to you for your loss. But I want to commend you that you took that grief and you guys made this happen. And for me, that's such an honor, because in my position, we can create policies, we have funding available, but it's just going to fall flat if folks, like yourself and Arlene and others of you that are participants today. It's you guys are the ones that make all of this happen, and not just this work here that Arlene and I were talking about, but the work for individuals to either prevent suffering or to help those that are suffering. And so I just want to commend you because it makes my heart warm to see, that's my passion, is to help individuals. And but you guys just do such incredible work. So I just want to thank you. And I want to encourage all of you as well. This work is tough. It's tiring. We have COVID now that we've had to deal with as well. But I want to thank you for not giving up. And I think it's important to every once in a while stop and celebrate the successes that have happened. And then we, tie our bootstraps a little tighter and we keep moving forward. But Antonio, I do want to sincerely thank you for sharing that today. And I hope we can prevent future situations like your sister.
We have a question from Thomas Noble. Thomas,
Hey there. Yeah, thank you. Yeah, I appreciate you as well, Antonio, sharing the loss of your sister and putting that into the space. I actually live in San Francisco, and a lot of folks are actually coming here for recovery services. And in the dialogue with them is the concept of either being a mix of some sort and not quite fitting into either world, and that stressor, and then the substance use and being in their community, wherever it is in the state of California, kind of the intersectionality of those two pieces, and then the levels of shame that people are facing with not being able to step into the space of quote unquote, getting clean. It's interesting just to hear these stories and realize how common they are throughout the state, and the connection that we have with the rural counties. And there's loss of life, and then there's this loss of community that individuals are feeling that they can't go back to their communities because of the level of shame and stigma that they are kind of carrying with them back into those spaces. And then the cycle kind of adding into it with regards to the substance use, addressing that level of stigma and loss is just critical to kind of getting it through the day to day. So I just want to put that out into the space as well. And it's loss of life, but then there seems to be all these additional losses that are combined with either internal or external racism, combined with the shame around substance use.
Thank you. Yeah, absolutely. I think, we've dealt a lot with, especially in the American Indian community, we're no stranger to what stigma, discrimination feels like, and even, hopelessness, lateral oppression, historical trauma. There's, a lot of different things that kind of come up, right? And the shame and stigma, that was kind of been one of the biggest things that try to address and put into practice is, discrimination kills people, and stigma is nothing but discrimination. And so, I know that there's people that won't go and get help out there because they feel stigmatized. They feel like they're going to get talked about. So there's a sense, there's a loss there when people won't even go in the door for treatment or for help, just based on the fact that, and even creating that internal stigma. So not only do they have external stigma that they have to face, they have to, endure the internal stigma of what that's done too. So.
Sorry, I didn't mean to bring the room down, or it's just so intense. So I very much am impressed by the day so far, though. So just to put it out in the work that you all are doing is hopeful.
I also really appreciated, Marlise, when you spoke about the crucial role that your key stakeholders had in, the process of you getting acclimated to the issues that are going on. And that's another thing that I've thought about this entire trip, no pun intended, but in trying to find those champions, those key stakeholders, people who have lived the experience, because we know that change doesn't come from the top down. It starts from the bottom up, and bring in people who are suffering to the table to find out what they need, and, before I understood the concept of positionality, I always considered what my potential biases were, and like, how am I going to react to this? Or how am I going to be a good therapist? How's my practice going to look regarding this? And I think that having that, for your research minded folks, having that gatekeeper is essential, especially at this time right now where, the communication and the connection is, it's like a thing of the past right now, especially with, everything spiking and the presenting issues, the barriers to getting out there and finding out what's really going on. I think that's still like a huge struggle. And I want to thank you, Marlise, for highlighting that.
Yeah, and I think what's really great is, and something I've seen that this project in particular has showed me is there's a lot of amazing champions out there with this work in particular, and substance use disorders in general. I think the challenge is making those connections. And I know as we continue our work at the state level, that's something because this is just one of our projects. With our opioid work, we have 30. Now this one is actually my favorite. Don't tell anyone else. But we have all these other, and Arlene talked about a lot of them. But that's something we've been continuing to think about. How do we, because we're doing work in the jails and the hospitals with our tribal partners, how do we connect people together at the local level? So then, because you're right, this work is tough, and it's, you didn't bring the room down earlier. It's reality. This is where we're at, but there are these amazing champions, and how do we all find each other? And so that's something we're going to continue to work on from our level at the state, is how do we continue to connect people together in their local communities? Because this funding won't last forever. And we're also looking at how do we sustain some of the work that we're doing. I know we're looking at it from the department lens, because we do oversee Medi-Cal, and that's part of it. I also oversee some other federal funding, but like, how do we keep going with what we're doing so we can make these differences? Because someone said it earlier about, it's not just the overdoses, it's the communities that are fractured, and it's the dang stigma that just drives me insane. But I think it's, once again, it's we're making progress. We got ways to go. But how do we, we really at the state level have wanted to, whatever we build, be continuing to make it sustainable. So it's not just like a flash in the pan and then gone when the federal funds stop. So that's something I'm committing to at my level. And I have other team members at my level, and I know community partners as well. But I think that's what's super important is as we build these things, that we do look for the long term. So.
Thank you, Arlene and Marlies. Great presentation. I'll just give a few seconds just to see if there's any more questions. Please type them into the Q&A. And any other comments from the panelists or questions? All right, so I think we'll break for lunch. We come back at 1 o'clock. Yeah, 1 o'clock, and that's our community panel. And then we have Rachel McLean and then Jessica Smith that will speak in the afternoon, and then we'll close. We have a kind of open discussion time from 4 to 5. So please come back, and we are recording this. So if you are unable to attend all of these sessions, then you can watch them later. All right, thank you so much. Have a good lunch. Hey everyone, welcome back. Hope you had a good lunch. The next section is our community panel. I'm just going to give a couple more minutes just to make sure everyone's here and gives people some time to get back into the Zoom meeting. Arlene, would you like to introduce our community panelists?
Yeah, can I have just one more minute? I'm actually I'm gonna retype an email address for you. Just in
Okay, sounds good.
Thanks. Sorry guys, just one more minute. So Jacinda, hopefully that email address will work. Hi, everyone. Oh, go ahead, Jacinda.
I was just going to say I just resent it.
Okay, perfect. Thanks. Hi, everyone. Welcome back. We are just waiting on one other panelist, but we can definitely go ahead and get started with our next section. And this panel is about stigma and kind of barriers and kind of getting to know community members as well. And so the people here are community members, and they're going to give a little bit about their testimony, their story, and then we'll ask them each questions, and then we'll come back together after that. So I'm going to go ahead. Right now, we have Alicia Baumgartner on and Antonio Cardenas, and we're waiting for one other person. And so when he jumps on, then we'll go ahead and introduce him, but we can go ahead and start with Alicia.
Hi. Can you hear me okay?
Perfect.
All right, awesome. I'm in my car, just got on my break from lunch. But anyways, my name is Alicia Baumgartner. I'm 28 years old. I've lived in Bishop most of my life. My addiction started when I was about 13 years old. And it started out with alcohol addiction, and then it went into other substances. And I currently have 14 months clean and sober. I've gone through a couple rehab programs, and in February, last February, my son was actually taken into state custody because of my addiction, and it's just been a long, hard battle, but I'm grateful for the community and for everybody on this panel today who have just been speaking. And I really relate to a lot of it. So I want to say thank you. So the last program that I went to, I was in there 4 months when my son was taken. So the last half of my program was spent dealing with CPS and all of that. And I had just a really hard caseworker that really looked at me as an addict and looked at me as, you know, no good, and really judged me by my past. And it was pretty difficult to get through. And I recently just moved back to Bishop and I joined the MAT program, and I'm really grateful for that program. They always encourage me, and they always, you know, ask me, how can we help? And they ask me, you know, how are you doing? And really want to get to know me and know where I'm at. And instead of looking at me as where I came from, they look at me where I'm going. And it's just really encouraging. And it's just been a blessing. And currently I'm working in healthcare. I'm an in-home health caregiver. And again, I have 14 months clean and sober. So that's a huge blessing. And I'm a Celebrate Recovery leader here in Bishop, California, as well as a youth group leader at our local church. And just really blessed to be able to use my life and my story to help others. And just really grateful to be a part of this today.
Thank you, Alicia. Antonio, do you want to introduce yourself next?
Sure. My name's Antonio Cardenas. Everybody knows me as Tony. You can call me either or, it's fine. Antonio's my government name though. But yeah, I just wanted to share, I'm from Bishop, California, grew up on the res, spent the larger part of my life incarcerated due to substance abuse issues. I was hooked on meth. And so, yeah, that landed me, basically a direct consequence of my substance abuse was incarceration since 1988. I'm 44 years old now. I've been sober for 7 years, 7.5 years now, from all substances, illegal ones for sure. I went through, you know, losing my child. Well, I was the non-offending parent, but I ran into, after I got sober about 7 years ago, I was in Bakersfield. I had to leave the area, and I also had Hep C. I had contracted while sharing needles inside of prison. So I had contracted Hep C and didn't want to reach out for any help around here. You know, I just figured that, you know, if somebody knows at Toyabe, then they're going to know, you know, that about my personal health issues. So there was no correlation, you know, about anything at the time. So I wanted to be a drug counselor, and the college that I was looking at didn't have a drug counseling program. So I said, what's the closest thing? They said sociology. I said, cool. I studied sociology for the last 4 years of my life, fell in love with it, realized a lot of structural things that have been happening over the short history of this country that have led to the disparities in which I now face privately. So that was a huge motivating factor in my recovery thus far. It has been academia, and finding out why we do the things that we do, and not having an opinion otherwise, you know, just observing. I'm observing life from a different lens now, and I'm very grateful for it in my recovery. I'm back in the area. Just wanted to, you know, I'm kind of limited in my time right now in my role due to school. I'm a grad student at the University of Montana School of Social Work. Sarah's, you know, a colleague, and my professor. I don't even call her professor. They don't use names like that there. But yeah, I just don't want to monopolize too much time, but that's a kind of a quick story. And here I am at Toyabe, grateful to be here today. A little nervous, but I just wanted to share a little bit of my story with you. Thanks.
Thank you, Tony. And then our third panelist just joined, Stephen Dondero. And Stephen, we're just going around. I'll ask a few questions, but right now we're just doing some introductions and kind of a brief testimony.
Okay, can you hear me?
Yep.
Okay,
Hear you.
see me? All right, my name is Stephen Dondero, age 44. Just got out of prison probably about 4 months ago, was in rehab. I've got like 3 days sober. If it- Tony, if it weren't for Tony and Arlene reaching out to help me through this, I probably would end up back in prison. So I'm really, really grateful for Tony and Arlene. You know, I don't know what to say. You know, I chose to go back out and use, and I don't want to hit that hard spot again. You know, I don't want to go back to the joint. I want to be there for my grandkids and my family. And this summer I had the opportunity to really get to know my grandson on a sober note. Up until 2 months ago, I started using and drinking, and really put a damper on that relationship. And I really want to get to know that little boy in a healthy light. So I'm reaching out to you guys for help. You know, I appreciate all the help you've given me. I don't know what to say. You know, I went out and started using meth, and things get crazy, and man, I just need help, bro. And I'm grateful for you, Arlene, and all this. If it weren't for you guys, I'd be out there in the streets still messing around, you know, out there, you know, trying to figure it out. So I appreciate everything that you guys do and that you stand for. You know, really means everything to me. And I'm looking forward to getting back into rehab. I'm headed down to Changing Spirits, and just looking at getting better. You know, I had a little taste of sobriety, little 3 years, and it was awesome. You know, and I went back and screwed that up, but I believe that I can have that again. And I got hope. Arlene, that woman gave me hope. You know, she gives me hope. She's helping me. I can't even barely this morning for me a big chore was getting up to shave my face, you know. And she's helping. She lined it all out for me to get back to rehab, you know. I appreciate that, man. I'm lost, bro. I need help. I'm grateful for the 3 days of sobriety I have, and I'm grateful for you, Tony, stopping by the Changing Jason's retreat, helping me out too. You know, encouraging me. If it weren't for people like you, I'd be real lost, man. I just appreciate it. Excuse my sniveling, you know, but I appreciate it. I appreciate you guys greatly. And that's all I got. Thank you guys. You guys got a whole different way of looking at addiction and stuff, and I wouldn't sit here. I'm not ashamed. I'm hurt. You know, I hurt myself with this, and you guys helped me to realize that it is better, and I am worthy. So I appreciate that very much. Thank you guys. Signing off.
Thank you.
No, hang on, Stephen. Hang on.
Hold up.
Yeah.
Hold on. You
Now we
can't
got
bail on
question
us
time.
yet.
Hold on. Have my person fix my makeup real quick.
Yep. Your mascara's running.
All right. Okay.
I didn't know it was gonna get this real in here.
You know,
I appreciate you, man. Like known you since day one.
Yeah.
Of life, pretty much. You know.
Yeah.
Same age,
Yeah,
same school, same grade. You know, I'm just so thankful that you're here today and you're sharing. You honor me. You know, you're my people.
Yeah.
Yeah, I'm very encouraged. You help me out just as much, if not more, than you say I help you. I'll tell you that right now. You're a big piece of my life. There's new things happening to help us get through this, and you're the beneficiary of some of the first efforts ever.
Yeah.
Area.
I'm
So
grateful.
I'm really, really happy for you. And I'm glad that you decided to reach out and doing what you're doing. You're a strong brother, man. We need you.
Yeah. That all that nonsense makes me weak. Well, all that alcohol and drugs makes me real weak. So I'm looking forward to getting strong again, brother.
Yeah, thank you. And thank you, Alicia, for sharing as well.
Yeah. Thanks, Tony.
Awesome story. And thanks, Arlene.
Thank you guys. Yeah, I mean, you guys are getting to see some of the real work that goes on behind the scenes unfold kind of right now in the midst of it. Stephen, you know, I am addressing you specifically right now because of the courage it takes to have 3 days of sobriety. And, I'd asked Stephen if he wanted to come on, and no hesitation for him to help when I've asked him to help too and stuff. And, so it's been, yeah, I'm super grateful. And, there's a lot of gratitude that you're here walking this journey with us. I think, this is where our approach and our whole, connectivity with the people is right here with everybody. And, we have that. I know, Antonio, I know you never met Alicia. I know Alicia very well, and, amazing person, too, who's had to, overcome a lot of things and barriers that have been imposed on her by a system that judged her and put barriers up in front of her. And she, was like, I'm going to get through this with God's grace, and walk through this and get it done and do what I need to do, because she has a goal too. She's got some other goals in mind as well. So, it's definitely an honor and privilege. And, and same thing for Antonio, you're, part of this panel too. But, what an amazing story that you have, and how powerful your voice is, and, the way you can advocate now and make a difference. And, I've watched him make a difference in a lot of people's lives. And he may not even have realized it, but he's definitely has done that. Part of our panel is there's, several questions, and they really just relate to stigma and barriers that people have faced at certain times. And one of the questions is, have you ever experienced stigma around addiction, such as discrimination, judgment, shame? And, if so, how has that impacted you, maybe prevented you from getting help? But if you wouldn't mind, and I don't, mind who wants to go first, but.
Me? You want me to go first?
Anyone could go first.
Oh. You want me to go first? Oh, there we go.
Let's
All
Alicia.
nervous.
Alicia.
You want me to go first?
You talking to me? Let's Alicia, why don't you lead us off on that first question?
So this is a great question, and it's something that I've definitely have been walking through this last year. Like I said, my son was taken into CPS custody last February, and the caseworker that I got, I've never met her in person, never talked to her face to face, and she got my paperwork, and I have quite the history, and I've made a lot of mistakes and a lot of poor choices. And the way that she would talk to me was like I was a child. I felt like I was treated like I was a kid and talked down to, and felt like a lot of times I had to defend myself, and really had to protect myself. And it wasn't looking at what I was currently doing to better myself. But it was based on my past, and it was really hurtful and really discouraging. And there were several times in the process where I just wanted to leave treatment. I mean, I was 4 months in, 4 months clean, doing great. And when he was taken, I really just felt that I didn't want to stay. You know, I felt really discouraged and really just hopeless because I felt all they saw was who I was, not who I was trying to be. And it was difficult to talk to them. And I felt a lot of shame and a lot of guilt. And I just felt that I couldn't overcome that.
Thank you, Alicia. Tony, do you want to go next?
Yeah. I've experienced quite a bit of stigma, and I've kind of been on both sides of the spectrum. Having a criminal history and the rural area that this is, it's people know, when they hear the name, oh, there's Tony Cardenas, or what's he doing? He must be something. So I've experienced it from my interactions with, the police, the sheriffs, just community members, community organizations. Like when I would apply for stuff and when I would get out of prison and come back and try to apply for something, I would just kind of get put on the back burner. Felt like I didn't belong. I felt like I was somebody, like I was being otherized, I was being profiled basically, and just stereotyped and stigmatized. And I have some good news regarding that. That's been my whole life since I was about 13 years old, since I entered into the juvenile system and became a ward of the state, and was all over the state in group homes and facilities all my life, feeling forgotten basically. But now the interaction I've had in the last year or so has been really, really good with, law enforcement, in the community. Now I can, I don't do it as much anymore, but get out and get Narcan out to the community as much as I can, and other information, and kind of plug people in and do what I do on the side that nobody knows about. My hobby, I call it my harm reduction hobby, which is an awesome hobby. I get to get out and, get the education that's needed out there, so, but anyway, like I said, I don't want to keep monopolizing the time, but yeah, I've had good interactions with a lot of people, and the community level of education regarding SUDs and OUDs it's climbing up the ladder, and it's more known, and it's being destigmatized and thought about, and I've had some really good interactions.
Thanks, Tony. Stephen?
Yes. Stigma?
Yep.
Have I felt that way? Yeah. Getting out of prison, I kind of felt like that was going to be the case, but then it was kind of different with the tribe. They kind of wrote me in and, encouraged me to be sober, which is awesome. But now that I've been out using again and stuff, I feel like I feel that stigma, except through you guys. You're the only people that, reach out to help me. So I don't know. I don't really know how to answer that question. Yeah, being like Tony, coming from prison and doing all that, you kind of feel like the outcast, But I see that things are changing slowly, That's everything right there. That for me, the help that you guys are giving and reaching out and not judging people and, putting me down or, none of that. So I don't know. I don't really know how to answer that, you guys. Okay.
Thank you. You answered it. Thank you. And then the next question is, has there been any agency, person, and or service provider that's made a difference in your life, and what was significant about that connection? Alicia, oh, sorry, go ahead. You want to take it or kick it over to Alicia?
We'll let her go.
All right, I'll go. Well, currently I'm in the MAT program, and so I do that, but I'm also involved with Celebrate Recovery here in Bishop, California, and those two programs connected together. I have a great community support. You know, they really come alongside me, you know, and they ask me how I'm doing, and they take the time to listen, and they, you know, every time I go into the office, you know, for MAT, you know, they ask me how I'm doing, how can we help, you know, and it's not, you know, them telling me what I need to do, but they take the time to listen, and you can tell that they actually care. You know, it's not, well, you do this and this wrong, and it's more of like, you know, we're proud of you. You know, every time I go in, they make it a point to be like, congratulations on your time, and we're proud of you. And they just give me that encouragement to keep going. And I text Arlene weekly and check in, and, you know, let her know what's going on, let her know what's happening in my life. And I just constantly get just encouragement, and constantly get that reassurance, you know, that it is one day at a time, it is one moment at a time, and it's a constant thing, you know. But just knowing that I have people that are looking beyond, you know, my past, and looking at my potential, and it's just great to be a part of, and I'm really thankful for that.
Thank you, Alicia. Tony?
I think the number one thing that pops in for me is probably Bakersfield Recovery Services would be like the my starting point, because I was facing too much stigma here, couldn't access services in jail, wrote and couldn't get any help. Oh, he's on parole, he doesn't, you know, qualify for anything. And I kind of heard that all my life, so it discouraged me, and I was just like over Bishop and everything else, and just over life. But luckily I got a parole violation, and instead of sending me to do my time inside prison, they sent me to a rehab. I had a choice. I was like, sure, I'll go smoke cigarettes there. And didn't have any concept, didn't want to get sober. I wanted to get out and so I could get high again. And went in Bakersfield. They helped me out, gave me a hug, you know, shared some really, really awesome life experiences with me. And I was able to make some good memories there and have some good friends and good connections there. Also, Teen Challenge of Southern California, they helped me a lot. You know, I went through there. Yeah, and just basically here, I have to say, just the network, you know, that's being developed right now between, you know, like with Toyabe and what's going on there, the tribe and Northern Indian Hospital leading the way. Obviously, I'm so grateful for the rural health clinic. I go there myself now since I'm back in the area. But yeah, those are the main, you know, agencies that, you know, that I'm really, I say affiliated, but from a community standpoint, I've had a really good, they've shaped my life basically.
Thank you, Tony. Steven?
Okay. This time around getting out, it was kind of different for me. Usually the you know, the tribe and everybody would kind of, I felt like they would, you're the outcast getting out of prison. But through Arlene and Tony working with the tribe, they were supportive, you know, in the beginning. And also they got me into a sober living house for 3 months. That you know, being on parole and stuff, they wouldn't let people do that. But I see a big change there. And I'm grateful for Arlene and Tony for helping me through this, you know. Northern Indian Hospital and the health clinic too, the doctor getting me back on my meds and stuff. You know, if it weren't for you guys, I'd be all bad. All worse. All gone. But I don't know. The only places that helped me is Jason's Retreat and Arlene and Tony. They've been the big support, you know, and the doctor. So I don't know if I answered that correctly. But I'm grateful for you guys and not shaming me or making me feel like an outcast. You know, even though I'm all jacked up and trying to get better, you guys still tell me that I'm a beautiful person and that life's worthy and I'm worthy of a good life. And those things I appreciate, those are the things I need to hear now. And I'm grateful for that. So thank you guys.
Thanks, Stephen.
Thank
Yeah, you
you.
answered it perfectly. Could have said it better
I'm
myself.
actually living it right now. Ay, ay, ay. Well, what do you do, huh? Keep going forward.
It's about to get a little more real in here. Oh, you know what? I'm gonna share a story because I'm sure you guys won't mind. But we Tony and Stephen and I had lobster down in Bakersfield before he came home. Fresh out. I know you were still in rehab, and we were eating these big nice lobster dinners and just celebrating life, and that's that's cool stuff right there. But we we had this vision to start welcoming home our people, and whether you're native or not, our people. So welcoming them home and bringing them back from prison, from rehab, from jail. And like a couple of years ago, wanted to do like the tribal significance of it, and having our tribal leaders really be part of it, start embracing that, and do like a whole ceremony to honor people when they're coming back into our community, and to recognize that. And part of it is for them to help separate where they just came from too, so if they're coming from prison, to say we're going to leave some of that, the bad stuff behind, and here I am, I'm starting something new, and to do all of that like in the best way possible. And so we did the first ever welcoming home honor ceremony for Stephen, and our tribal leaders got involved, rural health clinic was involved, the doctor came out, and we ate together, and we all recognized Stephen, and we all shared good things, and the whole evening was so healing. Everyone that attended was messaging saying they needed that more than you, Stephen, for the people that came and took part in that. And so for me it was a pretty neat thing to be able to see something like that actually happen, and start doing that more and more for people when they come back home. A huge blessing from that point. So and our last for the panel is really if any of you with everyone, and we can open it up to questions after that. I'll check in with Alicia first.
Sorry, I missed the question. What was the question?
It's just checking in with everyone to see if there's anything that you wanted to share, or last minute thoughts.
I just, again, want to say thank you to everybody who's joining on today, and just for this opportunity to share my story, and to be a part of this, and congratulate Stephen as well in his journey. And I think it's pretty cool that Tony went to Teen Challenge, because I'm a Teen Challenge graduate myself. So it's really cool just seeing all of this, and just being able to be a part of it. So thank you.
Thank you, Alicia. Alicia is a rock star, by the way. I'm always super, she inspires me all the time with everything that she does. And I think what's super inspiring is when she meets opposition, and instead of reacting to it in a negative way, she always turns it around, and she like walks right through it with grace. And it always inspires me, because I'm like, some of the challenges that are faced are like, could be overwhelming or paralyzing sometimes. And, to see you turn to your support system all the time, to see you turn to God all the time, put that into perspective. And, so you have your team, you know who they are. And, you always inspire me with everything that you're doing. And oh my gosh, she works so much. So we were lucky to get her, get her today. So. Tony, any last minute thoughts?
Just grateful to hear some of the testimony, some of the experiences that we've all been facing here. I'm just, like I say, I'm highly optimistic right now. I'm hearing a lot of good things today, and trying to be part of it as much as I can, considering the pandemic and also just my workload, my school workload. So I'm grateful. And Stephen, man, you know, 20 years ago when I saw you in prison in Wasco, I was just as happy then as I am now, and even more so. I'm just glad that you're getting well, and I hope we can all get there and get this healthy recovery ecosystem going and build strong network, because what is it? A large network is more powerful than a small network, like more people with sociological thing. But just wanted to share that. So networking going on and stay in touch, and basically, you described like we're here to accompany you, it's accompaniment, like we're going to be there with you every step of the way, beyond a therapeutic, but from a community standpoint, because it's kind of a cognitive thing, to welcome people back, offer them words of love, be encouraging, staying in touch, checking on you, making sure that you got everything that you need, and exploring possibility for you in your life, and I'm grateful for you. You're the most important person here today.
Thanks. Thank you, Tony.
Last minute thoughts or comments,
Yeah.
Stephen?
I just want to say thank you guys. Thank you, Arlene, Alicia, and Tony. Thank you for letting me share my story. I also am thankful that the tribe did welcome me back. And, that's encouraging for me to go back to rehab and get help rather than, keep messing up, knowing that you guys are behind me. And that feels good because you guys are the only ones behind me. I disappointed my family and let them down, and I understand, where I'm at and why I'm here. But my focus is just getting better. And I thank you guys for that. That's it. Thank you.
Awesome. Glad you're here, Stephen.
Thank you.
I'm gonna open it up to anyone else who would like to ask the panelists any questions, or if you have any comments. Now would be the time to speak up.
Hey, Arlene, it's Tom Boo. Can you hear me?
Yep.
Yeah. Hi, everyone. Thanks, y'all, for sharing your stories and experiences and teaching us a little bit at a time. So I've worked as a physician at Toyabe in Northern. I'm currently sort of still in Northern Inyo a little bit when the COVID pandemic allows me to, but I'm interested in what what y'all see as barriers to to getting services, and what services we could improve upon or missing, and that kind of thing.
Any takers on this question?
What do we see as barriers to getting help? Was the question?
Yeah, like at Northern Inyo Rural Health Clinic or Toyabe, I think I heard Tony refer to the some concerns about like confidentiality at Toyabe, but both places are trying to offer substance use services and MAT and counseling and support and groups and stuff like that. But I mean, kind of just thoughts on what we're doing right and wrong, and
I think what's working for me is the love and stuff that I feel from the rural health clinic and the hospital, the doctor, she's just encouraging, you know, and with Arlene, she actually maps everything out so I can put one foot in front of the other to get to where I need to be, It's like getting as simple as getting a motel here through IMACA. She went out of her way to, get that to happen to me. Those are the things that are working for me, just and right now I'm so screwed up. Hard putting one foot in front of the other to get to where I need to go. But it's like they're like Tony said, they're with me every step of the way, whether it's a text or what, get my TB test and all that, they're guiding me, and I need that, that's what's working. With Toyabe, it's just different, different feel when you go in there. You don't get that love from the doctors and stuff. I feel personally, but I think the rural health clinic and what Arlene and them are doing and Tony is right on point, just loving people, encouraging them.
Thanks, Stephen.
Thank you.
Hey, Stephen, are you related to Emily and Richie Dondero?
Yeah, Richie's my uncle.
Yeah, he's a good man. Yeah,
Yeah,
miss those guys.
lot of good old family members. Yeah, thank you.
I can answer some of that from my own experiences. I think that one big barrier obviously is like the stigmatization of like just tribal clinics overall, and even like the hospital as well, because there are, community members who work, tribal community members who work there as well. And I think there's just always kind of like this undercurrent of like gossip, like there's going to be gossip in this small community, and they're going to know, somebody's going to know about what I'm going through. So that's why I think that, obviously trauma informed training and things like that would totally benefit like the entire blanket the area with that, because these are first impressions that, are going to last when it comes to like, getting those services where the rubber meets the road as far as getting the services out there, and whoever's advocating or whoever's referring or whatever's going on. Because I do a lot of grassroots stuff like that. I've referred dozens of people to everywhere around here, in the next county over too. So I think that a big barrier is the just the stigma surrounding, are people going to hold my confidentiality? What's going to go on here? Is there any accountability for that? And I think that's where the proclamations come in, more training, things like that. But yeah, and addressing that is, going to be in the way that you treat them. Like the brother shared that, he has a different experience at a certain organization as he does at the other one. So I think that, definitely working on our approaches to providing services in a, in a loving way, encouraging way, I know they're not going to use that term in the policy, but they should. But that's a big barrier. It's kind of just basically how they treat you, because when I was in my addiction, which I had a 25-year meth addiction, if you weren't treating me good, then I'm flipping you off and walking out of there. And that's just how it's going to be. Call the cops. I don't care. Sometimes you only have one chance, to help that person, or to give them some services. And, if you blow it and turn them off like that, turn them away, that's the biggest barrier. I think it's like people don't trust the medical facilities around. They don't have that trust. They're like, oh, you work there, so I'm going to go there now. And I'm like, well, I'm not, I'm nobody yet, but I'm working on it, and I'm trying to be the best I can be to help, the community. But for barriers, though, I think it's just that stigma surrounding a lot of it surrounding confidentiality.
Thanks, Tony. Is Missy your sister, Melissa?
Yes.
Oh, cool. She's good woman. Known her a long time.
Montana, did you have a question?
Montana, and unmuted you. Okay. We do have some. Oh,
No, I was just gonna say, maybe we can come back to Montana then.
yeah. We do have some comments and questions in the chat. Shania says, I believe in you, Stephen. Thank you all for sharing your testimonies. And Glortiz says, you guys are awesome. All three of you. Thank you so much for sharing your story. I wish that we all can help you, Stephen, but you have an awesome support group, one day at a time. And then
Thank you.
Yeah.
Thank you. Thank you.
We have a question from Aaron Clark. What words of advice do you have for those in positions of power, such as CPS, probation, etc., so that they can hopefully change their views or approach regarding those with SUD or substance use disorder?
I can speak on this one a little bit. Like I shared earlier with my story, I have a CPS case. It's currently just been closed, so thank God for that. But when the case first started, it was really hard working with CPS because they read my report, and before we even had our first conversation, they already knew who I was and what I was about, and it was that prejudgment that they had before me. And so anything after that I had to say, or anything that I wanted to show them that I was doing to better myself, was kind of thrown out the window, because it didn't matter, because my report said, you know, all these things that I've done and that I've been doing. And for the CPS part of it, it's just have an open ear, I guess, you know, have an open ear and an open heart, you know, and be willing to listen and be willing to, you know, there are people who struggle with addiction and lose their kids, but they, you know, speaking for myself, you know, that was what changed my life. And that's what drove me to want to be a better person, to be a better mom, to be, you know, an active member in community. And, you know, it's what drove me to want to get clean and sober. And so I was willing to do everything that they wanted me to do, you know, but it was hard having that connection with them, and then having that trust. You know, I didn't want to talk to them. I didn't want to work with them because they already had this preconcealed thought about me and feelings towards me. And so I felt really shut off and really tuned out and really just not a part of it, and that everything was kind of going around me. So for people in that power, I would just say, you know, be willing to listen, you know, take the time to sit and listen, because that really made a difference when people started listening and wanting to know how to help rather than shut me down.
I would, thank you, Alicia. I would also add just finding ways to actually create space for the people that are, you know, utilizing the services, because, but they have to have real decision-making power. They have to have not just, you know, hold a group here and there, but that there, you know, actually is space for them to have some authority, that they're invested in everything. I mean, that their voices are being heard, but they have the power to make decisions, not just like we'll take things into consideration. So really kind of dismantling some of the systemic barriers that are just in place. And, you know, for me, I'm trained in Western psychology, and I, you know, I don't ascribe to a lot of the theoretical approaches. One, because I'm a tribal member, and you know, I often do cultural trainings, you know, and I talk about the fact that healing in our language and with us is different. It has different meaning. We have different ways. We already know how to heal, and so you know, it's kind of sometimes re-traumatizing, or it's recolonizing somebody to kind of fit them through a system that was never designed for us as Indigenous people. And so for me, that's always something that has to be looked at, because you have to comply with case reports, you have to comply with probation conditions, you have to, you know, meet all of these requirements, but at the same time, this was a system that wasn't built for Native people by any means. It wasn't, designed by us, and it wasn't built for us. And, so the outcomes look different. And so like kind of just putting people, through the mill of services, and not being able to think creatively outside of the box. And I could say for myself, services look different. And, Robin talked about loving the people that she works with. I'm in the tribal community, I'm in our community. And I've grown up with a lot of the people that I work with, and some people I've never met, never worked with before. But the job doesn't always go 8 to 5, because people's crisis and things that they need aren't 8 to 5. And whether people say that that's right or wrong, you have to have your boundaries, and everyone has to adhere to their policies and procedures. I go back to like what policies and procedures are actually working, which ones are a hindrance. And we oftentimes just assume roles and keep old policies in place. And sometimes these old policies are hurtful. They're not trauma-informed policies or procedures by any means. And so, what I really appreciate about hearing things at the Rural Health Clinic for our MAT program specifically is that we had dedicated people who built it from a harm reduction approach. And so that's, to me, that's what shines through and makes a difference, because no matter what the person is going through, they can still be loved, encouraged, and talked to, as a human being. And I think that's what, for me has really come through, because people tell me that all the time, like, oh, I've never felt that way. Oh, man, you guys really care, don't you? And they're kind of awestruck with it. We're like, yeah, we really care about you. We really love you. And no matter what, you keep coming back. And so it's not always working 8 to 5. And I know Robin even touched on that too, is that we build these programs to fit our needs. Sometimes, to fit our schedules and our agendas. And of course, so trying to find the balance between what that looks like and funding restrictions and policies that are in place. So finding ways to kind of disable the policies that are helping, and that could actually be re-traumatizing for people.
I think somebody had a question for me.
Yeah. So someone asked you, Tony, with your lived experience and now formal education, how can we work to disrupt the school to prison pipeline, reduce, this is a word I don't know, recidivism among, using a lot of fancy words. Spelling might be off, I don't know.
Carcerally?
There we go. Thank you for saying that. Involve people and decolonize systems and structures that keep people in the cycles of addiction and incarceration.
Okay, since I am getting some practicum hours for this, I'm gonna go ahead and go in. So first I would say that like it's important to understand the history and the context of the structures of power that are in place in the country. From a broad perspective, the prison pipeline. So I take it that you're saying that there's a pipeline from school to prison. Is that kind of what it is? I'm familiar with it because I was in the Pete Wilson's big prison industrial complex move in the 90s. So I think to disrupt things like this, I'll just be blunt. I think that more education about like why these systems are in place, how they're in place, what keeps them in place, broader mental health screening for kids, just all races, all cultures, everybody that's in the country. From a structural perspective. And I think that educating families about, addiction and or maybe adverse childhood experiences, educating these households earlier on, being more proactive, just being bold, and using, empirical evidence, scientific data, research, doing research yourself, taking an active role. These are kind of things that I'm leaning towards at this time of my life, because that's why I entered into this social work program, which went way beyond all my expectations. This is the program for me. It's worked out, and yeah, and I think just being involved and keeping yourself educated on a more micro level, and sharing that education with as many people as in conversation and things like that. Just a suggestion. I do it all the time. It's really fun. You can do it on the phone, on Facebook. You can have these conversations, but I think those are ways that just more education about what has happened in the state, how many people were in the system at any given year. In 1998, there was like 220,000 inmates. So I think and recidivism, that's probably gone down because they're not sending as many people to prison at this time. They say the pendulum swings to the far right and it swings to the far left. I think this is the highest left the pendulum's ever been. It's really hard to stay locked up right now. So these are some of the new issues that we got going on, but I don't want to monopolize any time further. Thank you.
I think, Montana, I don't know if you wanted to chime in or not, but you had made a comment too about thankful for sharing the testimonies, and good to feel supported from the Rural Health Clinic and the differences in the care. I will continue to strive to support you all. Your suggestions have been heard, and I appreciate your openness. It's important. And I hope you'll continue to be open and verbal about your experience. I have heard it is encouraging for others in recovery to hear these stories. Smiley face and hugs. How are we doing on time, Jacinda?
We just have 2 minutes left, so we could wrap up if you'd like.
Anything else?
Thank you for the comments and the hugs and encouragement to those people, and thank you guys for everything.
Thank you all.
Yeah, I just want to, thank Tony and Stephen and Alicia for, getting on and being part of the panel presentation and, sharing your stories. And this is the good stuff that needs to be heard and shared across all sectors. So, people can feel what impact's being made and how services are best addressed and reached to everyone. So thank you for taking the time out to be with us.
Thank you.
You're welcome. And thanks, Dr. Boo, for all that you do. That rhymed. But you do a lot. I hear about you like from everyone that I know, and everybody has really, really awesome things to say about you, and appreciate the work you're doing, frontline stuff with the public health and the public health sector. And man, keep up the good work. I appreciate you and I honor you, man.
Thank you, Tony. Likewise.
Yeah, I just want to say a quick thank you to everybody. This program not only just helps me, but my dad also is in the program as well for the MAT. So it's definitely not just affected my life, but it's affecting my whole family and in a positive way. And it's just been an honor and a privilege to be on here with you guys today.
Thank you so much to all the panelists. Really grateful for your words and sharing your testimony. Appreciate it. So we're going to transition into our next speaker. Her name is Rachel McLean.
Hi, everyone. I'm Rachel McLean. I'm the the lead for the Office of Viral Hepatitis Prevention at the California Department of Public Health. You'll have to forgive me, my neighbors have a lot of dogs, so they might be part of the presentation as well. So I'm going to be sharing the results of a project that we did where we looked at vulnerability to fatal opioid overdose, HIV and hepatitis C in California by county. So can you all see my screen?
Yes.
Great. So I'll talk a little bit about the background, what we found, and sort of what to do about it. So as I think everyone in this room probably is aware, and sorry, I should have also just said thank you so much for having me, and I'm sorry I wasn't able to join earlier. I was double booked for like day-long conferences today and really torn. I wanted to be part of both, so I apologize for not being there earlier. I really wanted to hear what folks had to say, but I'd love to connect afterwards. So, you know, as I think folks are aware, in recent years, opioid use has really increased in the United States, but I also just want to say that, you know, people have been using drugs as medicine for thousands of years. And so part of what we're talking about is substances, but part of what we're also talking about is what are the sort of policies that are in place that make it safe or unsafe for people to use substances. So, you know, often the way things are talked about is that there was sort of this wave of prescription opioids. And when that was cracked down on, there was an increase in heroin followed by synthetic opioids such as fentanyl. Again, in reality, people have been using drugs for a very long time, but there certainly has been a marked increase in recent years. So what happened in concert with that increase is that as more people started using drugs or using opioids in particular, and also meth, which we could talk about later, a small percentage of people transitioned from oral opioid use to injection drug use. And when that happened, hepatitis C rates increased. So hepatitis C is a virus transmitted through blood that's transmitted mostly through sharing injection drug use equipment. So there was like very large increases of hep C as opioid use increased and as more people started injecting. So that was nationally. And what we saw here in California was similar, which is that as heroin overdoses increased among young people, hepatitis C rates also increased among young people as well between 2012 and 2016. More recently, we've seen more fentanyl-related overdoses that have been really skyrocketing. So what happened basically as opioid use increased is that in places where there had been very little HIV infection before, HIV started showing up. So there was a massive outbreak of HIV in a very small town in Scott County, Indiana. It's a county of about 5,000 people. They had several hundred HIV cases where they normally would only have like maybe 1 or 2 a year. And part of that is because they had closed the Planned Parenthood clinic, so there wasn't any HIV testing available, but there also was no harm reduction or preventive services available either. And in Scott County, a lot of people were crushing up Opana and other pills and injecting them, which when you crush pills, you have to add a lot of water, and people end up using syringes that are even more likely to, hep C can live in a syringe for up to 2 months if it's just sitting on a shelf, if someone has already used it who had hep C and their blood is left over in the syringe. So there was just a lot of HIV and hep C happening. So, you know, now Vice President at the time, Governor Mike Pence, issued an emergency declaration to respond to this massive HIV outbreak. There were hundreds of millions of dollars of medical costs. And like I said, more than 200 HIV cases, and 90% of the people diagnosed with HIV also had hepatitis C. So when this happened, CDC at the national level, I think, did some soul searching and asked, like, well, if we can have an HIV outbreak in this little town in the middle of nowhere, then that could probably happen somewhere else too. So they did an analysis looking at the whole country and asked themselves, what were the attributes, like what were the social conditions in Scott County, Indiana, and what other counties in our whole United States have similar conditions where there could be a rapid increase in HIV or hepatitis C infections. And in California, they found 2 counties were at high risk for a rapid increase in HIV or hepatitis C infections. And those were Plumas and Lake counties. So a couple years later, CDC gave California, the state of California, funding to conduct our own assessment using opioid crisis cooperative agreement funding. And the goals of our analysis were to identify California counties that were also at risk for HIV and hepatitis C increases related to injection drug use, as well as increases in fatal opioid overdose. And then to develop tools for use by local health officials and community partners to prevent epidemics and address them. And then to share the findings to inform local public health action, which is what we're doing today. We created 2 different models, one for overdose and one for HIV and hepatitis C, just because they're overlapping, but a little bit different in terms of how diseases are transmitted versus what puts people at risk. So for example, if someone uses alone, they have less risk for HIV or hep C because they're not sharing equipment with someone, but they're at higher risk for overdose. So that's why we looked at them separately. So just to kind of jump right ahead to what we found in our analysis, we found that we really believe that every county in California has some level of vulnerability to a rapid increase in HIV, hep C, and or overdose related to injection drug use. And this has really been borne out that since CDC did that first analysis with that map that I showed earlier, there have been a number of HIV outbreaks all over the country related to injection drug use, including in places that already have preventive services like Seattle, Portland, and Philadelphia, but also in rural areas, both in places that CDC had identified as vulnerable and in places that they hadn't, which to me, to us really meant that everywhere has some vulnerability. But we also found that some counties had more vulnerability than others. We found that the northern counties in California had the highest vulnerability, in addition to a handful in the Central Valley and in Southern California, both for HIV or hepatitis C increases and opioid overdose increases. And specifically in terms of Mono County was found to have some vulnerability in comparison to other jurisdictions, partly because some of the numbers were pretty low. But again, we feel that that the same interventions are really needed everywhere, honestly. We also found that 2/3 of the counties had the same level of vulnerability, both for HIV, hep C, and overdose, which I think just really shows that these are overlapping epidemics. So what we did with these findings is we developed a report, like an executive summary that sort of explains what we did and what we found. And then there's a technical notes document that's really more for epidemiologists and researchers that want to get into the science behind the model, the methods of the model. But it's okay if that's, if you're not interested in reading that, or if you are, it's available. We developed a resource list to really promote the kinds of interventions and services that are needed to reduce vulnerability, and then like a action planning checklist for local communities to use to kind of figure out where to start to reduce their vulnerability. And we can share all of those. And so what the report recommends, is 5 key preventive services that have a strong evidence for reducing the risk, both at the individual and the community level, of HIV, Hep C, and overdose. Those include medication-assisted treatment, which I believe you all have talked about earlier today, increasing access to naloxone, which is used to reverse an opiate overdose, increasing access to sterile syringes and the other services and connections and social support that syringe services programs provide, and then HIV and hepatitis C testing and linkages to care. So just to talk about each of those a little bit, I think you're all familiar with these, but one of the things that I think is really cool about medication-assisted treatment, specifically maintenance with buprenorphine or methadone, is that it's actually been shown to reduce hepatitis C rates among young people who inject drugs by 50%. That's almost like a vaccine. So, but we also know that young people are not necessarily likely to access those services. And so they often need services that are developed really for and by young people and really designed with them in mind. And I found in my experience that kind of lumping adults and young people together doesn't always work culturally. Increasing access to naloxone, which again is used to reverse an opiate overdose. It's available in both an injection and a nasal form. There's lots of free naloxone available. So if you don't have it, then I'd be happy to share the resource list that provides information on where to get it for free. And one thing to keep in mind in particular with naloxone is that it really is used best by people who use drugs. Like the best people to use naloxone are people who use drugs and people and their friends and family members, because they're most likely to witness an overdose and be there to respond. So while, you want to have naloxone in, schools and police departments and stuff like that, the bulk of naloxone really should be going directly to the community because they are the best first responders. Increasing access to syringe programs, which I talked about. There's lots of evidence that shows that syringe programs increase access to drug treatment and really help keep communities safe. And then increasing testing and linkages to care for HIV and hepatitis C, which, I'm happy to talk about more. But really, patient navigation seems to be kind of the key to make that work. So I wanted to just provide one example of kind of what does this look like in practice. So as I said, Plumas and Lake County were the 2 jurisdictions identified as vulnerable by CDC. And so CDC gave Plumas County a heads up before they published that paper that showed them on the map of the whole country as being one of the vulnerable jurisdictions. And that gave them time to kind of prepare and figure out what they were going to do. So they started out by developing the Northern Sierra Opioid Safety Coalition, and they started out with naloxone distribution because in their county, they felt that is a conservative environment and that probably would be the least controversial thing to implement. They started out with naloxone at I think 1 pharmacy. And that went fine. The sky didn't fall. And so then, a couple years later, they added medication-assisted treatment. And then that went okay. So they added a syringe service program. And that went okay. And so they've added a Hep C testing and linkages to care, which we're partnering with them on. And right now they're working on implementing contingency management, which is really works very well for people who have a methamphetamine use disorder. It basically gives people a reward for not using by using prizes and things like that to help people feel motivated. And I share this example because it really, to me, illustrates what harm reduction means in practice on like big picture level, which is that you don't have to do everything overnight, and any positive change is a good change, basically. And what's interesting is that recently CDC just put out a health alert, really trying to call attention of the public health and the medical communities to recent outbreaks of HIV among people who inject drugs that have happened after the Scott County, Indiana outbreak, and sort of what some of the lessons learned were that and considerations during COVID. And what they recommend is really similar to what we recommended, in addition to having infrastructure for outbreak detection and contact tracing, and a lot of the things that people are starting to learn about now with COVID are really key tools in any public health outbreak response for an infectious disease. And the other thing is that, you know, even in a community that has some of these services, they really need to be implemented at scale, which means like anybody with, you know, who feels like they need treatment for addiction or for HIV or Hep C should be able to have treatment on demand. And everyone who injects drugs should have a new injection equipment for every single injection. So in terms of where to start on using the report, which I can, I've sent out by email to various listservs. I can send it to the organizers of this meeting so that you can send it out to everybody who is here. Is to just sort of look at it, look at the resources on the checklist, look at the CDC guidance, think about sort of how this intersects with COVID, and convene community partners, which you're doing today, and really center, you know, Black, Indigenous, and people of color who are most impacted by the drug war, and as well as people who are marginalized by our society, including people experiencing homelessness, people who use drugs, people who are incarcerated. And look at the services you have and build on the strengths of what you already have. And like I said, in terms of a harm reduction based approach to your work, really celebrate any positive change and know that incremental changes really can build up over time. And then even though our report did not get into depth on methamphetamine and syphilis, I just really wanted to highlight this because I'm very concerned that in California, over the last 10 years, methamphetamine related overdose deaths have really increased quite substantially. And what we've also seen is a very big increase in syphilis, which, you know, has been around also for, you know, many thousands of years. I think I think Beethoven had syphilis, or Mozart, I don't remember, one of the two. And of particular concern, we've seen increases in transmission of syphilis at birth to babies. So we've seen a very large increase in what's called congenital syphilis, which is syphilis transmitted from a person who's pregnant to the baby at birth. And this is all really preventable. And a lot of what we're seeing is that people who use drugs who are pregnant don't feel safe accessing prenatal care because they're afraid their kids are going to get taken away, or they just have a lot of trauma, they've had bad experiences, and they're scared of being judged. So it's a whole different topic, but I just wanted to say that I really see these as intersecting issues. And also just to offer that we at the State Department of Public Health are all available to provide technical assistance, as is the Harm Reduction Coalition. I know Jessica will be presenting after me. James Wilson and others at the Plumas County Department of Public Health have also said that they're more than happy to help any other jurisdiction that wants to kind of know where to start in implementing these programs. So that's my main part of my talk. I just want to really thank all the people who worked very hard to put this report together. In particular, Lauren Stockman was the analyst who did the analysis, and another of my other colleagues really helped sort of conceptualize and write up the report. I'll stop sharing in a second, but the questions that I was interested in talking with you all about is, what questions do you have for me? And how do you see this intersecting with your work regionally and locally? And how can you envision using this report to promote access to preventive services in your jurisdiction? I'm going to go turn off my heater because it's very loud, but I'll stop sharing. And thank you so much for having me. I really appreciate it.
Thank you, Rachel. And if you guys have any questions, feel free to put them in the Q&A or raise your hand. I appreciate your talk, Rachel. One of the things that sticks out for me in regards to locally within Mono County is we don't have a syringe exchange program. And that is an area that I feel like is we need to collaboratively focus on to reduce some of these disparities.
Well, Jacinda, we do have one. I think it might be I think it might be non-operational right at the moment, but behavioral health in partnership with public health, we did get CDPH certification for a syringe exchange program, and I think Andres Villalpando in behavioral health was quite active in harm reduction efforts, but he recently resigned, and so I don't know what's going on now. And I wish public health could step up, but I think we're so overwhelmed with with COVID right now that it'd be challenging. But yeah, so. Yes, and thank you very much, Rachel. And I might I ask? I mean, Dr. Swisher, are you still on this call? I saw you as a participant. But if you are, and I was just wondering how it's going with Mammoth Hospital with all the other things going on, but efforts to develop to start the MAT program that you've been working towards for a while, and then I know there was some talk about Mammoth Hospital also offering hepatitis C treatment. Either it sounded like Dr. Clark might have been interested, but then there was maybe an infectious disease doc that was going to be working with y'all, and I feel kind of like I haven't kept up with what's going on. So.
I think you're unmuted, Dr. Swisher, if you wanted to.
I'm happy to talk. I apologize. A family member just died, and I'm not somebody here in town, but I was gone for a little bit talking about things with that, so I've missed the last 20 minutes, 30 minutes.
That's okay. We can catch up. Offline. But I was just wondering how things are going with efforts to develop a MAT program, and whether you guys have moved forward on being able to treat Hep C and some of the other things that Rachel McLean's been talking about.
We're not there. We can talk offline. I'd be happy to chat with you maybe this evening, but at this point, it's we're in that same sort of, it could happen really soon, or it may not, happen in a specific, planned clinic format. We are taking people who come to the emergency department, and we are directing them toward. We do have a substance use, navigator, and we're directing them towards our behavioral health team, but. From the ongoing prescription problems or the prescribing, we don't have a dedicated prescriber. We've lost one of our main physicians. We lost Dr. Crunk for a little bit, and now he's back, but he's finishing at the end of December. We lost a nurse practitioner who's being replaced by somebody who I think is ultimately going to be very good, but is fresh out of PA school. We're bringing in an internist. We still have ongoing chronic pain issues, and right now the main part of the clinic is having difficulty managing the workload. So I'm not really sure where everything's going to go. Initially, we had plans to use part of the building we'd remodeled, and that became the COVID clinic. And it's, everything's just in flux. We just don't have a really robust program at this point. I wish I could give you a better answer than that, but that's a pretty honest one.
I mean, hi, this is Rachel, and I'm really sorry for your loss. There's a lot of that happening right now. I lost someone close to me yesterday. But part of what I was saying in my presentation is that, really the core tenet of harm reduction is that to really celebrate any positive change and know that these things often happen very slowly over time. And I think, during COVID, I think just keeping your head above water at all is a positive development for all of us, like just literally surviving. And, so even if it's just a matter of, I remember when I used to do outreach with homeless youth many years ago, Julian, one of the other outreach workers, used to talk about how, in terms of building trust and building relationships and building things over time, he's like, first you got to just loosen the soil, and then you plant the seed, and then you slowly water it, and then maybe it'll sprout, and maybe some of the sprouts will grow, and it's like that. That's really kind of how I see a lot of this doing this work. Yeah, it's, the example that I shared earlier was just that Plumas County recognized that they were vulnerable to an HIV or Hep C outbreak related to injection drug use. And it was really a 5-year process for them to implement a lot of the harm reduction services that they did. And, I could just hear the exhaustion and the burnout, it's like, I think we're all just doing the best that we can right now, and that's okay,
I mean, we are able to get people who come to the emergency department, we're able to get them to have follow-up appointments. We've done a couple inductions. It's just where we just are not going to be at that point, I think, probably for a while. I do, feel very fortunate that Inyo County, Northern Inyo Hospital, is able to provide the service locally, and it's just done such an incredible job stepping up for it. We would like to help you and help the locals who have difficulty traveling. But, I think every time I talk to you guys, I do have a shout out for you for doing such a great job and just really just getting it going. So,
To say, Dr. Fisher, this is Arlene, and I was just going to say condolences to you and your family. And yeah, I've been working with Janine and getting referrals in, and as much as possible. So whenever we get them into our program. So
awesome, we appreciate that.
We have a comment and a question in the chat. Shania says, this isn't directly pertinent to Mono County. However, I feel the data presented during this presentation with the case of increased HIV linked to the shutdown of Planned Parenthood is important to highlight during the current climate of the US. I think it's very important for all clinics to show statistical significance of their preventative care implementation so that people are aware of the difference clinics can make within various populations. Thank you for this presentation, Rachel.
Yeah, thank you for that comment. I mean, the meeting that I was just attending today is the National Coalition of STD Directors, and they were talking about their sort of federal policy agenda for the next, the incoming administration. And a lot of it is to really undo some of what was done in the last, 4 years in terms of access to contraception and supporting Title X clinics. So, Jacinda, I know you're in maternal and child health. I'm really interested in kind of your thoughts about the intersection between your work and harm reduction services for people who are pregnant. And I know you all talked about it earlier, so forgive me if it's a repeat, but just to say that I think these issues are really connected because of the drug wars attack on women in particular, and women of color has been so intense for so long and has really very real consequences. So thank you for that comment. And then I think the next question is, in terms of syphilis among pregnant people, are there co-diagnosis with HIV and Hep C and other STIs? That's an interesting question. I think I don't have the results in front of me. I would have to kind of dig through my computer to find them, but we have been seeing increases in hepatitis C among people who can become pregnant. We've done matches of our HIV and our Hep C data, but we've done matches of HIV and syphilis, but we haven't matched all three. And we have that in the works where we're going to try to sort of build a system that will automatically match all of those three with each other. My impression is that most of the, 50% of syphilis infections in California are among people with HIV, but that a lot of it's been among men who have sex with men. But it's an interesting question for sure. I mean, the impression that I've gotten from the data on syphilis among people who are pregnant is that there's actually not as much injection drug use and there's not as much opioid use. It's mostly methamphetamine and people are smoking or snorting meth. And so the Hep C risk is not as high if you're not injecting, if that makes sense. So I think of them as sort of there's some overlap, but it's not 100%. And I don't think we have really looked at that enough. So thank you for that question. I will definitely make a note of it.
I have a question for you. I used to work in Santa Cruz County, and I was there during the Hep A outbreak. Primarily affected individuals who were homeless or using IV drugs. And I was just curious, has there been any studies done about those outbreaks that were seen? I think it was 3 years ago.
Well, I mean, the good thing is that there have been a handful of hepatitis A clusters still among people experiencing homelessness and people who use drugs. I mean, thankfully, that big outbreak that affected San Diego, Los Angeles, and Santa Cruz primarily has ended. But there we have been seeing some, I think Riverside and San Bernardino have seen clusters of Hep A cases as well. And it really just highlights the need for vaccination in this population. And I mean, I know, vaccinating everybody against COVID when that's possible is going to be a massive public health undertaking that I don't think any of us have ever even seen before in terms of scale. But I do think it raises the question of, depending on the population, could you add flu vaccine? Could you add hepatitis A and B vaccine if it's depending on the population? If you're going to vaccinate for people against COVID anyway. And again, I know there's always capacity issues, but that would really be kind of the dream. Any other questions or comments? I'm curious to hear just from the other folks that are participating, what your thoughts are, if this resonates, if you think this could be a tool, the report could be help you politically I mean, honestly, that's really kind of what we see it for, is just to have a political tool to show policymakers, hey, we have vulnerability in our jurisdiction if there's political opposition to harm reduction services, for example.
I guess I can share some stuff, Rachel, because I am once again in the thick of it up here in Humboldt County. I no longer work at Hatcher, but I'm still on the board. And our Eureka City Council, I'm pretty sure the state gave a presentation to the Public Health Department up in Humboldt, and Humboldt has historically been on this list of vulnerable places. And the public health is very supportive of harm reduction. They have a syringe exchange. But the nonprofit grassroots program has really had a hard time with the city council and is once again dealing with the city council just last night, in fact, and now currently has a council member who is trying to wants to ban services. Basically, like, Hatcher's come to an agreement with the city about doing mobile only SEP to try to curb some of the community concerns around syringe litter and crime in the neighborhood, which none can actually be proven to there's no causation, right, that can be proved. They're all correlating, making assumptions. But so the rollout of this mobile only was slated to go in June, and that's not good enough for some of the council members. And one is suggesting that services should just close altogether for the next 6 months until it can be mobile only, and a fence can go up and a safety monitor can be there. So I wish that data would actually sway these folks. This council member blatantly said, I am coming from an emotional place, but I do care about the population and know that we need this, but I just can't get behind these services until they change for real, right? She's had her own history with engaging with the organization. It's too much history to go into here, but all of that is to say that it's still something that's so ripe with feelings, right? And beliefs, and the data is there and it's been shared over and over and over again with our community. And there are folks that refuse to budge, or do budge for a minute and then go the other way when the pressure gets real big, right? And it's just kind of ironic to hear council members saying, we're so tired of this, we're so tired of this. And it's like, yeah, the people on the ground are also tired. They're tired of watching their participants die of overdose or freeze to death or hit and runs or any of the other horrible things that happen to the folks that the program serves. So that's my rant for the day. Thanks.
Thank you. I'm really sorry. That's terrible. And it's a really good point. I mean, I know that, you need a multi-pronged approach, and data is just one part of that. And really what people respond to are stories. It's a good point that I guess it's like in government, I feel like that's not our strength, our strength is not collecting stories and sharing stories. I think the community really does that better, but it's a good point that I think that, that we need to think about more, is how to include more stories in these kinds of reports. It's just ironic because, in the government approval process, that's the kind of stuff that they take out, because they're like, oh, this isn't data, this isn't science, when in reality, that's what people respond to. So, anyway, thank you for that. And I'm really sorry, that just sounds really frustrating. I know Santa Cruz, San Diego, Orange County, I mean, there's a lot of Butte County, a lot of challenges like that all over the state. So, we're hoping that this can just be one tool in the toolbox, but it's not the only one for sure.
Yeah, thanks, Rachel. This is Tom Boo again. Sorry for talking so much, but we were concerned about the politics of harm reduction in Inyo County, but Because the hospital, it's a district public hospital, kind of like a county hospital, but serves the northern half of a large county. Um, Took it on, and it was approved by the hospital's board of directors. It seems to be well accepted. We haven't had to go to the to the county board of supervisors for approval. I mean, we try to, I think, keep them informed, and Dan David, if he's on, could probably provide more up-to-date information. But in Mono County, we've had surprisingly excellent. I mean, I shouldn't say surprising. We've had really excellent support from the county supervisors when we sought approval for seeking syringe exchange certification and naloxone distribution, and the components of harm reduction that that the county government's been involved in. So, and I just saw the sheriff responded to the the syringe exchange, I guess every couple of years or something like that. Law enforcement is supposed to be asked if they have any concerns, and I saw that our sheriff indicated that she continues to be supportive. But things can change. I mean, political leaders can change, get a different sheriff, get a different person or two on the board of supervisors, and it can all go south, obviously. So.
That's a good point. So it sounds like part of what works is having like a big, well-established institution sort of lead the way. I mean, because it's, it's not like people are going to tell the hospital to shut down, probably.
It's wrapped up in stigma, right? Like a lot of the smaller nonprofit or grassroots programs, they are led by people who use drugs, and they very much center that advocacy and centering of those folks. And so the community automatically assumes, oh, you're just this and you're just that and you're incompetent, and how could you run a program? People who use drugs shouldn't have that kind of power. Like, they're just in it for themselves. So I have sort of found with engaging with multiple organizations and, different kinds, whether it's through public health or a nonprofit or a hospital, the folks who do have that healthcare background, whether the person running it has some sort of healthcare background, or they're within a hospital, or they're within public health, they tend to be more accepted, I think, by the community, because there's this air of like professionalism that clearly anybody else can't have if you're not a doctor or a nurse or, associated with a healthcare setting. So just again, with the stigma sort of running through that.
As if healthcare professionals don't use drugs. I mean, but yeah, it's a good, that's lots of work to do for sure. Stigma comes up a lot, and, I'm just really curious, like what really works. I mean, if you look at this is me, obviously just commentary, but I just think about homophobia, just like as an example of something where there was a lot of social stigma. And then you think about, like, is it television shows like Will and Grace or Glee, or, like, is it television shows just showing people just being gay, doing their thing? Is it people coming out? Like, what made the difference to really sort of change the tide in terms of acceptance? I think it's a lot of different things, but, I think part of it is that there's this sort of separation of like good drugs and bad drugs, like coffee is acceptable, but it's still a drug. It's not any different than other drugs. Anyway, that's just me editorializing. But any other thoughts or comments, or, that people want to share? And, if not, if you want to take a break or whatever, the facilitators, whatever you think makes sense. I'm just grateful to you for having me.
Yeah, thank you so much for speaking, Rachel. I think we'll take a break. And if you're able to stay, we do have a open discussion time around 4. Yeah, we'll meet up again at 3 p.m. and Jessica will come on to speak. Thank you, Rachel.
Thank you, Rachel.
Thank you, Rachel.
All right, I think we'll get going again. And Rachel, I just wanted to point out, I did receive your email with the vulnerability assessment materials, and I will send that out in the email to all those that I invited via Outlook, but also put that on our website so people can access it there as well. All right, so I'm going to introduce our next presenter. We have Jessica Smith. She's a community mobilizer coordinator with the National Harm Reduction Coalition. Thank you, Jessica, for joining us.
I'm muted. Thanks. Really happy to be here. Now you can see my face instead of just hear my ranting voice. Yeah, I really appreciated being invited to this, and I've loved hearing from everyone so far. I've recently been able to engage with Arlene and Tony and Robert and Rachel, just in general, usually. So yeah, it's nice to see y'all here as well. So let me find the screen that I need to share with everybody. Okay, and let me make sure we're on presenter mode. Okay, here we are. So I'm going to talk with y'all about Foundations of Harm Reduction today. I appreciated the earlier presentation on harm reduction. It really gave sort of like a tangible, like, this is what it looks like in the world. And I'm going to get more into definitely some practical applications, but more like the theory, right? So talking about the principles and just really getting like a deep understanding and some like, yeah, meanings behind what is harm reduction, what does it mean to do harm reduction. And so I am with the National Harm Reduction Coalition. This is just a little bit about us. This is actually our North Star statement that was developed a few years ago. And it's sort of like our guiding principle that's even deeper than our mission statement. And it really revolves around acknowledging the harms of the war on drugs and how it disproportionately impacts people of color, Black and Brown communities. And so every time we do anything, we keep that in mind and ensure that all the things that we do are rooted in racial justice and equity. So here's a brief overview of what we're gonna get into today. So defining harm reduction, I'm gonna talk a little bit about stigma, go through the principles, and then I am gonna talk about some strategies for harm reduction and specifically doing harm reduction in rural communities. So as you might have heard me mention already, I live in Humboldt County, which is a rural county. And we have our fair share of struggles up here, ensuring that harm reduction exists and continues. So it's something that's very important to me. Before I took my position at National Harm Reduction Coalition, I ran the syringe exchange program that I mentioned that is still dealing with a lot of pushback from both community and city council. And as you might know, when people in positions of power continue harmful narratives, it makes it real hard to exist in community with other folks. And so, those ideas and narratives keep flowing throughout the community, and it ends up hurting the whole community, really, everybody, and especially the folks who rely on these life-saving services. All right, so we will start by defining harm reduction. And usually when we do these sorts of trainings, we like to make it a little more engaging. So like having folks answer questions and whatnot. Because of the webinar setup, it's a little more challenging to do that today. So the next few slides, you're just gonna see some stuff that's been like pre-filled in by other folks who've done this workshop. And we're able to sort of answer some of these questions. But so when we talk about defining harm reduction, we always like to start by asking folks, why do people use drugs, right? We're talking about substance use. It's a very complex thing. There are lots of reasons that people choose to use drugs. And as Rachel mentioned, basically, like everybody uses drugs, right? It might not be meth or heroin, but it might be alcohol, it might be coffee, it might be sugar, it might be shopping. Like all of these things like do the stuff in our brains, right? That things like methamphetamine or MDMA or heroin or, right? Like Rachel mentioned, like we categorize drugs as good or bad or like harder, when really we all do these things and we all do them for reasons, right? Like substance use is very much like there's a purpose. And so these are some things that folks have come up with, right? I love the top one. It feels good, right? Some people use drugs because like their substance use doesn't ever become problematic and it feels good, it's fun, it works for them. It doesn't become an issue. For other folks, it is a way to escape, right? It's a way to numb physical pain, emotional pain. It might be prescribed, right? Lots of folks use prescribed drugs. We may treat them different than people who use drugs that they acquire in an illegal or non-prescribed way. A lot of folks use drugs because that's what they've grown up around, right? They see people all around them using, and that's just the norm for them. A lot of folks, especially younger people, are just curious. They're experimental. They see their friends doing it, right? Peer pressure, or maybe not even pressure, but just wanting to try it because their friends are doing it too. And yeah, there's some self-medication that can be involved. Folks that are trying to manage depression or anxiety or, trauma that they've experienced at some point in their life. And it's also a way to feel connected. And so you'll see also that the reasons people don't stop using drugs are pretty much the same, right? Again, like using drugs, there's generally a purpose that folks choose. And the reason that they don't stop, it might be the same reason that they started to begin with, right? So, when we get into like addiction or having a substance use disorder, physical dependency, right? That's a huge reason for a lot of folks not stopping drugs. The idea of going into withdrawal or like not being sure how to start, like where to start, who's going to support me, am I going to be stigmatized, like how am I going to be treated in recovery? Those sorts of thoughts can be frightening for folks and deter them from stopping drugs if it's something that might be problematic in their life. Some people use drugs because it helps them get through school or work, right? And if they still have to work late night shifts or they still have to stay up all night writing reports, then they're not going to stop using those drugs because that reason that they use them in the first place is still relevant. Again, because it feels good, right? We do it because it feels good. We don't stop because it feels good. And it, isn't having a negative impact on our lives. I just like to remind folks, like when we talk about substance use, we're not always talking about substance use disorder. That's a very real thing for some folks, like we've heard today. And I really appreciate people being vulnerable and sharing their experiences. But for some folks, their substance use, whether it's coffee or alcohol or even methamphetamine, it doesn't impact their life in a way that results in serious illness or harm to themselves or other people around them or incarceration or things like that. So yeah, this is a great way to sort of get into the mindset of like understanding drug use, understanding that most people use some sort of drug and that it's a spectrum and a continuum. And we'll talk a little bit more about that as we go through these slides. So what is harm reduction? And again, we talked about this a little bit earlier, so I appreciate just sort of having a preface for all of this and that everyone's minds are kind of thinking about it already. So I like to talk about harm reduction in a way, so like this is the harm reduction approach, right? And we're going to talk about like harm reduction as a movement as well. And so this I call the little h, little r, right? It's like the practical application, like the services, the techniques, the strategies that are getting used for folks who use drugs. And this can be used for folks who engage in sex work as well. or other behaviors that might be perceived as having risk. And so one of the strategies that folks use is safer techniques. And that could be, you know, using a sterile syringe every time you inject. Maybe someone before didn't know the risk of sharing syringes, and now they've linked themselves up with a syringe exchange program, and they know that it's much safer for them to use a sterile syringe every time. Maybe they realize that they can smoke and snort their drugs, and that's actually causing them less harm than injecting. That would be a safer technique for them. Managed use, right? For folks who are not interested or able to obtain abstinence or full sobriety, managed use is a great way to reduce harm. So maybe someone's like, you know, I can't drink 6 beers every day anymore, but maybe if I have 2 or 3, that's gonna, you know, stop me from getting drunk and blacking out, and that's gonna, you know, cause me less harm. I'm going to start using medication for opioid use disorder, and you know, I'm living outside, so maybe I still have to use methamphetamine because it's cold at night and I need to stay awake to make sure somebody doesn't take my stuff, right? That's another form of managed use. And then abstinence, I think sometimes when we have this conversation about harm reduction, folks sort of see it in opposition to abstinence, and that is absolutely not the case. We see harm reduction as like a buffet of options, right? Like choice is the spice of life, variety is the spice of life. All of us are different, we have different needs. And so if abstinence is an approach that reduces the most harm for somebody, and that's something that they are interested in and can realistically obtain for themselves, then we absolutely support that and support folks into making that decision. So I think it was mentioned in the presentation earlier that, like, you know, just because something worked for you or your friend or your brother, or, you know, it doesn't necessarily mean that that same approach is going to work for someone else. And that's sort of wrapped up in one of the other principles that we'll get to, but just considering sociocultural factors, you know, meeting someone where they're at, trying to understand where they're at in that moment in their life and why the choices that they're making are the ones that they feel like they're able to make at that point in their life. So like I mentioned, the continuum of drug use. So this is really a great way to talk to participants, to clients about their substance use. Because a lot of times we think, you know, someone's using drugs or they're not using drugs. All drug use looks like this, that's it. And so this is just a really great way of framing it and giving people some language around like where they're at. And these things can look different, again, for different people. I think you'll notice like the big thing about harm reduction, it's not like a one size fits all thing. It's not fixed, it's not stagnant. It's really meant to address the needs of each individual person and meet each individual person where they're at. And like Rachel said, supporting any positive change, right? Big or small, once, twice, however many times, like all of those positive changes lead to big life-sustaining changes. So you'll see the continuum goes from no use all the way up to chaotic and persistent, and everywhere in between. And again, some of these terms can be different depending on who you are and what your use looks like. But it's really great to be able to talk to someone instead of just saying like, hey, are you using drugs? Being like, hey, can you talk to me a little bit about what you think your drug use is right now? Would you say it's only social? You know, do you only get together with your friends a couple times a week and, you know, have 6 drinks? Do you only do that at weddings, right? Is it a ritual binge? Are you only like blacking out if you go to a wedding or a bachelorette party or something like that? Oh, okay, I hear that you like went to a party and you used Molly for the first time, you know, like how did that make you feel? How do you think that went? You know, is your use chaotic and persistent? What does that mean for you, right? Does that mean that it is causing chaos in your life, that you're unable to maintain your responsibilities, that you're losing connections with your friends and family? Or does it mean that, oh, it's just chaos because like I don't have enough money and so I can't get what I need and so I'm feeling really sick, right? Chaos can mean a lot of things. Maybe habitual and daily is actually better for some folks because they're not feeling sick. They are using daily, and maybe it is problematic in some ways, but they're able to, not go in withdrawal, which means they're able to maintain their job or keep going to school or keep engaging with their family. So really just being curious, right? Being curious about where folks are and giving people language besides just sober, using. This is another helpful tool to think about drug use and to think of, to help a person understand how a drug can potentially be more or less harmful depending on these other pieces, right? So it's the risk set setting model or drug set setting. And so the drug is the drug itself that you're discussing, how it's used, how frequently, whether it's prescribed or was obtained from the street, right? So if someone says, oh, I got this Xanax from my mom's pill bottle in the cabinet versus I got the Xanax from the street from a dealer that I don't know, right? Like same drug, but could potentially have different harms. Maybe that Xanax from the street is laced with something else. Alcohol, right? Like if you're drinking, and this will get us into set and setting, right? If you're drinking at home by yourself versus if you're drinking and you're in a good mood and you're out with your friends, right? So the set is, let me move this out of the way so I can see. The mindset that someone brings to the situation, including thoughts, moods, and expectations. So if someone is deciding to use drugs and they're really upset, that might end up having a negative effect on them. The harm might be more, right? They might go into a spiral, they might go into a binge. If someone is feeling pretty good and, they're clear-headed and they're like, this is something I'm choosing to do, I'm not upset about anything. I feel safe and secure, like that could be that there might not be a whole lot of harm in that moment using that drug. And so similarly, setting can also impact these things, right? So the physical and social environment where the person is and their perception of how that can promote or reduce risk. So I always think about folks who are unhoused and using drugs and their setting of being out in the open and having that concern of possibly being caught by police or having community members see them and say something to them or, glare or call them names. That's going to impact the whole experience of using that drug. And maybe if, you're also kind of, what's the word I'm looking for? If you're sort of stressed out, trying to get it done quickly, right? If say you're injecting something, you might miss a vein or cause harm in that way, right? If you can't be in sort of like a calm, sterile environment, you just have to rush. So different things are going to make the actual drug that you're using potentially more or less safe. I think it's easy to just say, that drug, that substance is harmful, period. And while we acknowledge that there are some substances that can inherently cause more harm, more often than not, it's also the set and setting that's going to add to the potential risk to using that drug. And so now we're getting into the harm reduction movement, right? And so we just talked about our big or small h, small r harm reduction. Now this is our big H, big R, so the movement. And this is kind of related to that our first slide that I opened with, our North Star statement. But it pursues a model of public health as social justice, right? And I mentioned this as well. Well, so the second one says combats the forms of racism, stigma, marginalization, and criminalization that places people in harm's way. So harm reduction really can't be separated from social justice, right? Because at its core, it believes that people who use drugs are worthy and deserve health and dignity and respect and autonomy. And the status quo has said that that's not true, right? It marginalizes people who use drugs. And if they have intersecting identities, maybe they are someone who uses drugs and they're Black and they're trans, they're going to be marginalized even more, right? So it's really impossible to do harm reduction without acknowledging these issues and trying to fight back against them, merely by centering and lifting up people who use drugs, who are marginalized in our society. Similarly, right, it understands the interlocking struggles against inequality and oppression, being central to both health and liberation. So we are fighting inequality, we are fighting oppression, and generally a lot of folks who use drugs experience both of those. And so when we advocate for low barrier treatment, when we advocate for overdose prevention sites or supervised consumption sites, when we advocate for decriminalization, right, we're acknowledging both of those things and working towards health and liberation for all people. And as I mentioned, it affirms the wisdom, dignity, and leadership of those most impacted by these harms as the keys to transformative change. So we are not here to paternalize people or control their lives. It really is the belief of harm reduction that folks are autonomous individuals and nobody knows what they need more than themselves, right? They're able to make those decisions. They have the wisdom to know what they need, when they need it, how they need it. And as providers, folks that are supporting people who use drugs or people who engage in sex work, our job is really to be curious, to be supportive, ask what you might need, how can we help, if at all, and remind people that like they are valuable, they are worthy of love, and that they can have control over their own life and their health, and they should. So I'm going to touch a little on stigma because it is a big determining factor in whether folks actually seek support and care that they might need if they have a substance use disorder, or even if they don't, right? Even if they use substances and maybe they haven't been diagnosed, or they feel like, it's not problematic, but I just want to be safer. Like I want to make sure that I'm taking care of myself. And stigma can really be a barrier to accessing that care, as folks have talked about today. So stigma is a social process which can reinforce relations of power and control. It leads to status loss and discrimination for the people who are stigmatized. So the main thing about stigma is that there's a power dynamic involved, right? The people with the power are trying to keep the folks without the power in that position. And it's going to impact folks' ability to get what they need, to access the care that they need, to access the resources that they need. They may be disowned by friends or family or other community. It may prevent them from accessing a job that they are otherwise qualified for. And I'll click over here to the next slide because it talks a little bit more about how that plays out, right? So this is really how stigma operates, sort of like the three pillars. And it really starts as a stereotype or an idea, right? So things like the idea that people who use drugs are incapable, they're fragile, they're dangerous, they can't recover, they don't want to recover, right? They made this choice, they put themselves into this situation. So stereotypes and ideas. And it's always good to sort of think about our own stereotypes and ideas, right? Even when we do this work, we can have sort of deeply ingrained ideas surface because of the society that we live in, right? The prejudices, the beliefs, the deeply ingrained beliefs that we have because we live in a society that reinforces these stereotypes and ideas. So those ideas, like I said, they turn into beliefs or prejudices. So, people who use drugs are dangerous, and therefore that belief turns into they are scary, or they're shameful, they're less than. And eventually those prejudices and beliefs actually turn into discriminatory actions. And so those can play out in both social discrimination and structural discrimination. And so thinking about, social discrimination, NIMBYs, right? People not in my backyard. I don't want them to live next to me. I don't want a recovery center or a homeless shelter in my community. I don't want my kids dating somebody who uses drugs. And then structurally, which can really impact someone's ability to move through the world, if especially if they are in recovery, or even if they're not, right? If they're trying to access a job, and like I mentioned, like their substance use is really the only thing that society has decided will hold them back, even if they're perfectly qualified otherwise, right? So employers not hiring or supporting people who use drugs, having, very strict no drug use policies. It can play out in recovery, right? Not having the proper education or supports in place, having very strict abstinence only policies. And for some folks, right, like that is their harm reduction. They want to be in a safe and sober house because they realize that like being around other folks who use drugs might be problematic for them. And could trigger them and they might start using again. But to not make that the only option, right? Again, we want to give folks options. So to let people know that, yeah, there are options for harm reduction based recovery. You can go through this program and still use meth if you're just here to stop using opiates, right? Oh, you've had a urinalysis and it's positive for drugs, but we're not going to kick you out of the program. And a lot of programs are not that way. Health insurance, right? Or just health care. I can't tell you the number of times that participants at the program that I used to work at come back to us with horror stories from the ER, being treated like they're there just drug seeking, being denied medication for opioid use disorder, having their personal information shared in ways that don't comply with HIPAA, just like horrible things that most other people don't have to endure. But because of these ideas that are then turned into prejudicial beliefs, they are now experiencing this very real discrimination in a healthcare setting that's supposed to care for all people and provide services to all people equally. So now we're going to get into the 6 principles of harm reduction. I'm going to see, I can't make this big, so I can't, can't see if there's Q&A happening. So if people do have questions, like as we go through this, I'm happy to answer. Someone can maybe just unmute and tell me that you have a burning question. Otherwise, I'm happy to answer at the end.
Currently no questions in the Q&A, but I'll let you know if any come.
Perfect, thanks. I know it's just like a lot of stuff and we're moving through it really fast. Usually we do these foundation trainings in 2 hours. So trying to get all the content in a little bit quicker than usual. So feel free to stop me if anyone needs clarifications. So our principles of harm reduction, there are 6 of them, and we're going to go into detail with each of them. And I encourage you, as we sort of look at the definitions of each of these, think about in your own work, where you feel like maybe you're already utilizing these principles, and then maybe where you're kind of struggling or your organization is struggling. Everybody, there's always room for improvement. I think we all struggle with at least one some of the time, if not all the time. So like, it's no need to be like shameful or sad about it. Just always great to work on getting better for the sake of the folks that we serve. And so the 6 real quickly: health and dignity, participant-centered services, participant involvement, participant autonomy, sociocultural factors, and pragmatism and realism. And you'll notice as we go through them, there's a lot of overlap. They're all sort of intertwined together, which is okay, because I think they're amazing principles and really just remind us to treat people like people first. And so the first principle, health and dignity, establishes quality of individual and community life and well-being as the criteria for successful interventions and policies. And I honestly, I think the most profound thing about this principle is that it doesn't talk about cessation of drug use. as, you know, sort of being the end all be all, this goal, right? For some folks, that is their goal, and that is fantastic. And while getting there, they deserve health and dignity, right? So if their path there isn't linear, which it, you know, generally isn't any sort of path, that's okay. They still deserve health and dignity as they walk that path. And so, you know, substance use, using drugs is an action that someone does. It's not the whole of their identity. So actually thinking about the whole person, right? Okay, someone's coming to me and they want to address their substance use, but, you know, are they housed also? Are they in a situation where they're fearing for their life, like intimate partner violence, things like that. So really seeing the person as a whole being, and being curious about what other things might be needed to ensure health and dignity is achieved. Participant-centered services calls for the non-judgmental and non-coercive provision of services and resources to people who use drugs and the communities in which they live in order to assist them in reducing attendant harm. I was grateful that there was some discussion earlier today about coercion. If you can think about a time when someone, like, you know, tried to force you to do something, you know, whether it's you have to exercise, you have to stop eating sugar, you have to clean your room every day, right? Like, none of us really like to be forced to do anything. And generally, like, we're gonna say no and then like double down on it and be like, I'm just gonna eat more sugar now, or like, you know, I was thinking about exercising, but now I'm not. So really providing folks an opportunity to make choices for themselves, and not judging them for whatever choice they do or don't make, right? So really centering the person and their experiences and what they're saying that they need. And making sure that, like, we're checking our language, we're checking our body language, right? All of those things can tell someone, like, oh, I'm feeling judged right now, or stigma's coming into the room, right? You'll probably notice that I continue to say people who use drugs, or people this, or people that. So, you know, just using people first language is a huge way to start implementing and addressing some of these principles. Participant involvement ensures participants and communities impacted have a real voice in the creation of programs and policies designed to serve them. So is there a new recovery center opening? Have people who use drugs and people who are going to actually use that service been involved in the creation of it? That's a great way to do participant involvement. For syringe exchanges, a lot of them do surveys or participatory budgeting, saying like, hey, we have this chunk of money that can go towards anything. What do y'all think it should go to, right? Involving the people who are actually using the services in a very real and tangible way. Ensuring that people who use drugs, people who engage in sex work are like being advocates. They're going and lobbying to the state or to the federal government for things that are going to directly impact them, right? And not only does it center their voices and make sure that they're actually getting the services that they need, but it's so empowering to be like, I believe in you and I know you can do this and this is your life, like you should be your own advocate. So I really love participant involvement. Similarly, right, participant autonomy, y'all are probably starting to notice a theme here, but this one affirms participants themselves as the primary agents of change and seeks to empower participants to share information and support each other in strategies which meet their actual conditions of harm. So again, treating people as autonomous humans, which they are, you know, being supportive, being there, believing in folks, empowering them to know that they are totally capable of making any sort of change that they decide that they want to make, of addressing any sort of thing in their life that they're wanting to address. And then also ensuring that like they can then take that support and give it to other folks that might be like in a similar situation as them. And again, not saying, hey, bro, like I did it this way, like now you have to do it, but being like, yo, I did this thing and I'm curious how you might want to do it. Are you ready to do it? How can I help you? I'm here when you are ready. And sociocultural factors. These recognize that the realities of various social inequalities affect both people's vulnerability to and capacity for effectively dealing with potential harm, right? So I always talk about the fact that like when I was in college and I was going through my own experimental substance use stage, like I never thought about getting in trouble because I'm a white woman. Just like real talk, like I didn't have to worry about someone like eyeballing me sideways or making an assumption that I was doing something I wasn't supposed to do. And so, you know, thinking about that, similarly, like I grew up, my grandma raised me, my mom was an injection drug user. And I, you know, the fact that I had my grandma to take care of me, the fact that I was able to maintain a relationship with my mom, who is now many years, I don't even remember anymore, sober, the fact that I didn't deal with CPS, like all of those things are privileges that I have because of my sociocultural status in life, right? So folks who are people of color, who are queer, who are poor, they're not gonna have the same experiences that I had as far as their vulnerability to actually developing a substance use disorder, or their capacity for effectively dealing with it, right? If you are undocumented and you can't get health insurance, how are you going to access treatment, right? That's a sociocultural factor that's going to impact your ability to address substance use. Yeah, if you are unable to pay for food or you're unhoused, how is that going to impact your ability to reduce your use or change your use patterns or enter into treatment? I can tell you from running a program for folks who do go into treatment who remain unhoused and very low income, it's really hard for them to stay sober, especially if they have nowhere to go after. They're going to go back to the same folks in the same situation. And repeating that cycle, like wears people down, right? They start to feel like there's something wrong with them, like they're failing, and they're not. Like every time they try is a success. But some of these bigger issues, right, these structural things that are impacting their ability to get into housing or to get a job, is also impacting their ability to deal with substance use. And finally, harm reduction is pragmatic and realistic. So it does not attempt to minimize or ignore the real and tragic harm and danger associated with licit and illicit drug use or other risk behaviors. So similar to this idea that like abstinence is in opposition to harm reduction, I think a lot of folks think harm reductions are like, woohoo, drugs for everyone. And while I do think that drugs can be fun and there's like a time and place to do them, I definitely don't ignore the fact that they can cause harm to folks, that substance use disorder can impact people's lives. It can impact the lives of the people around them. Again, I have seen that happen. I grew up without seeing my mom on a regular basis, and I have trauma from that, right? I feel fortunate that I still have a connection with her, but I acknowledge the trauma that caused me, not seeing her come and go and have that sort of chaos in her life. So definitely not ignoring that overdose is a risk, Hep C is a risk, family issues, incarceration, all of these things are very real. And also trying to create plans with the people who we're working with that are also realistic, right? If someone is in like very chaotic substance use and they're like, I'm just gonna quit like right now, I'm ready, and like all of these other things aren't being addressed, that might not be realistic, right? It's a great thing to think about, but again, getting curious, asking like, you know, okay, what are the steps to get there? Do you think, you know, that this goal that you have is realistic in 6 months, in a year, in a week, you know, really trying to understand what is pragmatic and realistic for that person. And then also thinking about it in relation to the actual potential harm and danger that substance use or sex work could cause. And so these are some harm reduction services, excuse me, which again were, some of them were mentioned earlier. And so you'll see sort of, again, the buffet of options. And for folks who, like, I often talk, I'm a co-founder of my local harm reduction coalition. And we have really tried to take harm reduction out of the context of just substance use, because sometimes it's easier for folks to digest things if it's not so focused around drugs, because there are a lot of like feelings and beliefs wrapped up into this, right? The stigma is real. And so I often talk about harm reduction, or the coalition talks about harm reduction in relation to things like helmets and seatbelts and sunscreen, right? Not to diminish harm reduction roots, because it is very specifically like from a period in time and specific people, right? Who weren't getting the care they needed when the HIV/AIDS epidemic was happening. And so definitely not to diminish those roots. But sometimes you can get to folks a little bit easier if you can, especially if they have like no experience with substance use or people around them like using, or maybe they do, and like that's why they're so avoidant, right? They really don't want to talk about it because they have been impacted in such a negative way. So you can always talk about just everyday ways that we reduce harm. But in relation to substance use or sex work, these are some really great services. So syringe access and disposal, right? Syringe exchange programs, having syringe disposal kiosks throughout your community or in places where substance use happens, you know, around parks where syringes might be getting discarded. Safer drug use supplies, so having fentanyl test strips to test for fentanyl so that folks don't inadvertently overdose, especially if fentanyl is now in methamphetamines and other things that wouldn't actually cause an opioid overdose. So being sure that folks know what they're getting. Things like having your own straw or other materials like cookers and cottons, all of those things, if shared, can share bloodborne illnesses. Overdose prevention, which was talked a lot about today. So having Narcan or the intramuscular naloxone. Safer sex materials, right? Oftentimes sex and drugs go hand in hand. So making sure that folks who are using and or engaging in sex work have those things: condom, lube, dental dam, all those items. Medication for opioid use disorder, safer consumption services, overdose prevention sites, supervised consumption sites. They have lots of names, but basically a sterile, safe place where folks can come and use their pre-obtained drugs under supervision of a medical professional and get connected to other services that they might need. Drop-in centers are like a magical realm of love and acceptance. Again, as someone who came from working in a syringe exchange and drop-in center, it's just like a really awesome opportunity for folks to come as they are, to come as who they are and just be, and not have to worry about getting hassled by police or community members who don't want them in the community, and connect with other folks who might be experiencing similar things, and connect with people who want to help and support them and get them the things that they need. Housing first, right? Housing is like so very important, and like without means testing and stipulations, like just give people basic human rights, get them a roof over their head, and see the magic that can happen, right? When you have that base level of stability and like foundation and safety, like what amazing things can be achieved when just like the basic needs are met. So definitely a big proponent of housing first. And the referrals. Referrals happen through safe consumption services, drop-ins at syringe exchanges. It can, if you're a healthcare provider, you can refer out to those other services, right? If you know that your client is not ready to stop using drugs, but they want to reduce their harm, refer them over to your syringe exchange program. And there is actually a syringe exchange program in Mono County. I don't believe that it has been operating recently, but I am working with the folks over there at Behavioral Health to hopefully support them into getting that going again. So I'm really excited. Hopefully see that happen for your community. And so here, we're going to chat a little bit about harm reduction in rural communities, because y'all are rural over there in Mono and Inyo, just like I am here in Humboldt. And like we already talked about, harm reduction isn't a one size fits all, right? So like the services that are created are going to be most effective when they're tailored to the unique needs of your community and the participants, especially the participants accessing the services. But there are definitely some things to keep in mind when you're trying to create harm reduction programs, syringe exchange programs in rural communities. And these are actually things that are relevant to anybody trying to start a program. But I think like especially so in rural communities, because often rural places are small, right? So like this idea that everybody knows everybody. And you don't always want people knowing all your business. So that in itself sort of creates a challenge. And so like keeping that in mind when looking at these different things. So before like things even get going, it's real good to get a sort of feel of community need and readiness, right? Like while I truly believe that every community should have harm reduction services and syringe exchange, like it can be really hard battling basically with your other community members trying to get this thing to happen. And again, I see it happen here, and it has oftentimes been an uphill battle, but there's been enough like need and support that it has still been able to happen. But so just like, doing needs assessments, getting out and doing outreach and talking to people, hosting town hall style meetings, like figuring out who needs the services. How does your broader community feel about harm reduction? How do they feel about a new program? Is it just like everybody, all the people in power, all the neighbors are like, hell no, we don't want this? Or is it just like a couple of people who are loud, but maybe don't actually make all of the decisions and could be talked to and sort of convinced that this is actually going to be a benefit to the whole community? So similarly, right, local opposition, that can be a very real thing. How's it going to be addressed? And who is actually at risk from that opposition? In Chico, we were seeing, their program was seeing participants actually getting physically assaulted. They were having like protests out while they were trying to give services. So that kind of opposition is actually very harmful for folks who are already feeling uneasy maybe about accessing services, or, already feeling a lot of stigma, and then they're like being yelled at and physically assaulted. So just sort of power mapping is a great way to figure out, who is opposed, who is your support, who is this going to impact, and how can we sort of mitigate some of the issues. And so similarly, right, you've determined opposition and might look like. You're going to also want to figure out potential allied service providers and supporters, right? You're going to want folks who can support you. You're going to want places to refer your clients, and you definitely are going to want a nice big pool of volunteers and community support. Sorry, I was looking at something there. Location, right? Again, if you're in a rural area, you might be geographically spread out. And that's under accessibility. Accessibility and location are pretty similar, right? But thinking in relation to rural places. So you want your participants to feel safe and comfortable. If your behavioral health is where you're doing your work and it's right next to the police station, might not be the best location, right? Folks might feel a little uneasy coming to a clinic there. They might feel uneasy coming to a clinic, period, right? Sometimes like larger institutions or like government-based or state-based programs. folks have not had great experiences with that. So thinking about where your building can be so that people feel comfortable. There's confidentiality, there's anonymity. It's not just like the main building in the middle of town so everybody can see you coming to do your business. And it is important to take the broader community needs into consideration. I keep talking about my own experience because it's just like, it's very real and it's happening constantly. Even though I'm now with National Harm Reduction Coalition, I still sit on the board for my former program. But the building is in a mixed zone residential business, but it does have neighbors and it's down the street from a library. And the community is not happy about that. And the building was given to us by a healthcare provider who used to do healthcare services in there. And so it's just one of those things, like, it's caused a lot of grief, and had there been a better option for a different location, I'm sure the org would have taken that. And so, like I mentioned, accessibility, right? If you're geographically large, maybe just having a drop-in center isn't great. Maybe you need to do some outreach and have mobile so that you can reach people who are farther away, or you might need to have, more hours so that people have time to get to you. And quite literally, right, meeting people where they're at, not only where they are in their life, but like physically, can you get the services to the folks that need it? And like I mentioned, confidentiality, right? Small communities, everyone knows everyone. How are you going to make sure your participants feel safe, confiding in you, giving you personal information, making sure that they're not, being blasted all over social media, like, oh, I saw so-and-so going to the syringe exchange yesterday. So really important things to think about when implementing these services in rural communities. And then down here at the bottom, there's a great toolkit on our website down there, harmreduction.org, issues establishing rural programs. You can see some of this information, and I think printed out in a handy dandy PDF. So to end, practicing harm reduction is when we add the principles and the tools and services, right? So you can do syringe exchange and medication for opioid use disorder and drop-ins, but if you're treating people like crap when they come through the door, you're not really practicing harm reduction. So making sure that you're implementing those principles with those tools and services so that you can actually provide compassionate, people-centered harm reduction services. And these are just some opportunities for reflection, things to think about as we get into some other Q&A stuff.
So feel free to put any questions or comments in the Q&A and we can address them. Or raise your hand if you would like to speak. Jessica, are you able to stay on for the discussion portion?
Yeah, yep, absolutely.
Cool, thank you. All right. So not seeing any questions in the Q&A. Maybe we'll just take a little break and close out with our open discussion forum. Thank you, Jessica, for presenting.
Thank you.
So we have about 6 minutes until we get going with the discussion portion. If panelists, feel free to stay on if you're able to be a part of the discussion. I believe Arlene will be running this and we'll get started around 4. Thank you so much. All right, I think we're gonna get going with the open discussion portion. Invite the panelists to come back if you can. Arlene, are you still able to coordinate this portion?
Oh, I was talking to you and I was muted. Sorry.
No worries.
Sounds good. So I think kind of the whole point was just coming back as a community and really talk about action steps. Where do we go from here? We most of us work for either Inyo or in Mono County, and so today we heard a little bit about what's happening, services, but really to just take some action items to say what we would like to see, or maybe even challenges to what we're facing, but really kind of identify some of those gaps in services, needs that we think we need to start addressing. I think is a great talking point to be able to do that after we've been given so much great information. And everyone, I mean, this has been a great day, full of so much good information. But yeah, I think that's kind of what we wanted to do and just go from there. So I will just open it up.
Are you opening it up to us, or are you opening it up to the audience?
Great question, Robert.
Everybody?
Not
All
just
above?
panelists, to our community.
I didn't get to listen to every word, but I did get to listen into quite a bit. And I just really want to appreciate everyone. The information is extraordinarily helpful. And the personal experiences being shared, aside from courageous, are also extraordinarily helpful. Whoa, end of the day, not be able to talk. So thank you. I can say for Mono County, we have some staff changes, and because we have one person dedicated part of the time to our efforts with all parts of our harm reduction model and syringe exchange and Narcan distribution and all those things, we got backed up and aren't really active at the moment, although right at the beginning of starting that. So we'll be back in business pretty soon. But I think one of the things I would love some help with is how to do this in the land of COVID, especially with county employees who, especially if we're locked down again. And not that any one of you are going to have any of these answers, but, or if we have travel restrictions and all the things that happen, is like, what's the best way to keep this going and keep everyone safe in the county way? Does that make sense?
I can maybe give you some feedback on that. There's a lot of great resources that have been put out recently by varying organizations around harm reduction during COVID-19 and how to keep providing services. A lot of the programs in California that are connected through KSEP, which is the California Syringe Exchange Program Coalition, have sort of highlighted the ways that they kept going. And, I think it depends on your sort of shelter in place, like if you get back to shelter in place, and like what your orders say as far as what is essential, but your public health, right? Harm reduction is public health. So y'all are essential. So those services can continue. Outreach is a great way because it's out in the open. I know y'all get snow, so that's like a different level of stuff that like I don't experience here, although it gets really cold, just not so cold that it snows. But yeah, there's also been a lot of stuff recently on like winterization of programs through COVID-19. So
okay, I'll look it up. Thank you. That's very helpful. We hope we get snow. Right now we're in a really bad drought. So
One of the
And,
things. Oh,
I was just gonna say, I think for us, it's we're a fixed site and we're also mobile locations, so we do a lot of deliveries, and that's really coincides with and our patients have been considered essential from the get-go. So we've been very lucky because I know the clinic had to implement a few different policies and procedures to keep everyone safe with COVID, and a lot of like normal appointments like physicals and other things had actually been delayed and like rescheduled when COVID first happened. But from that time frame, the thinking is that our patients have been very essential, need and have been offered that if they want to do telehealth, great. If they want to come in, feel like they need to come in, that they have that option to come in and do that, and have kind of been set aside as termed essential. But I guess for harm reduction, it's been a lot more deliveries or just meeting up. But we do home delivery, so and we can do it safely. Like there's safe ways to get it done.
yeah,
Or
sure.
do the trainings, even like with other organizations, to be able to do a Zoom naloxone training and then just go and give them the opioid overdose reversal kits. So you're not actually in the meeting with them, but just doing it through Zoom. So
Okay. I think one of my concerns too is that it's around, I was going to say it's everywhere. I don't know if that's true, but there's a lot of COVID around right now. And if staff get sick or get quarantined, then how we, with such a small, we have a small staff, how we then back up. And I mean, we figure things out, of course, that's what you do in Mono County. I'm just curious if other people have ideas about that.
well, I was going to say, I mean, right now within Mono County, the biggest public health intervention we're doing is COVID testing and soon immunizations. And I think that's a hub right now. We see so many community members. We're all in full PPE, so we're protecting ourselves. And I think it's a good opportunity. We're seeing people, they're coming out and they're seeking services that we can almost like provide a menu of, do you need any of these on this menu? So they don't have to say it out loud. It can just be like, hey, we have this if you need it. So it's just like a stop and go because it's every day almost that we have testing. So it's a really good opportunity.
So let's talk offline about with Lisanna and Deborah and figure out what our plan is.
Yeah, sounds good.
I was going to add, I think that another important thing to do during this time, as far as like harm reduction efforts go, is like, or anything, is to take good care of yourself too, as well, because I recently was doing some secondary trauma training, like, for staff and for providers. And I realized at the moment where my light bulb came on, I was suffering from it, and I was bringing it home, and going to situations on the reservation where there's overdose and Narcan's out and everybody's heightened in their emotions, and just kind of had to ground myself and practice that every single day, keep that grounding going, and getting rid of the work part, and coming home and being more healthy. And I think that it means a lot for as it pertains to your subjective well-being, which is your happiness. So I'm focusing on that right now. And I've found that I can be more effective and kind of spread myself a little bit more thin because we're all going through this together, regardless of what position in life you are at. But yeah, I just wanted to share that with you.
Thank you.
I think some of the flexibility that's happened around methadone has been super helpful. Being able to get take homes, I think for clients has been, helpful at every level. I wish it was that way all the time, actually, because, it's for some clients going to the clinic is a diversion. Like they just get kind of distracted and caught up in other stuff. And so being able to not have to go lots of times is good in general, but especially during COVID. So that has been, I think, there's been a lot of I think we've learned some good lessons that we could take from this time for many, many things. And so, hopefully we keep them, including just making telehealth easier, allowing all those kinds of ways for it to improve access, I think is important in all communities, in particular rural communities. So let's hope we preserve those lessons learned from this pandemic.
I also just wanted to add that there's a program called Next Distro. I'm not sure if you're familiar with them, but they do mail. They just send people stuff in the mail, naloxone, syringes, supplies. So you were asking about well, what if your staff are at home quarantined,
Yeah.
Then maybe you just give people stuff, envelopes to stuff and boxes to stuff from their home, and then maybe you have somebody do post office runs periodically or something. I don't know exactly.
Well, that's a good
but I
idea.
imagine you're probably pretty spread out, right? And so
Quite, yeah.
I think in addition to what Arlene said about deliveries, Jessica was talking about some of the tools, if you have a mobile van they've been calling it sort of taco truck style, where you're up in a window and you're handing people pre-packaged things that are in a brown lunch bag, so that to just reduce the face time. I mean, people have been, I think, very creative with their strategies. So yeah, just telehealth, obviously, but mail delivery also.
That's a good idea.
And there, there are some, there are HIV tests that can be self-administered, sending people an HIV test in the mail, things like that. I mean, not all of the, Hep C isn't FDA approved for that yet, but we're seeing really major increases in complications of undiagnosed gonorrhea that we've actually haven't seen in many years, where you can die actually from disseminated gonorrhea infection, which I didn't even know until a couple of weeks ago. There are kits for self-collected STD testing, mail, I don't support Amazon as a company, but people are used to that concept of just getting, if they're housed, just kind of things coming to the door. And anyway, just a thought.
So I'm hearing mobile assessments and contactless delivery. That's kind of what I'm getting. Because I don't see why, I'm thinking about this. I'm like, well, how about maybe working with the people who are doing COVID testing and have them pass out a box with each person, because we live in a rural area. So there's an upside to, the rural, I guess, how to get the services out there, I guess the greater good on that one. I'm thinking from a more utilitarianistic point of view. So, just being innovative, and these are unprecedented times. So I think it's going to take some unprecedented, well-informed, practices mixed with community, understanding and community knowledge, and finding out what's really happening on the ground and seeing what is possible. And as far as people that don't want to get on Zoom, or they don't want to push the button on Zoom and get on their phone, even though they got it, it's easier than Messenger. But if they don't want to do that, then we have to, find new ways and get out there. And that's what I'm thinking. Just want to share that.
Arlene, I have a question for you. You mentioned that you have people that can deliver the Narcan at kind of any time, or how does that work for you guys in y'all?
So we have providers that will administer Narcan. We have overdose kits in the emergency department as well, in English and in Spanish. And then also though, people that if they need Narcan in the middle of the night, they can get Narcan. And it's me, being able to do that, but I will never, if someone requests naloxone, they're not trying to bug me. They're doing it for a reason. And, and I've taken that responsibility on, is that I'll leave my house and, go deliver it whenever I need to deliver it. Just because I know there's a big reason of why they're asking for it in the middle of the night. And like I said, it's not because they want to be a pain in the ass at all. It's because they need it. Something happened, or, they just got something in that they want to use right away. So there's big reasons why people need it. And, and I don't have a problem doing that. Because like I said, this, work isn't for everyone, and everyone won't agree with, the fact that I'm more accessible and available for people. And I am not because I don't want my own time or boundaries or any of that, because I do create that space for myself, but I also I choose to work in this field, and I choose to do this work. And that's kind of part of the job for me, is being able to do that. So that's how that part will work. And actually, I know Tony will go take Narcan too. He's offered. I've had someone one time, and they're like, "Oh, wait, I need to go. It needs to go down to Lone Pine." And then they're like, "Oh, I'm coming up right now." And then they're like, "Oh, I'm going over here by Mammoth." And they're like, "I'm coming back." And I was like, "Okay, well, where are you going to be?" And then Tony was like, I'll go take it. Whatever you need, I'll take it." And I was like, "Oh, cool." And then they ended up coming right to Bishop, so it was fine. And I was able to get it over there. But I know Tony will do that same work too. So.
That is something I kind of envision within Lono County too, is having kind of community advocates within our little towns, because we're so far apart. It would be nice if we had kind of advocates that could have a stockpile of Narcan that they could distribute at any time, or within that community, because so then it's getting to them. And I know EMS is also on board with distributing that, and but I think, as we've talked about, connections is big, and having that community advocate would be great in each community.
Yeah, I agree with that. I think it's very important to have those community champions, because honestly, like everything we're talking about right now, without that bridge to the community who's out there, engaging in substance use, without that, you're not going to reach them, period. Like, they're not going to hear about services. They're not going to want to go to any services. They're not going to trust anybody. I know, because I'm one. And those are my people, and I'm with them all the time. So there was a time when Arlene and I could drive around on the res, literally driving around, passing it out to people walk in, and people in the middle of, drug deals and things like that. And we're like, "Hey, heard of Narcan? Hop in," before pre-COVID. But so yeah, I think that getting, raising up that little army, to do their thing, because they're out there. They just need to be accessed and encouraged and loved and brought to the table, and because there's some very valuable assets out there that I've recently identified, and I'm trying to bring them in and welcome them, and hey, this is what it is. For me, it's, social workers are overworked and underpaid, and burnout's quick, and I don't want to be burned out, and I'm just going to continue to do what I love to do, and that's watch people grow and change and be healthy and become champions, the people who will do the work that nobody else wants to do and love it. So yeah, just want to add to that.
So I don't know if anyone has anything else they want to discuss or further thoughts they want to elaborate on. We could probably wrap up if nobody has anything else that they want to ask a question about or make a comment on. I would just say that you know, it's pretty amazing to see everything that's happening and to be a part of it, and you know, humbled that you know, we can do this work that we do. And you know, I always say you know, I don't think there's ever a time that I don't honor and recognize the people that we've actually have lost. And I say that because, you know, this work is always a sense of urgency for me, to get the Narcan out there, to get the services out there, to be available when people show up. And, you know, for me, it doesn't matter, you know, if people aren't ready, it's not my job to decide any of that. I just make it my job to make sure that the services are available when they want them. The resources are out there, that they are cared about, that they know where services are, that they know that there's Narcan, that they know how to use it. You know, those fundamental things are available, and that they, you know that they're cared about and loved no matter what. So, you know, sometimes it's a hard job to be a recovery support navigator. And you know, you're cheering for people in their recovery and different things. And sometimes they make a transition, and then they turn around and they need, you know, clean using supplies. And that's okay too. We try to be very upfront and let them know that that's totally okay. We're here to just keep you safe. We're here to just love you. And, you know, people stay engaged, and then they, you know, kind of are always intersecting. And so I just know that, you know, there's people that have been given up on in our community a time or two. And, you know, what's kept them going is the love that somebody has shown them. And it's been the hope that somebody has shown them. And it's been someone who's just encouraged them and never thought like, I'm just going to throw you away or turn my back on you. And that's what's kind of kept them coming back for services, or, you know, staying engaged, and that they didn't actually give up on themselves. Because you know, people don't go to rehab and get it right the first time, if that's their goal. You know, I mean, I see people come in and out, and like I said, they intersect, you know, between all of it. So it's not my job to ever decide who gets what for services, but it's always my job to provide them, and then, you know, always give that compassionate care. So I want to thank everybody for coming. And we have a great community. And, you know, I know Tony mentioned it earlier, but that hope, you know, things are definitely changing. Like I said, in the fall of 2018, you know, none of this was being discussed prior to October. November, there was the first meeting that started addressing that, and kind of broke the silence. And, you know, people were saying, what are we doing here? And what's happening with the opioid stuff? And why can't I get into rehab? And I think, you know, for me, one of the biggest considerations is the fact that we have a Medi-Cal system that has locked us out of rehabs. And to me, that's the biggest deficit, because we have people that want to go to rehab. And if they have Medi-Cal, it's a struggle to help find them treatment. And so somehow, some way, the California system needs to change in the fact that we need in Inyo County, and that, you know, and I'm sure Mono County might be the same way. We need the ability to place people in rehab when they want to go. We need to be able to get them to detox when they want to detox. We need to be able to get and access sober living homes You know, we always talk about wanting to have our own rehab here. We talk about wanting to have our own sober living homes. For me, that's kind of the big picture and ways to move, because you know, it's hard to watch somebody not be able to get into rehab when they want to get there, and we miss opportunities, and a week goes by and, you know, they don't want to go to rehab next week, and then another week goes by and they want to go to rehab, you know. And so to not have that ability to take people and access, you know, inpatient, you know, really does hurt people that need to go. So I guess for me, as like next steps is, you know, how do we address that, to not only just get our own resources here, but to be able to change the way Medi-Cal operates, and why we're locked out of it as a county.
All right, thank you, Arlene. And I think, yeah, we'll close out for the day. Is Chelsea able to join us again for the closing ceremony or not?
No, you know what? I didn't invite Chelsea back. She wasn't feeling good at all. So.
Oh, okay, yeah, that's right. No worries, yeah. All right, well, thank you all for attending, and thank you all to the presenters, panelists, all of everyone. I really appreciate it. I'm glad this came together despite the chaos going on around us, and that we're giving more attention than COVID, because COVID's been annoying. We need to focus on some other public health crises that are still going on and haven't gone away. So I appreciate your time, and yeah, let's keep the conversation going. And yeah, hope you guys have a good rest of your afternoon.
Thank you. Thank you, Jacinda, for all your help in organizing the event and keeping things going in the background. So just wanted to give you a big shout out for all of that. So.
And thank you, Arlene, for helping me keep it going too.
Bye, everyone.
Bye.
Thank you.